I'm audible, but
Yeah,
yeah,
sir. Audible, sir.
okay. And good evening, Dr. Niharika.
Evening.
Uh,
Good evening, sir.
so my topic is first to start with about antibiotic stewardship program. What can be asked in the exam on this topic, and then we will talk about two long cases. Um, so if you have any questions or queries in between, just post it in the chat box or just interrupt and ask. That's fine. All right. So it's already time to start. So antibiotic stewardship program, or we call it as ASP in ICU. It is a evolving question that is usually asked in exam at different stages. It can be asked in a theory exam, which you guys have already passed, which is good. It can also be part of Viva or even at the bedside clinical case. So it can be formed in different ways, but what is expected from a candidate is to know few aspects of the antibiotic stewardship program. First of all, what does it mean? What are the key parts or components of the antibiotic stewardship program? As a ICU specialist, how will you develop such a program in your ICU or in the hospital? And of course, they can ask you about the benefits. What are the important aspects that it can bring with itself to the unit or to the hospital? We'll be talking about definition of antimicrobial stewardship program and why it matters for ICU. Then we'll talk about the core elements, which would include how it is structured and what is the governance principle of it. What should be the workflow of a antibiotic stewardship program and how to build it. And then we'll talk about the benefits, as I said. Now, definition is you don't have to write or remember it word by word, but the concept should be mentioned if it is asked in the exam. So it is a coordinated set of intervention that improves and measures the appropriate use of antibiotics. So simple as it is. It helps to optimize the drug selection, dose, route, and duration to improve the outcomes and limit resistance in the ICU or in the hospital. In the ICU, antibiotic stewardship program must balance two competing risks. So ICU being an acute care facility, there is urgency to many things, and it becomes tricky to push for antibiotic stewardship program or to advocate for it because of some competing interest that is inherent to the ICU practice. So the question in the exam can be, what are the obstacles to start an antibiotic stewardship program that you expect to face? Sometimes there is a risk of undertreatment because if you um, follow antibiotic stewardship program, the concept sometimes other physicians have the concept that it can delay an effective antibiotic therapy in a sepsis. It will not provide adequate empiric cover if you go by the stewardship program guideline. And also it can lead to missed source control or diagnostic or delayed diagnostics. But on the other side, there is also risk of unnecessary broad spectrum exposure if you don't use it. There will be irrational use of antibiotic leading to toxicity, leading to superadded infections such as C. difficile infection if your choice is irrational, and also you can select out MDR organism. Plus, Even if in patients where antibiotic is not required, they keep on getting it if there is no stewardship program in the ICU. So people think in different way. There may be a risk associated with it is under treatment risk or not adequately treated. At the same time, if you don't use it, there is a risk of over treatment. Now, why ICU is a perfect place for using a antibiotic stewardship program? Why we need it in the ICU? The reason being, the use of frequent empiric broad spectrum therapy is common in ICU. Now, you would have faced that if you are running a surgical ICU, you'll have your surgical colleague putting patient in the ICU post cholecystectomy, post hernia repair on peptides or on meropenem. So there is a high burden of this concept that if you use broad spectrum antibiotic, empiric antibiotic, then there is less chances of infection. So which is a real thought that governs 90% of the surgeon. So antibiotic stewardship can help in negating that type of thought or that type of practice. Second is, because there is high colonization pressure and invasive device use in the ICU, there is always a chance of selecting out or always a chance of MDR risk in these patients, in ICU patients. And if we start using irrational antibiotic, the chances of getting these organisms or these infection are more common. So that has to be controlled so that you have things in your place so that if the patient has a resistant bug in their blood or infection, you can treat them. If you start the patient with meropenem to start with without an infection, it will select out organisms which are resistant to meropenem, and then after day 5, day 6, you will not have any other antibiotic in your hand to treat the patient. So that part is well covered if there is a antibiotic stewardship program in the ICU. The third thing is, not a single size fits to everyone, because ICU patients are very different to each other. They have other things associated with them. Any disease process or any sort of support that they get can alter the pharmacokinetics of medication and antibiotics. So that part of alteration in dosing, route, or selection can be well done if it is done through the antibiotic stewardship program with the team, because each prescription goes through a scrutiny among different people like a pharmacist, a ID physician, intensivist. All these are strata of scrutiny, and after that whatever comes out is very uh, evidence-based dosing selection of antibiotic rather than irrational use of it. Also, few of the conditions where you have a diagnostic dilemma, patient comes with a non-infective fever, they are negative with culture, but still they are on antibiotic, which can further complicate the disease course. So those things can be minimized if there is a antibiotic stewardship program in the ICU. Now the question arises, what are the components of it, of an antibiotic stewardship program? This is an important part for um, like a Viva question. They can ask you what are the components of antibiotic stewardship program, how will you set it up? So first of all, component include you need to have a clear leadership which would provide you the resources and visible support. Then you need to have accountability to that. So who is the lead of that program? Who will drive that? Usually the ICU consultant or the ICU director or the ID physician. So this is the second component of the ASP. The third one is to involve the pharmacy or pharmacist experience or pharmacology. That has to be there, because as doctor you cannot be on top of everything. You need a pharmacist to calculate the dose, calculate the route, and formulation, etc. So third component is a pharmacy involvement. Then fourth, once you set up the team, the top three, once you set up that, then you go to the next stage is the function or what you call the action part. So you need to form policies and intervention, like the antibiotic stewardship program has to be following a particular policy or intervention, like written guideline about it. Once that is done, you implement the antibiotic stewardship program and you then track how things are. There's no point putting a guideline and nobody is using it. All right. So you need to have a look whether that guideline is being used by people or not. So that is called as tracking. That every day somebody has to take a note that how much antibiotics are prescribed as per the guideline for that institution. After a period of time, suppose you started the antibiotic stewardship program in January, you monitor for 6 months, in May, June, you report it. Like out of 100 cases or 500 cases, antibiotic were rationally used in 60% cases, 40% cases were used where there is no indication of antibiotic or inappropriately, and that can be then presented as a finding to the hospital board and hospital doctors, so that they are aware of which way that is going. Okay, and that data can be fed back to the common uh, data, whether it is a common ICU pool data, like hundreds of ICU maintaining their antibiotic stewardship program and reporting to that data to a central server or something, so that you know where you stand, so that you know that your meropenem use is maximum among 100 ICU similar to you, or your polymyxin B uses minimum in the whole state. So you can compare yourself where you stand. So that's the reporting. And from that you look for education. What are the points you have, you gained with the change in antibiotic prescribing, whether there is an improved outcome, whether there is cost benefit, whether there is less ICU stay, and all those things can be analyzed. So it gives a good opportunity for education and also research. So these are the components you need to remember. First of all, the leadership or the personnel. Then you set up the once the top three are set up, then you have a plan of action, which includes action, tracking, and reporting, and education and research. So basically 7 component to that. Now, next question they can ask you, what are the specific stewardship intervention that is there in your ICU, or you think it should be there in the ICU? Unknowingly, there are many things in the ICU that falls under the antibiotic stewardship program. You follow a particular sepsis guideline or pathway, which is again a part of the antibiotic stewardship program. Even you send cultures before starting antibiotic. That is a recommendation from the antibiotic stewardship program. So that is a part of that. You dose patient based on their PKPD and also based on their other equipments that they are currently using, such as ECMO or CRRT. Again, that also falls in the antibiotic stewardship program. The consideration of stopping or reviewing the use of antibiotic 48 to 72 hours, it is an important part. We call it as a de-escalation of the therapy. That is a part of the antibiotic stewardship program. Avoiding prolonged prophylaxis is an important part. That is one of the recommendation usually from the antibiotic stewardship program. Suppose you work in a cardiothoracic surgery unit where the surgeons wants the antibiotic for 3 days or 5 days. It's not required. So universal guideline is less than 24 hours or 3 doses post surgery. So your recommendation from the program should be as per the standard guideline. That's what it need to be used. Use a particular biomarker. Suppose you are using CRP or some sort of other sepsis biomarker like a procalcitonin. Again, this can be incorporated to your recommendation from the antibiotic stewardship program. And also recommending or trying to make a daily review of rounds as a corroborative or as a combined rounds with the pharmacist, with the intensivist and ID physician at least once every week or twice every week is an important part of this antibiotic stewardship program, but because that gives us opportunity for current evidence that can be discussed during the round to see whether we are compliant with the guideline or not, and interim data analysis. They can come up with last 3 weeks or 4 weeks data or last 7 weeks data to see what is the trend of different infection, what is the trend of use of particular antibiotics. So daily, not daily, even twice weekly is an important twice weekly round with other specialty is very important in antibiotics stewardship program. So usual pathway for starting an antibiotic as per the ideal antibiotic stewardship program is start the antibiotic usually according to the sepsis guideline within 1 hour. Try to send the cultures before that if possible. Review the use of antibiotic in 48 to 72 hours for adequacy and de-escalation. Based on that, you de-escalate or modify your antibiotics. So this is the usual trend that is recommended in the antibiotic stewardship program. No rocket science, just the way you present in the exam that is important. Now, next question, how will you develop it? Okay. So there are 6 practical steps that has to be followed while developing a antibiotics stewardship program. This is the most important slide in this presentation. First is baseline assessment. So you first assess what is your current antibiotic use or treatment. We call it as DOT. Then resistance pattern in your ICU and look for specific things like whether your C. diff infection is high or gram-positive sepsis is high or something else is high, and look at a prescribing pattern in your ICU. So this is the baseline you assess. Okay. Now set goals and scope. Don't say I will do everything at a time. So take 3 or 4 things that you want to focus on, such as sepsis or ventilator associated pneumonia or intra-abdominal infection or perioperative prophylaxis. Take 3 or 4 things and see how you are doing with it, whether you are complying with the usual guideline or universal guideline or not. Then find out problem area in that and build your team. As I said, the team will have a ICU lead, a antimicrobial a pharmacist, a nursing, and you need someone to collect the data. And nowadays IT is an important part who can manage the IT or manage the data management in terms of doing Excel file and presentation, etc. Then you, based on this group's input, modify some standard guideline or put your own guideline forward, which is in accordance with the current practice. Okay, which should include disease specific guideline. For example, for intra-abdominal sepsis, what is the first choice in your setting? This is my first antibiotic. On day 2, day 3, I will assess this and then de-escalate or something. And then detail of the set, like if you're using vancomycin, how are you using, what is the dose, whether you are using an infusion or intermittent thing, all these things. If your unit has a therapeutic drug monitoring system, then that's fine. When to do and how to do, what time is the collection of blood for that drug level. Okay, so all these things has to be predefined in your guideline. Then implement the guideline and see things, how monitor things and take feedback from all the possible resources or sources. And then finally, as I said, maintain the data, analyze the data, present the data, find the learning points from them, and then try to implement that in your next session. Also look for what research things that you can add. So these are the 6 steps that you have to talk about how to set up an antibiotic stewardship program in the ICU. A little bit of staffing, what you do. So you need an intensivist, you need a microbiologist, you need infectious disease if they are different people, you need nursing, staff, you need data collection person, and also approval from the hospital executive. So all of them are important component of it. We talked about that. Now tracking, how do tracking? So there are different type of tracking you do with your protocol that you have set up for the antibiotics stewardship program. Process numbers, you have to see how many percentage adhered with the guideline or not, whether they were timely review done or not, what is your de-escalation rate, whether appropriate cultures are taken and your antibiotic is modified based on your cultures or not. Then first of all, this is the process variable that you look for. Then you look for antibiotic, what type of antibiotic, duration of treatment of the antibiotic, then whether you have converted the IV antibiotic to the oral antibiotic when it is appropriate or not. So these are the metrics you look for antibiotic use. The third one is the outcome measures that you look for. What is your rate of opportunistic or superadded infection? That is C. difficile, resistance, mortality, etc. Just give me 1 second. I'm getting a call from the hospital. Um, just 1 second. Come out. So the third is the outcome variable that you look for is what is your superadded infection rate, what is your resistant trend, resistance trend, what is the mortality associated with this, and all those things. So you need to measure all these things as a part of your antibiotic stewardship program. Benefits, this is again what is the benefit of antibiotic stewardship program. When it is asked, you will say it is multifaceted benefit. Patient, ICU team, and hospital. Patient benefits are earlier targeted therapy, fewer adverse drug reaction, lower rate of superadded infection, lower selection of MDR. ICU team, it improves the culture of shared decision making, reduce prescribing variation and errors, better diagnostic discipline, and education and research embedded with it. Hospital system benefit is reduced antibiotic spend. The cost of treatment can be reduced significantly. Improved antimicrobial or antibiogram. You get better accreditation support if you are aligning with the guidelines, and you can report your data in the national and international levels. So these are the benefits of ASP. So if somebody asks you as a general blanket question, what do you know by or what do you mean by antibiotic stewardship program? At least these four things has to be there in your answer. First of all, definition, make a smaller definition like it is a coordinated intervention to optimize antibiotic selection, dose, route, and duration. It includes leadership, accountability, pharmacy expertise. Then we put an action plan, then we track it, report it, and look for educational point and modify the protocol. The ICU actions that is involved in antibiotic stewardship program includes rapid start of antibiotic or timely start of antibiotic, review in 48 to 72 hours for de-escalation, go for short effective duration, dosing, safe therapeutic dosing, and also advocate for biomarkers for early diagnosis of sepsis. And also it helps in building baseline data, and then it can be audited, and the unit can be compared with the standard. So this is the important part of antibiotic stewardship program. We talked about the benefits already. All right. So basically, this is expect this question as a quality question in the Viva, or at least at the bedside. Expect this may be asked in the exam. I'm happy to answer if there are any question. Otherwise, we'll go to the long case discussion. All right. Let me open the long case. All right. Is my slides are visible?
Yes, sir.
All right. So long case. Um, so first of all, I'll discuss about the usual pattern of long case, and then we can go to discuss two long cases that I have planned to discuss about. I plan to finish this in an hour. Hopefully, I'll be able to. So usually there is a standard pattern in long case in the exam. You will be given a vignette, or you will be given a what you call initial string, which is 3 or 4 lines in before the exam. The patient will be in front of you, and then you will be asked to examine, then summarize, and then viva. This is the usual step that happens. The examiner look at how best you perform there. Okay, there are few etiquettes that has to be there to at least satisfy the examiners that you have understood the concept of critical care, how you approach a patient, what's your behavior, and how can you manage the situation as a consultant. So somewhere it's called as bedside dance. That's what they aim to look from you, right? And always there is an impression point. If you examine the patient well, if you later on answer the viva question well, that is required to pass the exam. But the most important thing that the examiner look at is the motherhood statement that you bring out at the first interaction with the examiner. So always think from the beginning that what are you going to tell as the first 2 or 3 lines to the examiner. All right, always try to keep making that statement or keep forming that statement when you read the initial clinical vignette. That's the starting point. So I am going to speak this because initial 3 line that is provided to you, they will say this is a 8-year-old presented with this complaint to the ICU. Currently he is this. Evaluate the patient for this, or what is your finding on this. So there will be a leading question there. That's what they want for you to answer as the first thing in the exam. When you finish the examination and then go to the examiner, they are expecting that you are going to answer that question what is being given to you 10 minutes ago. They are not prepared to listen anything else. If you start repeating the history, they are not interested. If you talk about something else, they are not interested. If they ask, suppose in the question, what are the barriers of discharging this patient to the ward, you think that's what they want as the initial 1 minute discussion. That's where the things will start. So make sure you read the question well, read the final line what they want from you, and frame that answer when you are going to speak for the first time to the examiner. Okay, so always frame a statement in the mind. Now once you see the patient, try to greet whoever is there. The nurse or the patient is awake, say hello, my name is XYZ. Always introduce yourself and seek permission to the patient, permission to the nurse, because it is important. That's your etiquette. That's what the examiner want to see. This is helpful because the exam is a very difficult exam. Only 10% of people straight away pass in the case. Rest of them are in the mark, suppose out of 10, rest 90% people will be in the range of 5 to 6. If 5 is the pass mark, 5 to 7, rest 90% people will be there in that mark range. To give you the better chance, you have to have other peripheral things with you along with the knowledge for the case. So make sure you are polite in the exam. Straight away greet the patient, good morning, Mr. X. Even if he is unconscious, sedated, don't forget to greet, because nothing is taken as granted. How do you know whether the patient is able to hear or not? So, good morning, Mr. X. I'm going to examine you. My name is Y. I'm one of the doctors. And also, if the nurse is at the bedside, try to wish or greet him or her. Okay. You need to have a lot of situational awareness because this is a tricky exam. You need to see what are the machines there, what are the monitors there, and what are the mediums in there. So we say 3M. So whether the patient is attached to a CRRT machine, if there is ultrasound open there, or if there is a traction to the patient, these are the machine you look for, and that will help you to frame the diagnosis and answer the questions also. Never forget to look at the monitor. Specifically, candidates miss few particular things. Temperature, they usually don't see. There is a temperature probe somewhere and the number will be there, they miss it. Or the patient who has a traumatic brain injury, there will be ICU monitor and there will be waveform there. Not all of you are conversant with it. If something doesn't make sense in the monitor, straight away ask the examiner, can I know what is this waveform or what is this number? I'm not able to figure out. They will tell you that this is a ICP monitor, this is a PA catheter pressure, or whatever it is. If you are not able to make out, straight away ask, what is this? That means you have identified there is something in the monitor. You want to make some sense of it. So you are asking. There is no negative mark for that. But if you ignore it and 3 minutes after that you get a question about it, then you are totally in a difficult situation. Okay. Third thing is medium. Medium means whatever going into the patient or whatever coming out of the patient, whether a urinary catheter, intercostal drain, a pacing wire, IABP, whatever, ECMO cannula, it's going to the patient or coming out of the patient. Examiners are very particular about it, whether you have seen that or not. Expose the patient and see what is there or not there. Make sure you tick out that. So, okay, these are the things going into the patient or coming out of the patient. All right. So, machine, monitor, and medium, that you have to be very careful because these are, first of all, will give you some idea about what is going to be asked in the exam, what is the diagnosis of the patient, and also few of them you cannot miss. If you miss a dialysis catheter, or if you miss a pacing wire, or if you miss an intercostal drain in the exam, probably passing will be difficult after that. Particular standard question you can ask: how long the sedation has been stopped, what was the last dose of paralysis, when was it given. These are the important information. If it is not given to you, you want to know, but avoid asking unnecessary question which is not relevant to the patient, right? The judge is you. What is relevant and what is not relevant, you have to decide about it. Now, before you step into the clinical examination, you must know what system you are going to examine first and then the others. This is important. Suppose the case is a abdominal sepsis, all right? And they have asked about there is some complication or intra-abdominal hypertension this patient has a monitor. You can see the IAP been measured, or the patient has undergone laparotomy for ischemic bowel or something. Abdominal issue predominantly you can find in the vignette, and then you start examining the CNS or respiratory system to start with. It doesn't look good, right? Make sure that what is the money in there. The abdominal system, yes, you need to examine the whole patient for sure, but make sure what is your priority. Even if you examine the CNS fast, make sure that you spend more time in the relevant system that is more important in this patient. So identify that. Okay. Cardiothoracic surgery patient, suppose someone post CABG and that's the case in the exam. And if you start examining his belly to start with, it doesn't look good. You may do that, but it has to be bit rational what you're doing. Okay. So make sure that you go in a normal expected format rather than making something very complicated there. Okay. Now your examination has to be slick. I know in the ward round we don't examine the patient that thoroughly, but if you're doing something, it has to be very slick. For example, you are examining the cardiovascular system, and if you don't hear all the four places where you should hear the heart sound, and if you don't give adequate time for that, that means you are forging that. The examiner can easily see that you are not doing the right thing. Okay. If you are going to do that, do in a way it should be done. If you are watching for the JVP, all right, for a patient who has a central line CVP, that doesn't make any sense. But If you're examining a JVP, then you have to do it in a way it should be. Suppose you don't examine the JVP or in a wrong way and present your case that I found the patient has a raised JVP, but you haven't examined in the way it should be. We don't do it usually, so don't start doing it for the sake of exam if you're not conversant with it, right? Keep it simple. Whatever is required, do that examination, and if you're doing it, do it thoroughly the way it should be. This can only happen if you do it repeatedly before the exam. It cannot happen by learning from the book and straight away go to the exam and start examining. Abdominal exam, I see a lot of candidates struggle with it. How to look at the liver dullness or how to palpate the spleen is very difficult for them. Or even ascites, they can't make out how to do the ascites or testing for the shifting dullness. You have to practice this few times before going to the exam. Make my word, if you fumble in checking shifting dullness in the exam, you will be failing that exam. If you don't know how to look for the liver dullness and you start doing in the wrong way, the examiner will be very, very upset with it. So make sure you practice those simple clinical examination at least 5 to 6 times before going to the exam. This is a very important point. All right. Few do's and few don'ts. Make sure that it depends on what you are doing. So if it is a long case, you have to spend time. If it is short case, you cannot spend time. But for example, you have 1 hour or 45 minutes to examine the patient, and you want to examine the patient like a neurologist for something which is not related to his neurology, for a shock, then it is not required. Suppose somebody has a septic shock and that's the primary focus, intra-abdominal sepsis, and you start examining the cranial nerves and you want a soap for the patient to smell whether his smell is intact or not, these are not required. So you have to be very careful what you are doing. Even if it includes a thorough neurological exam, but some sort of rationality has to be there. Okay, so be intelligent and think what are the examination I am going to do within that time frame which is going to yield me information. Okay, but the best thing is practice and have your own pattern. There is no set pattern for the examination. You have your own pattern how to examine the patient and practice it thoroughly few times before going to the exam. It cannot happen single time in the exam for sure. uh, for example, we'll talk about one case, a respiratory case. I cannot talk about all the cases at this moment, but suppose somebody has a pneumonia, is in the ICU on ventilator. So in that patient, pneumonia, ICU, respiratory system is the major bread and butter in this case. So that's where you are more focusing. In that case, look for the oxygen, how much oxygen levels the patient is on, what's the ventilator setting, and what are the other devices that can be there. Okay. For example, when you are presenting the case, not all the information that you gather during the examination can be told in the presentation, and sometimes you may forget it. For example, this patient is on point 0.8 of FiO2. You may forget while presenting at the end. Some people do a good thing is that which is abnormal during the examination, they verbalize that. Oh, the patient is on 0.8% FiO2 with a PEEP of 14. This is abnormal, right? So you have to verbalize that, a way of doing it, so that even if you forget during the presentation, the examiner has heard that you have identified that and he's not interested to hear it again while presentation. Okay. So sometimes it is a good practice to say, oh, the patient has an open wound there of 10 centimeters and it is actively bleeding. If you say that during the examination, you don't have to repeat that during the presentation. But if you miss it or don't say both during the examination and during the presentation, then there is a problem. So sometimes to get a benefit of later not able to tell it or not remember it, people verbalize an abnormal finding always. Oh, the CVP is 20. All right. If you find it out in that situation and verbalize, the examiner can hear it, then you don't have to present it again to the examiner while doing the final presentation. Okay. Now for this patient particularly, ventilated patient, You see what is the FiO2. If it is abnormal, try to verbalize that. What's the mode rate? If it is normal, usual SIMV rate is fine. You don't have to talk about that, right? Now, while examining, you may look for the suction, what sort of endotracheal aspirate is there. If there is dirty, thick endotracheal aspirate, you say it about it. Oh, the patient has dirty aspirate or thick purulent sputum coming out of the tube. All right. If there is a chest tube, verbalize that yes, there is a chest tube and it is bubbling or it is swinging or there is a air leak in there. If the patient is attached to the nebulizer, talk about it. So yeah, there is a nebulizer attached, I can see. May I know what is the medication being given to the patient? So things, so you have to see for a patient who is on a ventilator is oxygen, ventilator setting, and other devices attached to the patient. As I said, we always ask the permission, always tell the patient, even if he is sedated, paralyzed, you need to. Now, exposure is an important part in the exam, particularly in an Indian setting. You have to do graded exposure. You cannot take the whole cloth out for a female patient. So it has to be very graded, right? So you cover half of the body, upper half, lower half, examine that part. While examining a female patient, you can cover the chest and examine around it. Okay, and now ask for permission. Can I have a look, or can I auscultate your chest, or can I hear your chest? Similarly, the lower part. So part cover and part exposure, whichever you are examining, expose that, and then again make sure that you cover it. So in Indian setting, this is important. This is dignity of the patient. This is again judged by the examiner what you are doing or not doing. Okay, very important part. You have to look for associated things in a respiratory examination. This is all medicine stuff that you have done years and years. So look for cachexia due to COPD if the patient has COPD, use of accessory muscle. Look for chest if there is any visible abnormality, structural changes, if one side is moving, other side is not moving, etc. Look for nails, nail bed stains, nicotine stain, etc., and signs of infective endocarditis. So these are the associated things that you have to see. And it is good to mention the negative finding which can be associated there. Suppose somebody has a infective endocarditis, but you say, okay, the patient has no stigmata of infective endocarditis that I can see. Patient can present with blood culture positive infective endocarditis without stigmata of infective endocarditis, such as any punctate hemorrhage or other findings of infective endocarditis. So important to mention few of the negative findings also. Um, and go properly. If you are doing a respiratory, some people do respiratory cardiac exams together, which is completely acceptable. But suppose you are doing a respiratory examination, you did inspection, you did palpation, then you started auscultation, and then again you go and palpate something. This is not looking good, right? You have to complete the palpation in one setting. You cannot go to and fro. You check the vocal frequencies first and then auscultate and then go do the percussion. It is not acceptable. So you have to do in a sequence way that is accepted, because that is a negative mark for you. You don't, that means you don't examine the patient regularly because you don't have a set pattern. All right, make sure that the symmetry and the sequence is maintained. Um, when you hear the breath sound, make sure that what type of breath sound you are hearing. If there is a bronchial breath sound, if there is crepitation, if there is wheeze or not. So if there is an abnormal finding, make sure you present it that way. So I can hear bilateral bronchial breath sounds or bilateral normal vesicular breath sounds with decreased air entry on the right side with occasional crepitation but no wheeze. So these three or four things has to become as a package, right? So what type of breath sounds, presence of wheeze or not, presence of crepitations or not. So these are standard things that if there is something which is abnormal, that you have to mention also. As I said, things going in, coming out of the patient, chest drain, use of non-invasive, any nebulizer attached, use of nitric oxide, ongoing paralytic infusion, if there is a barrier precaution or a contact precaution, etc., etc. If you find something which is like a red flag, you mention that, because that's what is expected from you, from the examiner, that you identify and verbalize that. It's very easy to forget everything during the presentation, so it is a good idea. Whatever abnormal you find, just verbalize at that stage. Even if you forget at the final presentation, the examiner knows that, don't know, he has identified there, so that's fine. Okay. All right, now go to case one now. So first case, so first of all, the limitation of what we're talking about is not a real case. It is a real case, but I cannot forge it as a real case. So what I'll do is, I will run a video which is around 6 to 7 minutes in total about the case. You see the case, have an idea, and then we can go next. We can go step by step to the questions that can be asked. Okay. So I'll first show you the case one. We complete the case one, then I'll go to the video for case two, and then we'll complete the case two. All right. Any questions you guys have till now? No questions mean good and also bad. All right, I'm sharing. Sir, is palpation in respiratory system expected in ventilated patient? It is. It is expected. Um, but again, think what it is. So all ventilated patients, suppose somebody has a head trauma and doesn't have any signs of pneumonia, you don't need to, probably. But if somebody has a pneumonia or a pleural effusion, it's better to do it, and do it in a way that should be like, I know you cannot turn the patient prone and do the percussion on the back, but if you're doing a percussion on the front, do it. If you're looking at just expansion, do it the way it should be in the front. Okay. No, just not just one tap, one tap, one tap and come out. That means you're forcing it. If you're doing something, do the way it should be. Okay. Um, let me share the screen. Share. I believe this is the one. Can you see my screen there?
Yes, sir.
Right. How do I make it full screen? Is this the full screen? All right. I'm starting this video. I'll stop once this is the first case we'll be discussing about. So I'll run this video and then I'll spare 2-3 minutes for you guys to identify what is the problem with the patient, what can be the question about this patient that you are expecting, then we can go to the discussion. Okay.
Sir, you are on mute, sir.
Okay, that's the end of the gist of the first case. What do you guys think? What is happening here? You can unmute yourself and answer one or two people, or you can type the answer, that's fine. But as long as I don't get an answer, I'm not going to proceed. So we'll make it simple. So what will be the question? What thing the examiner is going to ask about this patient? What have you seen the examiner is going to ask?
Regarding the
Okay.
system,
What system they are going to ask?
respiratory system.
Yes. So you have a system that is going. Now you have an idea that this is going to be a respiratory-based question or case. Now, first stage. Okay. Second stage, what in respiratory system? So what abnormal things or what are the findings that you have seen here? And that will include in the viva.
He's tachypnic and he has a tracheostomy tube and right pneumothorax with air fluid level and right ICD in situ with the air fluid column movement is there with the air bubbling.
Yep. So what will be the question on this? What are they going to ask?
Regarding the ventilator settings, he's on high flow nasal.
Yeah.
So how will we wean this patient?
Yep. How will you win? Correct.
And any because he has already fistula from the cricoid to the esophagus, any fistula from bronchus to pleural cavity, bronchopleural fistula.
Yep. Correct. Bronchopleural fistula, and what is the management, etc. How bronchopleural fistula? Yes, that may be a question. There's something else was seen shown you. What was it?
IC was there, then
The peg tube there.
peg tube, and TPN also was going on because he has tracheostomy fistula.
What can be the question on TPN and
regarding the nutrition because he couldn't be started on enteral nutrition, so parental nutrition has been started for him.
Yes. So what will be the question? It will be around TPN, around conditions where you start TPN, complication of TPN, etc. So at least 50% of question you can always imagine what is going to be. Not 100%, but and think about that. Okay, this is a tracheostomy patient. Yeah, tracheostomy. What are the questions in tracheostomy? Now tell me what are the questions in tracheostomy that can be asked in this exam?
How many days old tracheostomy? Then it is a cuffed tube or uncuffed.
What questions the examiner will ask about tracheostomy if they are going to ask?
What is the method of tracheostomy which was done in this patient?
Correct. What are the
types of tracheostomy you know about?
Correct.
Complication expected post during tracheostomy or post tracheostomy. Then how to wean from that and what are the evidence for tracheostomy?
Excellent. 100%, right? Tracheostomy, these are the 5 questions, standard, right? Now, second, bronchopleural fistula. What are the questions can be on bronchopleural fistula?
What is the etiology for this bronchopleural fistula first? And is he on ICD placement? And what is the uh, ventilation mode we can
Yes.
do? And how can we wean this patient on
Yes.
bronchopleural fistula? And what are the surgical management available? Um, and regarding pleurodecisive.
So TPN and PEG, what they can ask you about?
What are the indications for this patient? Then
Yep.
complications
Yep.
and IV line management during TPN, and what are the monitoring we have to do, and refeeding syndrome.
Correct. 100%. There's no other question in this one. Let's see. It's very easy. You can anticipate. So just circumstantial presence. Don't get bogged down with so many things. Yes, this patient has these 4, 5 important things. The questions are going to be on this, right? Let's see what is there in the question. So what are his current issues? Uh, so we saw a patient who is tracheostomized, looks malnourished. So the question thread starts with what are his current issues. It's the first thing they will be wanting to listen. So what do you say? I have a X-year-old patient presenting to the ICU 3 days ago with complaints of shortness of breath or whatever. The current issues are, the second statement should be the answer to the question, right? No mumbling around like he has this finding, that finding, that will come later on. First, the answer to the question. The current issues for this patient are generalized deconditioning and he is malnourished. There is an artificial airway, which is a long-term tracheostomy. The patient is high flow and oxygen dependent. I found a bronchopleural fistula, which is complicating the situation. The patient has a high risk of microaspiration. That's why probably he has a PEG tube in situ, and nutritional balancing or nutritional plan will be an ongoing challenge. So these are the current issues, right? Then how do you do? So this is the first question is answered, the examiner is happy. Now, but you have to present the case after that, isn't it? So this is not finished. So further examination of the patient showed me, this is the way you tell. So first answer the question, then further examination of the patient showed me, or I found on further examination, he was conscious, oriented, following to the commands or whatever GCS you say. He was, if you are starting with the neurology, he did not have any focal neurological deficit, but he has generalized proximal weakness, which is more suggestive of critical illness, myoneuropathy. On further examination of his respiratory system, I found that he is on a 5O2 of this, respiratory rate of this, his secretions are this. I would be interested to see the ABG to see what's his PO2 and titrate my management accordingly. On further examination of his cardiovascular system, I found this, abdomen is this, XYZ. The overall impression was the patient is having this pathology, has been in the ICU for this many days, and going ahead, I would be doing battery audio, three or four things. I will be optimizing his nutritional status. I will screen him for any infection, which would include respiratory or other site infection, and I will make sure that he gets adequate physiotherapy and early mobilization to improve his recovery. Also, the chest tube can be managed initially conservatively to see if the air leak is reducing, but if it is not by day 3, day 4, I would seek for a surgical consult to look for other options. So overall, that's how you are going to present the case, but make sure that in the second or third sentence you answer the question that is asked in the beginning, and then you go to your examination finding and then summarizing the case. Is it clear what I'm saying? So that will take around 5-6 minutes to complete your presentation of the case to the examiner. Now the examiner will ask next question. Okay. As you see, there is a tracheostomy. Please enumerate the clinical indication for tracheostomy. So that's the first question for tracheostomy. if you reach this stage that the examiner have already started asking the first question within 10 minutes, then you know that you are going well. Okay. If they do not, do not start asking again the same question. No. What is the current issues? You did not tell us. That means you are in problem. You haven't told that, right? So make sure that you answer the first question that is in the vignette first, right? If you do not answer, the examiner will again ask, no, answer the question. What is his current issue? Unless you answer the first question, they will not go to the second one. Okay. As you see, there is a tracheostomy. What are the indication? It's always good to have a particular answer pattern, right? There is not hundreds and hundreds of questions that can be asked in the exam. If you have a device, there is 2 or 3 type of question that can be asked. Tracheostomy indication, types, and what is the literature for early tracheostomy. These are the 3 things they usually ask. Okay. IABP, again, indication, complication, literature around it. Okay. Then PA catheter, again, indication, complication, what is the literature around it. So practice these things, like 10 things, before the exam. So make a note, like if there is a tracheostomy, these are the questions I have to answer in one breath. That these are the questions, I have my answer ready. Problem is, if you don't have these things practiced before in the exam, then it is very difficult to talk about it in the exam. So I would recommend to practice each of these devices, like not more than 10. There are only 10 devices that can be asked in the exam. So in the respiratory, it will be a tracheostomy, or if the patient is on a nitric support or a high flow. Okay, 3 things. Or non-invasive ventilation again. In the cardiovascular, if the patient is on an IABP, they will be asked about, you will be asked about it. If the patient is on ECMO, they will be asking about you about that. If the patient is on a pacemaker, they will be asking about the pacemaker. So these are the 3 things in cardiovascular system that you get. In neurology, neurosurgery, you'll get a ICP monitor or a EVD that they're going to ask about. So make sure that you have practice this. Suppose somebody was on a EVD. So what are the questions in the EVD they will be asking? So what is the indication of EVD? How many days you can keep it? And what is the chances of infection? And what is the treatment for ventriculitis? So these are 3 or 4 questions that is standard for EVD. Similarly, everything that is attached to the patient, they can ask, but there are not infinity number of questions. There is very limited number of questions that they can ask. All right. In this case, indication for tracheostomy, divided in your way, whatever you think. Like I have divided as emergent and elective. Emergent is upper airway obstruction such as angioedema, anaphylaxis, hematoma, infection, mandibular abscess, or a mass that is causing difficulty in breathing. Post-cricothyrotomy to formalize the airway, or if there is a patient who is having severe airway trauma, then emergent tracheostomy may be required. But mostly it is elective, which is anticipated requiring prolonged mechanical ventilation, poor airway protection, severe subglottic stenosis, and patients with vocal cord palsy or paralysis. So these are the usual indications for tracheostomy. What is your opinion on early versus late? Standard question for a tracheostomy. What is your opinion? So there is no major advantage in performing early tracheostomy, that means less than or equal to 5 days. Data are limited in specific population. Recent randomized trial in severe stroke patient, early tracheostomy less than 5 days versus 10 days did not show any improvement in survival. In the landmark TrackMan trial, there is nil advantage for early tracheostomy. So this is the current evidence they will be asking for. How will you decide which patient will need early tracheostomy? Again, you have an answer. So usually cervical spine trauma or high cervical spine trauma, traumatic brain, hypoxic brain injury, patients with neuromuscular conditions such as GBS or motor neuron disease, um, or poor pre-hospital functional status, nutritional status, poor pulmonary function, advanced age, significant cognitive impairment, patients with prolonged ventilation. All these are indication for early tracheostomy that you do. In those cases, not prolonged ventilation, but you are anticipating a prolonged ventilation for a patient. Again, somebody told types of tracheostomy. What are the types of tracheostomy? Surgical, percutaneous. What are the emergency approach in a cannot intubate, cannot ventilate patient? In those cases, scalpel bougie technique or cricothyrotomy can be opted for. They can ask about these things also, because there is a station in the exam, like a what do you call your competence in terms of procedure competence. So they can ask about this also. Name few techniques of percutaneous tracheostomy. Again, a very common question in the exam. It can be asked in the table viva or in the case also. So Sigalia, Griggs, or Frova, or translaryngeal, different types of techniques. So at least you should be able to say these two, Sigalia technique and the Griggs technique. Enumerate possible complication of percutaneous tracheostomy. Again, you have to have a classification in mind and practice it before the exam. You cannot tell 100% in the exam for sure if you haven't practiced it. So in my classification, it is immediate, early, and long term. You can classify anyways. So immediate is subcutaneous emphysema, loss of airway leading to inadvertent extubation, decannulation, complication of depressurization, which is include de-recruitment, pulmonary edema, hypoxia, cardiac arrest, hemodynamic instability, bronchospasm, etc. Early is dislodgement, infection, tracheitis, uh, wound infection. Long term is tracheal stenosis, tracheomalacia, osteomyelitis, pneumonia, aspiration, tracheoinnominate fistula, etc. So there's no point going in detail about that. Make a pattern to answer in the exam straight away. If you start thinking in the exam to answer this question, then you lose time and also the marks. You mentioned about so the patient has malnourished because the first figure had what do you call had supratemporal fullness or supratemporal temporalis muscle wasting, which is an indirect evidence of malnutrition. So they are going to the malnutrition type of question. So how will you assess nutritional status? Again, very important question in the exam. How will you assess a nutritional status of the patient? Can anybody attempt? Then we can discuss about this.
Nutritional risk screening method and Nutric scoring.
What you do in the ICU usually?
NRS, we're using risk screening.
So what are the components of that?
Recent comorbidities in the last 3 months, any loss of weight loss, and appetite status, and weight loss in the last 3 months, mobility status of the patient, and
So do you do it regularly, or is it, what do you do?
this we do regularly, sir. During the patient as reaching the ER itself, we do it.
Okay, excellent.
Mm.
All right. It depends on what we do at different places. So make your answer ready for this, because nutrition, this will be a standard question in the nutrition. So what we do is more clinical examination history. So history, clinical exam, investigation. But if you use the Nutric score or some other type of assessment, just be conversant with it and talk about it, right? For me, we take a history. So as you said, what are the comorbidities? What are the habits? What is the social status? What is your usual food habits? And um, like before getting ill, how is he eating and what was his diet? Then add some clinical examination point, which includes the weight, height as per the age, muscle store, temporal muscle loss, skin fold thickness, other signs of malnutrition such as angular stomatitis, cheilosis, pitting edema, anemia, etc. And then investigation to backup, which includes a serum albumin. We don't do pre-albumin in my setting, but if you do it, you can talk about it. Serum creatinine, again, an indirect evidence of nutritional status. A low level does mean, but a high level doesn't give you any significant information. Electrolyte screening, if somebody is low on potassium, low on magnesium, low on phosphate, that means they are malnourished, and also sometimes vitamin levels. So I will answer with clinical history, examination, and investigation. These are the three things that we do. But if you use a particular score, be conversant with it and talk about it. Okay, because this is a standard question in the exam, very frequently asked. How do you nutritionally assess your patient? Now, how will you optimize nutrition in this patient, thinking his body weight is 60 kilo? So they are asking about a nutrition prescription. Again, assessment of nutritional status. So the requirement will be 25 kilocalorie times 60, which will be 1500 kilocalories plus protein, whatever you prescribe, 1.5 or 2 grams, that will be 90 or 120. Non-caloric protein needs to be going to the patient. Any other method that you do in the ICU regularly and you are conversant, you can talk about it. If the patient is in acute stress, such as ongoing cancer, inflammatory stage, then you can think of adding some more, 25% to the baseline requirement. You can add that. Now, if they ask about how do you plan your nutrition, you have to talk about first assessment, then how will you do it? Assess the route, whether enteral, parenteral. Enteral is nasogastric or PEG or JETs. This patient has a PEG. But if there is a mixed enteral and parenteral you have to use, you have to talk about what sort of access you need. Okay. And extra marks, if you said, can consider supplementing with TPN if the target is not achieved within 3 days and the patient has ongoing intolerance. So you can add TPN to the uh, nutrition if the patient does not tolerate or the goals are not achieved within a reasonable time frame. And also assess for tolerability. Gastrokinetic agents needs to be given if the gastric residual volume is high, if there is vomiting, all those things you have to look for, assess for tolerability. So 4 steps in the assessment of nutritional plan or giving a nutritional plan. First, you assess how much nutrition, how much calories, how much protein, and based on the stress level you can modify that one. Then assess for what is the route and method of feeding. Enteral parenteral mixed, when you consider mixing it. Number 3 is assess for tolerability, like monitoring for electrolytes, monitoring for gastric residual volume, vomiting, diarrhea, etc. So all these points has to be covered to give you the full mark. When will you consider TPN? We talked about that. So again, if you have a pattern of answer, it becomes very easy. It's a general question. When will you consider TPN in a patient if they ask you as a general question? So it can be a general indication, feeding into the GI tract is contraindicated, not possible, enteral feeding fails to meet nutritional requirement, or enteral access is totally non-attainable. So in those cases, you start feeding that patient with parenteral nutrition. In some cases, patients who have coexisting malnutrition to start with, so perioperative or preoperative feeding can be considered with parenteral nutrition to buff up their nutritional status, and also in general will have a better outcome post surgery. And post-operative, where indicated is patient has mild to moderate malnutrition where oral and enteral route feeding is not possible within 7 days, then you can consider to start TPN early. It should be considered in severe malnutrition after 5 days. So there is no point starting it straight away. If you think that the patient is not going to be fed for day after day 5 and has baseline malnutrition to start with, you can start early parenteral nutrition. What are the possible complications? Again, we talked about that. So it can be catheter related, it can be refeeding syndrome, hypercholesterolemia. Make a pattern of answering. It will be easy. You practice this before the exam. Then they may give you some sort of um, thing that you have to evaluate, whether it is a scan they will show, they may show you an ECG, they may show you another set of blood tests and ask what is that interpreted. In this case, they have shown us a blood test which has a high white cell count, high urea, low potassium, low bicarb, and has a low magnesium phosphate, and glucose is high. So they are asking you to interpret what it is. So 2 days after commencement of TPN, the following are the clinical and laboratory values. What are the most probable cause? His heart rate is 134, blood pressure is low. He feels very fatigued, tired, and overnight he required to be put back on pressure support, ventilation, as he was getting tired. So what's your impression here? Anyone wants to Somebody has already written that. Good, excellent. Yeah, refeeding syndrome, which is looking very obvious. So they can go into refeeding syndrome next. What are the complications that can be associated with refeeding syndrome? Again, have a pattern of answer. I would usually go by the system. So it can be associated with heart failure, hypotension, shock, cardiac arrhythmia because of dyselectrolytemia. Patient can have LFT derangement, diarrhea, delayed gastric emptying, arrhythmias we talked about, can lead to acute tubular necrosis, respiratory muscle weakness, prolonged ventilation, muscle weakness, rhabdomyolysis, seizure, coma, delirium, and also reduced infection resistance or phagocyte dysfunction leading to more prone for infection. This is a possible complication. Patient has a bronchopleural fistula. How will you manage this fistula? So ventilatory management, non-ventilatory management. So ventilatory in general, prefer avoid positive pressure ventilation and drain the air with a wide bore intercostal drain with suction attached. Definitive treatment if it is not getting better day 3, day 5, still ongoing high air leak, then it will be probably a surgical consultation, either bronchoscopic guided glue or thoracoscopic repair of the leak. So these are the possible um, management. What is the record? What is the recommended ventilatory management of bronchopleural fistula? So ventilatory is usually ask the patient to breathe spontaneously if possible, and if not, then the ventilation is like the asthma type of ventilation where you have a high inspiratory flow and a decreased inspiratory time to reduce the leak. So the flow setup will be high, 60-80 liters per minute, and decrease the inspiratory time so that you get less time for the leak. So that's how, if the patient is ventilated mandatory or a CMB or a SIMB mode. Okay. Role of DLT, yes, if you are not able to ventilate, yes, double lumen tubes can be tried, but these are all acute management where everything is going through the hole. Then you have to put either a bronchial blocker or a DLT. You use it for acute management, but if the leak still remains after day 5, then probably surgical consult and find out ways to treat it. Yep, that's the end of the first case. Any questions or any doubts? I'm happy to answer. Otherwise, I'll run the second part video. Okay, good. No questions. Let me run the video again. All right, can you see my screen all right? Yep, I believe so.
Yes,
Yes.
sir.
All right.
Screen is visible.
Second case we are talking about. So again, we'll run that and stop at the end and evaluate what can be the questions you can anticipate, and then we'll try to answer those questions one by one. Okay. All right. That's the vignette, and I'll stop sharing this. All right, let's talk. What do you think what's happening, and what can be the, first of all, questions in this case? Yeah,
This is a 55-year-old gentleman with a known alcohol history. He comes with abdominal pain and vomiting. Mostly is an acute abdomen related to the pancreatitis or acute calculus cholecystitis picture. And he is clinical signs look like jaundice, distant abdomen with the skin discoloration in the abdominal wall with the on the right flank there is a ecchymosis like picture with the visible veins on the abdomen, and CT images were showing pictures of pancreatitis with the peripancreatic fluid collection was there, and there was in the USG also was showing calculus gallbladder with the minimal peri-gallbladder collection also. The questions could be around related to pancreatitis and nutritional status, fluid management, and regarding acute cholecystitis management, and a role of enteral nutrition, parenteral nutrition also is there.
Yep.
Fluid management.
Yeah, more or less.
As a 6.
Yeah. All right.
Mm.
Now let's go step by step what the questions are here. So what is your differential diagnosis? That will be the starting point to start with. So in this case, I want to highlight differential diagnosis means you'll have at least 4 or 5 things that you have to talk about which are relevant to the patient in this case. Okay. It's always good to have some sort of, again, classification in your mind to talk about, but the problem people face is sometimes in the differential diagnosis question they talk about something totally irrelevant in this case. So if somebody says he has viral induced pancreatitis, or he has antiretroviral drug induced pancreatitis, it will be difficult to defend those things. So you have to talk about the top 3, 4, 5 causes in a differential diagnosis. So in this case, probably it is a gallstone related acute pancreatitis, but the other causes can be, in this case, he has a high cholesterol, as somebody has answered there, triglyceridemia causing that, number 2. Number 3, it can be idiopathic. Number 4, he has some history of alcohol probably, and that can be another cause of differential. So the top 3 differentials for pancreatitis in India is gallstone, alcohol, or top 2 I'll say, gallstone and alcohol, and then other will be triglyceridemia or idiopathic. So these are the 3, 4 things that is most common, right? After that, if they ask, oh, what else, then you can talk about other things. So this is the table that you may have in your mind, but doesn't have to talk about everything. So alcoholic, drug-induced, or biliary pancreatitis is the most important. Other causes can be vascular, infectious, drug-induced, neoplastic. So vascular, again, mesenteric ischemia, acute mesenteric vasculitis, infectious disease, which includes cholangitis, cholecystitis, colitis, drug-induced causes that can cause pancreatitis, neoplastic can cause again. So these are the things that can be differentials to that. The main thing is your differential should be rational to the patient and the finding that is given to you, rather than talking something totally unrelated. That will be a problem if you talk about it. Okay. As you said, pancreatitis, what are the possible causes of it pertinent to this patient? Again, same. So alcohol or anti-diabetic medication, he was on some anti-diabetic medication that can cause it, or obstructive, that is gallstone, biliary tract disease, or hyperlipidemia. All these things are the most relevant causes in this case. What specific investigation will you send for this patient to delineate a diagnosis? Anyone wants to answer?
Primarily, we can do an USG abdomen first.
So delineate the diagnosis means you have to first establish it is a pancreatitis, isn't it? So if somebody asks you what are the investigation you are going to send in the beginning of the stem, that means he wants a complete evaluation. Okay. If somebody asks about what is the investigation towards the end of a stem, like the examination or viva has gone through for 10 minutes, and they're asking specifically for one examination or one investigation, you have to answer one investigation. So USG is correct, but it has to be in a sequential or in a what do you call formalized manner. So I'll send some blood test, I'll send some imaging, or I'll ask for some imaging, right? So blood test will include full blood count, lipase, amylase, RFT, LFT, etc. But don't give them a shopping list. If you say something, you have to explain why you want it. So full blood count to look for white cell count, to look for signs of inflammation or infection. Also, I'll do some CRP that will help me to risk stratify if the patient has a pancreatitis. I'll do some LFTs to rule out any obstructive cause of it, and also associated electrolyte derangement that can happen with other organ dysfunction. I'll send some amylase and lipase to rule out or rule in pancreatitis or other causes of uh, pain abdomen or this type of presentation. The other investigation that will be essential in this case is an ultrasound abdomen. Yes, but what are you looking at? You have to tell ultrasound abdomen to look for biliary pathologies such as calculus or acalculus cholecystitis, cholecystitis, ascites, or any other hepatic pathology, and also look at the pancreas. If the patient is stable, I would look for SCT abdomen unless I have answers from the above test. So usually you don't send the patient for a CT abdomen for a case of acute pancreatitis. If it is clinically evident with a raised lipase, amylase, usually you wait for some time to things to evolve, and then you do the CT. You do the CT only when the diagnosis is not apparent to you, or if there is a complication, or if the patient is like you cannot explain the presentation of the patient, like somebody is severely shocked, or somebody has abnormally high pain or something like a high lactate or something. In those cases, if it doesn't make sense, then you go for a CT scan, right? So if the bottom line is, if they're asking for what are the investigation you want to do in this patient in the second question, that means you need to tell how are you going to establish that this is pancreatitis. If they're asking this question later towards the end of the viva, then there is a very specific investigation they're asking, whether an echo, depending on the scenario, whether it is a echo or a X-ray or a chest CT or something. So make sure where they are asking and why they're asking it. Okay. You understand what I said? I hope so. As you have asked for the ultrasound that you have already, this is ultrasound image that is being given. Now you tell me what is abnormal there. You saw the ultrasound already. What is abnormality there?
Sir, sorry to interrupt you. So your screen is not visible.
Oh, why is that? Not visible from the beginning.
Yes, sir. This time you have not said your screen.
You should have told me earlier. All right. Can you see now?
Yes, sir.
So we talked about this investigation. So depending on where they are asking, that's what you are going to tell. If they are asking very specifically ultrasound abdomen, yes, that's the first thing you do. If they're asking as a general question, you have to tell about all the possible investigation that you are going to send. You have done the ultrasound. Now they're asking, based on that image, what is the finding that is there to explain this is a gallbladder or gallstone related pancreatitis. Anybody wants to explain the ultrasound image that you saw, or what you usually see in a cholecystitis or cholangitis type of picture? What are the things are very specific to that diagnosis? It's a very common question they ask in the exam. What are the signs of ultrasound signs of acalculous cholecystitis? So make sure that you have those points covered. They usually ask what are the ultrasound signs of acalculous cholecystitis. So in this case, what you saw, it showed a moderately distended gallbladder with thinned out gallbladder wall with possible hyperechoic shadow in the lumen of gallbladder suggestive of cholelithiasis with gallbladder sludge, and there is some pericholecystic fluid. The signs of acalculous cholecystitis usually, can anybody tell the three major signs that you look for? Guesswork?
Distended gallbladder, gallbladder wall thickening, and gallbladder fluid collection.
Yeah, so gallbladder wall thickening, perigallbladder fluid, and distended gallbladder with possible Murphy's sign, radiological Murphy's signs positive. What are the signs of acute cholecystitis on ultrasound? So cholelithiasis, most sensitive sign, sonographic Murphy's sign, you press, they will jump with pain. Gallbladder thickening, 3 millimeter more than 3 millimeter, perigallbladder fluid, and distension and sludge. So these are the signs of acute cholecystitis. So they can ask you these things at the spotter also, because nowadays we are very pro ultrasound, and these are the common understanding that they think that the candidate should have. With the above laboratory and ultrasound finding, what is the current provisional diagnosis? Acute pancreatitis, possibly due to gallstone, associated with cholecystitis and/or choledocholithiasis. So probably that's what is the diagnosis. Other differential we talked about is possible hypertriglyceridemia that can cause it. But the patient has jaundice, and which is more commonly goes with a gallstone pancreatitis. What are the indication for this? Is again very fond of question by the examiner. What are the indications for contrast CT abdomen in a pancreatitis patient in the initial phase, like acutely within 1, 2, 3 days? What are the indications? Well, usually we don't do a CT, but what are the indications? We discussed about that. Initial imaging of acute pancreatitis, when the diagnosis of acute pancreatitis is uncertain, patient with hyperamylismia, severe clinical pancreatitis, abdominal distension and tenderness, fever more than 102, leukocytosis for detection of complications. So complications can lead to these things. So to rule out any complication, you may need to do a early CT. Also, if the Ranson score is more than 3 or Apache score is more than 8, that is again you can consider. Patient who failed to improve after 72 hours of conservative treatment, then that again warrants a CT scan. And any acute change in clinical status, such as new onset fever, shock, which is not explainable and not responding to resuscitation, these are the indication to do a CT with acutely within 3 days. This is a very fond of question by the examiner, because they try to avoid CTs. And what are the conditions that you need to do a CT early? They will be asking. Next step in the management of this patient. If it is a gallstone pancreatitis, this is the only thing that you do acutely in pancreatitis. You need to do a MRCP followed by an ERCP, or can consider directly to do an ERCP to release the obstruction. This is one of the, or we say only one indication where you need an urgent ERCP. If the patient has gallstone pancreatitis presenting within 24 hours with obstructive symptoms, you look to decongest or decompress that early rather than late. This is indicated, right? So they will be asking this question: if it is a pancreatitis, give me an indication, or what will you do to treat. So Pancreatitis in general is conservative management. Only two things that is done acutely. One is ERCP for a gallstone pancreatitis with cholangitis. Second is hypertriglyceridemia causing pancreatitis where plasmapheresis can be helpful. Okay, so these are the two acute interventions that can change the course of the disease. Rest all etiologies of pancreatitis is managed conservatively. What are the indications for ERCP acute pancreatitis? So gallstone pancreatitis with cholangitis, common bile duct obstruction, visible stone on imaging, dilated common bile duct, and worsening liver function test without cholangitis also is an indication. So if you suspect a gallstone pancreatitis, it's always good to refer them to a gastroenterologist for an early ERCP within 24-36 hours. Ideal time frame within 24 hours. Okay. What is your nutritional plan? Again, somebody was already having this discussion that this is going to happen. This is the thing. So again, route, timing, type, target, and monitoring. These should be the points what you are touching. Any question on plan of treatment, make sure that you cover at least the monitoring part. How do you monitor the treatment? Suppose I have told this earlier probably. CRRT. What is your CRRT prescription? Again, the prescription means route, dose, monitoring. The route is with a VAS cath in the groin or in the IJB. Dosing 25 ml per kilo. That's what you do as a ultrafiltrate rate. And then you talk about monitoring. So I'll do some electrolyte in 4 hours to see the electrolyte levels with the dialysis change in the electrolyte pattern, and then modify my dialysate or a replacement rate. So similarly for nutrition, you talk about route, timing, target, and monitoring. Route, enteral feeding is preferred, or nasogastric is preferred over anything. But if no tolerance or decreased tolerance to nasogastric, then you go for nasojejunal feed. You start within 24 to 72 hours. The target, you don't have to fully feed the patient, but you at least start at 30, 40, 50% of the basal rate and to gradually titrate over it and look for gastric residual volume. There's no fixed volume that we look for, but anything above 500 may need gastrokinetic agents such as metoclopropamide or erythromycin, and also monitor intraabdominal pressure, because in pancreatitis this is a common finding to have a high intraabdominal pressure. So that's how you tailored your answer. If somebody says, oh, what is your nutritional plan? So I'll feed enterally and stops there, it is 0 mark. You have to tell what is your plan, what is the target, route, monitoring, all those things that we discussed. Okay. How do you evaluate severity of acute pancreatitis? Again, this is a very common question. Clinical scoring, organ-specific scoring, and imaging. Clinical scoring are Ranson's criteria, Apache 2, or biceps scoring. You probably don't need to know each of the component of that, but at least Ranson's criteria, you need to know what are the component of it. And then other severity scoring can be used. SOFA score can be used, and also imaging scoring such as CT severity index or Balthazar scores have been used. So you need to know at least the Ranson score and the CT severity index for pancreatitis, acute pancreatitis. What are the complications of acute pancreatitis? Again, very pet question for the examiner. You have to have a frame of classification in the mind. You cannot talk randomly saying that, oh, abdominal compartment syndrome, then vomiting. It doesn't work like that. Local complication, systemic complication. Local are necrosis, abscess, pseudocyst, pancreatic ascites, splenic and other arterial aneurysm, catastrophic bleed. Local complication. Systemic complication, system-wise, respiratory pleural effusion, atelectasis, secondary infection, aspiration, stress cardiomyopathy, shock, hypovolemia, hypotension in CVS, renal is AKI, metabolic will be hypoalbuminemia, hypocalcemia, GI bleed, etc., mesenteric ischemia, abdominal compartment syndrome. So you have to classify your complication beforehand, practice it so that you can talk about in exam. Do you know, sometimes if you answer one single question very well in the exam in a well structured manner, that carries the impression for the examiner. Oh no, he knows about it. Then they can consider, even if you do poorly later on, they can consider your approach to one or two questions, how good you have answered. So practicing this beforehand is definitely helpful. Interpret the CT scan. I think this is a video, so they can show you. It's a usual thing. Towards 8-9 minutes of Viva, they will show you a CT scan run through and ask you what is the abnormality. In this case, why is it not going here? So this is not that patient, but has something here that I want to show you. Going back again. All right, any finding, comment? Sorry, can't hear you.
The plain CT abdomen, axial cut, which is showing, there is a destruction. Pancreatic is destructed with a peripancreatic collection and some calcification inside the maybe hyperdensity inside the pancreas.
So a contrast CT, not a plain. Possibly because I can see the contrast there. And peripancreatic collection, yes. Possibly developing a pseudocyst. Sorry, the quality of scan is not good, but that's what I can manage. And this is not the same patient, this is someone else. And now going back again. You can see non-enhancing region there, possible collection. Formation of a pseudocyst possibly. Dilated stomach. Stop that. I don't know how do we go to the next slide. Okay. So severe pancreatitis with walled off pancreatic fluid collection. That's there. Now, how do you manage a pancreatic pseudocyst? I think this is the last question. Anyone wants to volunteer?
Conservative management initially. If there are signs of infection, we can proceed for initially start with antibiotics, then proceed for aspirations, interventional, minimally invasive techniques.
Yeah. So gastrocystostomy for a matured one. So wait for organize and if asymptomatic, then observe for possible spontaneous resolution. If symptoms or complication, then endoscopic or surgical drainage that you do. Yeah, that's the end of that. Now there are few queries in the box. Lipase, amylase, ultrasound, yep. Wall thickening, yep. Wall thickening, minimal invasive techniques, yes. Cystogastrostomy or cystogenostomy, yep, that's correct. All right, that completes the two cases that we discussed. I'm happy to answer your queries if you have any other questions. All right, if not, then I'll stop sharing and I will give you a couple of minute breather before the next speaker comes in. All right, thank you for your patient listening. This is for me today, and many trials related to pancreatitis. Yes, they can ask you about the trials, but majority, there are two aspects to the trial. Early versus late starting of antibiotic or profile, not early versus late, prophylactic antibiotic, yes or no for pancreatitis. That's one. Number two, the nutrition, gastric, like a nasogastric feed versus nasojejunal feed or any feeds. That will be and the outcome of that trial is nasogastric is superior to any other or comparable to any other, and only indication where you don't have tolerance to nasogastric, then you go for a nasogenital type of feeding. Then I think these are the two major clinical evidence they want to talk about, and starting timing of feeds, so early versus late feeding. But these are the three major aspects they look for. Rest of the trial, like early intervention with a minimally invasive surgery, etc., it's more surgical specialty based. I don't think they'll be asking about it. So majority it will be nutrition related and antibiotic related. These are the two things they ask. All right. Any other questions? If we don't have any other further discussion point, you can post it in the group if you have any doubts or any clarification required. I think the next speaker is Dr. Niharika, and I will hand over the presentation to her. Thank you.
Thank you. Thank you, sir. So good evening, all. Yesterday we couldn't complete the instruments entirely. So you people want the remaining part of the instruments, which might take some half an hour to 45 minutes, or you want to start fresh topic like ABG, where you want to solve a lot of ABGs. So what do you think? Whichever you want, you please put it in the chat box. We'll start with that. Okay, finish instruments, done. Okay, so post instruments, we will do at least an hour of ABG. So keep your paper, pen, everything ready. Okay. So we'll start with the remaining instruments. So yesterday we completed, the last one was your tracheostomy, central line. So now we will go with the spinal needles. So I think everyone knows from past many years, you people are familiar with your spinal needles or the Quincke Babcock's needle. So they may keep this. So whenever you take it, describe about it, the parts of it. Okay, so it has totally 5 parts. One is the needle shaft, which is the outermost one. Okay, and you have a needle hub, a bevel, a stillet, and the stillet hub, which is usually color coded. Okay, so whenever you take that instrument, please explain the parts first. Yesterday I told description of the instruments. Then you can come to the indications if you want. The indications, contraindications. Okay, and if they ask about the procedure, please tell about the procedure. Okay, and important are the uses, that is the indications. Okay, so a lot of color code specifications are present. So the most common one which we use for an LP is from either 22 or 23 gauge. Okay, so please remember the color coding. I think most of you all know the color coding. So it starts with the 18, okay, pink. Then we usually use either green or black, 21, 22, and 23 is the blue gauge. And for proper spinal, we usually use from 23 to 26. Okay, that is the brown color. So now major indications. So this is one of the beautiful slide which tells everything about your spinal. So when they ask about the indications, so in the ICU, it's basically because of the diagnostic indications. So the diagnostic indications can be divided as infections, that is to diagnose your meningoencephalitis. Second, to rule out any inflammations like your Guillain-Barré syndrome, to rule out any CIDP DPs, multiple sclerosis, vasculitis, or neurosarcoidosis, and others like SAH if the CT is normal, and to do in order as a therapeutic part for idiopathic intracranial hypertension and for normal pressure hydrocephalus. So these are the indications, diagnostic plus therapeutic indications in the ICU. Okay, now coming to the contraindications. Yes, contraindications, the first thing we do is your coagulopathy check. Okay, so if the patient has a coagulopathy, then that is one of the relative contraindications. So where the patient has thrombocytopenia or patient is on anticoagulants, then you need to check. So usually the spinal is indicated if the platelets are more than 50,000, your INR should be less than 1.4 and your APTT should be less than 35. Okay, and the other contraindications are skin infections at the puncture site and if there is a raised ICP. Okay, so can anyone tell me when to order an imaging before your LP? You can put it in the chat box or you can just tell me.
There are signs of raised ICPs, papillary edema, double vision, and any history of tumor in the past, brain tumor in the past, intracranial lesions.
Okay.
Mhm.
Yes, one is focal neurological deficit. That is very, very important. Okay, any CNS disease and to rule out cerebral edema. Okay, yeah, basically raised ICP signs. So brain CT to be done if the patient has coma without an apparent cause. That is the most important indication. Second, if the patient has an altered sensorium with a seizure episode. Third, focal neurological deficits. And the fifth one is a relative sign immunosuppression. Because most of the HIV positive patients will have a raised ICP because they might have any other cryptococcus or histoplasma or toxoplasma, anything. Okay, so these are the indications of a brain CT before doing an LP. Okay, and a brain MRI is indicated if there is an isolated papilledema and or a headache. Okay, especially to rule out a cerebral venous thrombosis. Okay, so please remember all these three things: coma without apparent cause, seizures, and a focal neurological deficit. Okay, so what is this?
IGL size 2, supraglottic airway device.
Okay, so anyway, this is Soumya, right?
Yes,
Is this okay, Soumya? Can you okay now from yesterday you were listening, so can you when you're taking IGEL in your hand, so please describe me about the IGEL. How much ever you know?
supraglottic airway devices. Generation is second generation, and size is two sides. There's patient end and machine end, which has a female connector in the machine end, and this has a drainage for nasogastric tube placement. Drainage can be done, and this is a self uh, expanding in size and doesn't need any inflation thing, and to shown to be better seal.
Okay, now indications, contraindications.
Contraindication, if the patient has a full stomach and need for long-term mechanical ventilation, then cannot place this one. Indication is for short duration, and if in case of emergency, difficult intubation or difficult mask ventilation, also we can use this.
Okay. Good. Okay, so this is a supraglottic airway device. So we'll just go into detail about some supraglottic airway devices, the classifications and all. So what are supraglottic airway devices? So these are the devices which are used to maintain the airway patency and provide ventilation by placing just above the glottic opening. That's why they are known as supraglottic. So who invented the supraglottic airways or developed? It is the Archie brain. Okay. So coming to the classification of the supraglottic airways. So there are two types of classification. One is your Cook's classification, which is based upon the generation, which you told that second generation IGEL belongs to the second generation. And there is one more classification, that is your Miller's classification. And this is based on the sealing mechanism. Okay, so Cook's classification, the first generation, it has a simple breathing tube. There are no additional provisions for your gastric drainage or any other thing. Okay, so the first generation has a simple breathing tube. Examples includes your classic LMA, unique LMA, okay, your Cobra, everything. Your second generation will have a breathing tube plus a provision for your gastric drainage. So your IGEL, ProSeal, Supreme, everything comes in second generation. So third generation, still there is a lot of debate going on about the definitions. So you can just tell about the first and second generation. Now coming to the Miller's classification. So this is, as I told, it is based on the sealing mechanism. So in that you have again three types. Cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and cuffless pre-shaped sealers. And your IGEL comes into your cuffless pre-shaped sealer. Okay, so when they keep IGEL, you can tell that it belongs to second generation and it is a cuffless pre-shaped sealer. Okay, so you have to just remember some of the examples, at least your ProSeal, Classic LMA and IGEL and the intubating LMA. Okay, so these are the things that they usually keep over there. So which belongs to what, you should know. So this was about the classification. Now coming to the indication of any of the supraglottic airway devices. The first one is, we all know, it is elective ventilation. Those who cannot be mask ventilated. For those people, you can use as an elective ventilation, a supraglottic airway. Okay. Second, any difficult airway, that is after a failed intubation, the LMA can be used as a rescue device. Okay. So you should tell in elective ventilation, when do you want to use the LMA, and in difficult airway, when do you want to use the LMA? And in situations like a cardiac arrest, where most of the people doesn't know to intubate, in a pre-hospital setup, you can use this LMA. Okay, so these are the indications of LMA. Coming to the contraindications, all are relative contraindications. So as I told, these are supraglottic, above the glottis. So any pharyngeal pathology, pharyngeal obstruction, you cannot use this LMAs. And if there is a low pulmonary compliance, especially if there is a restrictive air disease, you will not be able to ventilate it, and they require a lot of pressure. And when you give that pressure, the supraglottic airway may be displaced or dislodged. And especially those patients who have an aspiration risk like pregnancy, better to avoid the LMA. Okay, so these are the different types of LMA. Okay, so intubating LMA, classic LMA, and your IGEL. So these are the parts which you have actually told. Yes, there is a gastric channel, and you can mention about this bite block. Okay, it's a bite block also present here. You have an epiglottic rest, non-inflatable cuff, and there is a distal end for your gastric channel. This is how you describe it. Okay, so can anyone tell me what is this?
12 French trilace catheter with 16 centimeter.
It's a
Used
triple
for
lumen.
both
Okay, it is a triple
dialysis.
lumen. It's a triple lumen, right?
Yes, ma'am.
So you need to tell about the lumen also. Double lumen, triple lumen. Okay. Okay, ma. Tell. Triple lumen. Okay, Jyoti.
So this is a triple lumen, 12 French 6 centimeter dial. We tell it as trilace catheter, ma'am. Is it like, can we tell like that, or
Dialysis catheter you can tell.
dialysis
Yeah,
catheter can be used for dialysis as well as infusing medicines. So this line can be placed both in the right internal jugular vein or femoral axis. This has multiple markings, and this is radio opaque also. And the indications are for both dialysis and for giving medicines, inotropes and fluids, and for also CVP measurement. And complications associated with during placement, risk of bleeding, then risk of pneumothorax, and risk of subcutaneous emphysema, and cannula displacement, line site catheter related infections. So contraindications, if there is any coagulopathy or skin site infection.
Okay. So most probably when they ask about the indications, examiner might ask the indications for hemodialysis. Okay. So you should know the indications of hemodialysis. So this is a triple lumen HD catheter. Yes, you can tell the different insertion sites from where it is, you can put it. So this is just a theory which I'm giving you. Okay. I think this is, I've actually discussed in your during your theory classes also. So this is just a revision. So which is the best site for the insertion is your right internal jugular vein. Okay. So length of the catheter, the right sided catheter should be at least 13.5 centimeters. And if you're inserting into your left internal jugular vein, the cannula size minimum should be 16 to 20 centimeters. So that's why ideally we better put a 16 centimeters on both the sides. Okay. So femoral veins should be considered as the second choice, and the subclavian axis is discouraged because it may lead to stenosis of the vessel. Okay. And in future, if you want to do any fistula at that side also, then that won't be a useful thing. Okay. So that is very important. So this is the different sizes of the catheters which you have to use at the different sites. Okay. So as I told, 13 to 16 right IJV, 16 to 20 is the left IJV. In the femoral, it is still longer. Okay. Minimum 19 to 23 French to be used. Okay. And the diameter is usually 12 to 14 French. So one important thing you should remember is what should be the what should be the intrinsic properties of the catheter. Okay. So they tell that the design of the catheter should be like a shotgun. Okay. So shotgun will have a longer edge and a smaller end. Okay. So why you should have this? In order to prevent recirculation of the blood. Okay. So what is this shotgun tip is? So your inflow cannula. So the uppermost portion is your inflow lumen and the lowermost part is your outflow lumen. Okay. So whenever the blood from the the dialyzed blood will go from the outflow lumen to the patient. Okay. So the distance between the inflow and the outflow should be minimum 2 to 3 centimeters distance. If not, what happens? The blood which is already dialyzed, okay, which is fresh enough, removing all the, your creatinine and everything is being removed, waste product is removed, it will directly go to the patient side. If the distance is very less, as in the figure B, what happens? Some amount of the blood will go into the inflow lumen. Okay, so that is known as recirculation, and the blood that the patient receives will have a mixture of the both. Okay, so that's why they tell that the catheter, the design of the double lumen catheter should be of a shotgun design with a 2 to 3 centimeter distance between the inflow and the outflow tips to limit the recirculation. And one more thing is, sometimes we see that, okay, we are not getting a good flow. Basically, you remove the flow from the uh, blue line, okay, and the dialyzed blood will go to the red one. If you do a catheter reversal, because the flow is not good, okay, from the blue you are not able to withdraw it properly, so I'm going to connect it to the red, okay, so that also will lead to recirculation. So better to avoid the lumen reversal. That is one of the way that you can limit your recirculation. Okay, and whenever you're inserting the catheter, it should be at the middle of the vein. Okay, so your catheter tip should not touch the walls of the vein. Okay, that also may cause recirculation. So the blood flow should be proper. Okay, so to limit recirculation, three important things you should remember. Most of the examiners will ask this. Okay, one is your catheter distal tip must be located in a high blood flow area, so it should not touch the walls of the vessel. Second, I told about the shotgun design. And third is rumen reversal should be avoided. Okay, so this is how you prevent recirculation. Okay, so this is not required. So what are the questions that they may ask when you hold your instrument, your HD catheter is the indications of RRT, the different types of RRT, what are the complications of RRT. Okay, so indications of RRT, I think most of you all know. Absolute indications and the relative indications. Please divide your answer. Indications of RRT, don't tell the absolute indications like whatever you know first. Okay, so please divide your answer and then tell about that. Okay, now the next comes your CRRT. So I think most of the institutions have CRRT, so they will ask the prescription of CRRTs. Okay, so prescription about your hemodialysis, nutritional prescription, both are very, very important. I think most of y'all have attended the theory class where you know all the things. So I'll just go to the prescription directly. So can anyone tell me the different types of CRRT modules?
Continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, then continuous veno-venous hemodiafiltration,
Okay.
then scuff.
Okay. At least these three you should remember. Okay. So okay. So first we will go with CVB HD hemodialysis. So hemodialysis, so what is the dominant method of solute clearance is diffusion. So you have diffusion and convection, which you need to remember. So in hemodialysis, which we also regularly do the intermittent hemodialysis, it follows the diffusion method of solute clearance. Okay. Now, what are the characteristics? So this you need to remember because you should write the prescription whenever they ask for a CVV HD. So what are the blood flows that you keep for a patient of CVV HD? It is 80 to 150 ml per minute. And for all CRRT patients who are undergoing, the anticoagulation of choice would be your RCA, regional citrate anticoagulation. Okay. And how will you calculate the dose in CVV HD? It is the sum of dialysate plus the ultrafiltration rates. Okay. Dialysate plus ultrafiltration rates. Okay. So some examiners might actually show you this and tell what type of modality of CVV, CRRT which has been shown. So whenever there is a dialysate, that is a CVV HD. Okay. Now coming to the hemofiltration. So hemofiltration means it is convection. Okay. So in convection, you will require a relatively higher blood flows. That is around 200 to 300 ml per minute, nearly the double of your CVV HD. Okay. And here, what is your dose that you calculate? How do you give your effluent rate here? It is the replacement fluid, which is pre-dilutional and post-dilution. along with your ultrafiltration rates. So there is no dialysate in CBBH. It is only a replacement fluid that is present. Okay. So now this replacement fluid, most of the guidelines suggest that, as I told, it is pre-dilution and post-dilution. So the pre-dilution is 1/3 and the post-dilution is 2/3. Okay. So in CBBH, so you don't have a dialysate here. You have a substitution fluid which is given your pre-filter and the post-filter. Okay, so this is the hemofilter here. So pre-filter 1/3, post-filter is 2/3. Okay. Whereas in your CBBHDF hemodiafiltration, you will have both together. You will have a dialysate and you will have your substitution fluid, which is divided into pre-filter and post-filter. Okay. So just remember these diagrams and how to calculate the dose. Okay. So what is important for us when they ask about CRRT prescription? One is the dose of exchange. That is nothing but your effluent rate. So when they ask how to write, so I'm going to give an effluent rate, or I'm going to remove the effluent rate of this much. Okay. And you will give a replacement fluid. Okay. You should mention about the blood flow and you should mention about your ultrafiltration rate. Okay. So as I told, the treatment dose, it is known as effluent flow, and usually the KDIGO guidelines recommend that it should be 20 to 25 ml per kg per hour. But when you calculate, actually it is around 25 to 30 ml per kg per hour, because a lot of losses, interruptions can happen, treatment interruptions can happen, because you have to move to the patient to MRI seat, whatever it is. Okay, because of that, so the effluent flow rate which you need to remove is, just remember it as 25 to 30 ml per kg per hour. Okay, that is the dose effluent rate that you need to remove here. Okay, blood flows I've actually mentioned, so we'll directly go to so here last time we have discussed about a 60 kg patient. Can you people now calculate for a 50 kg man the dialysis CRRT prescription for CBBH and CBBHD? You can calculate it and put it in the chat box. So take it as 30 ml per kg, because for calculation it would be easier. So for CBBH, so please give me the prescription. Okay, so for a 50 kg person, take your effluent rate as 30 ml per kg per hour, and you give me the prescription for CBBH first. So CBBHD, Soumya. Okay. So blood flow is, okay, 80 to 150 ml, 100 to 150 ml per hour. Dialysate is 1000 ml, and effluent is 30 ml per kg per hour. Okay, Soumya, how did you get your dialysate here? So you calculated first for CBBHD. So even CBBHD for a 50 kg man, it is, so your effluent rate will be around how much? So 30 into 50. So that is 1500 ml. Okay. Soumya, can you tell me? So 750 dialysate and 750 ultrafiltrate. So it is 50% of dialysate and 50% of ultrafiltrate. So how do you calculate ultrafiltrate for this patient? It should be per hour calculation, because we don't know till how much is your CRRT going on. For 24 hours, 48 hours, I don't know. So whenever you're giving prescription for your CRRT, your ultrafiltration rate should be per hour, ml per hour. Okay. So anyways, we will discuss it. Okay. So before going that, how to remove the ultrafiltration, how much to keep the ultrafiltration is very, very important. So for a patient, okay, who is having a positive, or you want to keep the patient little positive fluid balance and you don't want to remove any fluid, you can keep your ultrafiltration rate as 0. The the ultrafiltration rate should be 0. But for those patients, okay, whom you want to maintain at a uh, null balance, okay, so you don't want to remove much, okay, but you don't want to keep the patient more negative also. In such patients, you can keep a minimum ultrafiltration rate between 50 to 100 ml per hour. So if you're going for 24 hours of CRRT, it will be nearly 2400 ml of ultrafiltration will be removed. So you can't directly mention as 750 of ultrafiltrate, I'm going to remove in 24 hours. Okay. In a patient whom you want to have a negative fluid balance. So in ICU, most of the patient requires a negative fluid balance. So just mention your ultrafiltration rate as 100 to 200 ml per hour, depending. Okay, so this is the ultrafiltration rate you need to keep for a patient. Now here it is a 60 kg man. So now first we will go to the CVVH. So most of the people will ask you CVVH because here you need to divide it into the replacement fluid. Okay. So you should write like this. You should mention about the blood flow. You should mention about the ultrafiltration, anticoagulation. Everything has to be told. Okay. So in CVVH for a 60 kg person, as I told, the dose is 25 to 30 ml per kg per hour. Okay, so it will come around 1.5 to 1.8 liters per hour, right? 25 into 60 is 1.5, 30 into 60 is 1.8. Okay. Second, as I told in CVVH, the effluent flow is nothing but the replacement fluid plus your ultrafiltration rate. Okay. So first in this, you remove your ultrafiltration. So okay, if you want to take it as 1.8 liters, remove 100 ml per hour from that. Okay, so the remaining will be around 1 point. How much it will be, the remaining? 1.7 liters. That 1.7 liters should be divided as a replacement fluid. So 1700 into 1/3 of it and 1700 into 2/3 of it in the post dilution. Understood whatever I'm telling? Okay.
Can you please repeat it?
Okay. So this effluent flow rate you understood, right? Till CVVH. So it is replacement fluid plus ultrafiltration rate. This you understood, right?
Yes, ma'am.
Okay. So now first is you need to remove your ultrafiltration. So here we are planning to remove around 100 ml per hour. Right? Okay. So in 1.5 liter, you remove 100 ml for UF. Okay. So how much will be remaining here in 1.5 minus 100? 1400 ml is remaining, right? This remaining 1400 ml is nothing but your replacement fluid. So this replacement fluid has to be divided pre-filter and post-filter. Okay, so as I told, pre-filter it is 1/3, post-filter is 2/3. Right? You have to divide your replacement fluid like that. So 1/3 into the replacement fluid, that is 1400. You might get around 420 ml. Okay, and post dilution 980 ml. That is 1400 into 2/3. You will get around 980 ml. Okay. Understood? I mean, don't
Ma'am, what
calculate. I'm just telling it is a near calculation which I'm telling you.
if ultrafiltrate 100 ml per hour for 24 hours, it will come around 2.4 liter, right, ma'am? How, like, what are you saying, 1.4 liter?
This is all in hours, ma.
Uh,
Everything is an hour you're going to calculate. You can't calculate, you can't calculate for 24 hours. Your CRRT might stop in between 18 hours.
okay, okay.
Okay, so your ultrafiltration rate or your replacement fluid, everything will be in hour. Okay, you can't calculate like your intermittent hemodialysis. I'm going to do for 6 hours, so I'm going to remove around 1.5 liters for 6 hours. No. Okay, it is per hour because suddenly something happened, it got clotted or clogged or anything. So you might complete only 16 hours. So you will be not achieving the proper ultrafiltration that has to be removed for this patient, right? And if your replacement fluids are not measured properly, then patient might have a seizure because of hypocalcemia, or there could be hypomagnesemia, okay, or there could be citrate toxicity. Everything can happen. So everything, whatever you are doing in CRRT is measured for per hour only. Okay.
Okay.
So UF here is 100 ml per hour we have taken. Okay. So your effluent flow, as I told, will be the addition of both of these. Okay. So first UF, you write it off. Okay. So UF is 100. The remaining will be, if you're taking it as 1.5 liters, your replacement fluid will be 1.4 liters. If it is 1.8 liters, your replacement fluid will be 1.7 liters plus 100. The entire thing will be 1.8. Understood?
Yes, ma'am.
Now you have to divide that replacement fluid. If it is 1400 or if it is 1700, your pre-dilution will be 1/3 of your value which is remaining, that is 1400, and post dilution will be 2/3 into 1400. So that's how you divide it is into pre-dilution and post-dilution. Understood?
Yes, ma'am.
Okay. So that is about your replacement fluid. Ultrafiltration, you have already told it. So blood flow, as I told, it will be 200 to 300 ml per minute here, and your anticoagulation will be your regional citrate anticoagulation. So this is how you give your CVBH prescription. Okay. In the same way, the dialysate flow also you can adjust similarly here. Okay. So first calculate your ultrafiltration rate, and the remaining will be your dialysate flow rate. So here there is no pre-dilution, post-dilution, so you need not to divide it. So you can directly tell it. Okay. This is how most of the books have been given. But certain books have told that your dialysate flow rate can also be adjusted based on this 15 to 25 ml per minute. Okay. If you can remember this, you remember. Otherwise, you better tell that the remaining 1400 will be my dialysate flow rate here. Okay. The only difference between these two is your blood flow. The blood flow will be 80 to 150 ml in CBBHD. The others will be the same. So if you're planning to remove more of the ultrafiltration, so depending upon the patient's positive balance, so then you can remove till 200 ml per hour also. Okay. So if you're planning here 200 ml per hour, then here, if you're taking as effluent flow as 1.5, so the replacement fluid here will be around 1500 minus 200 will be 1300. And this 1300 should be divided into pre-dilution and post-dilution. So 1300 into 1/3 is pre-dilution. 1300 into 2/3 will be your post-dilution. Understood? If not, please ask, because this is a very important thing, the prescription they might ask you.
Ma'am, how will we decide upon whether we have to take 25 or 30 ml per kg dose, ma'am?
No, anything you can take, not a problem. For an easy calculation, you take it 30, because 60 into 30, 1800, it will be easy for you to calculate. So you can just mention there.
Okay, ma'am.
While telling, see, the effluent flow rate for this patient, the usual dose I keep is 25 to 30 ml per hour. So for a 60 kg man, I would like to take 25 ml per kg per hour. Anything is fine. They just want you to know whether you know the concept of CVVH and CVVHD. That's it. Okay. And if you can tell that, yes, 2/3 and 1/3 of pre-dilution also, they are happy. Okay. So if you people are okay, then I'll go to next slide. Otherwise, please ask. Okay. So CVVHD is a little more complicated. I don't want to confuse you people. At least remember both of these. Okay. And usually if you tell one of this, it's more than enough. Okay. Either CVVH you tell or CVVHD you can tell. Okay. But you have to write in this pattern only. Okay. So that is about the prescription of CRRT. Now, complications, yes, as you told, the complications could be early or late, whatever you want to tell, or you can tell us vascular access complications, infections, anticoagulations, okay, fluid removal complications. So, however, whichever way, but make it in a specific pattern. That's it. So, when they listen to you, they should be happy. Yes, you are going in a systematic way. That is very important. Now, can anyone tell me what is this? What are these cannulas representing?
ECMO cannulas.
Very good, very good.
ECMO.
Okay, ECMO, very good. So, do you people practice ECMO in your institutions?
Yes, ma'am.
Okay. So, I think a detailed class about this theoretically has been taken by Dr. Srihari. So, please go through that. It is a very, very important topic. Okay. So, whenever you pick up a ECMO cannula, okay, so you're going to tell about the indications of ECMO. Okay. Specifically for us, it is VV ECMO. So try to tell VV ECMO indications. And if they want to know the VA ECMO indications, then a lot of VA ECMO indications are also present, like a weaning from cardiopulmonary bypass after cardiac surgery, a bridge to cardiac transplantation, acute myocarditis, intractable arrhythmias, post cardiac arrest, your ECPR, okay, pulmonary hypertension, or your beta blockers and calcium channel blockers which are not responding to your conventional therapies, pulmonary embolism, okay, in cardiac arrest, everywhere VA ECMO is the one which we are using. VV ECMO, I think most of you all know the indications for VV ECMO. So coming to the contraindications, okay. So contraindications, you have absolute contraindications and relative contraindications. Absolutes are advanced age, more than 75 years. Okay, there is something known as frailty score. Okay, so that if it is more than or equal to 3, then ECMO is an absolute contraindication. If the patient is on mechanical ventilation for more than 10 days, this is for VV ECMO. Significant underlying comorbidities, MODS, CVA, coagulopathy, and inability to accept the blood products, all these are absolute contraindications of ECMO. Relative are, as I told, advanced age more than 75. Here, relative contraindication is age more than 65, immunocompromised status, and obese patients. So, this is one of the beautiful slide which will tell about the different complications of VA ECMO and VV ECMO. So, you can tell same cannula related complications, okay, technical or non-technical complications. So most of your that cannula related complications you can tell for VV ECMO. Can anyone tell me 2 specific complications of VA ECMO? Specific complications.
Harlequin syndrome, differentiation syndrome.
Okay, Harlan syndrome or the North-South syndrome. The other one is? The other one?
LV distension.
Very good. LV distensions. Perfect. Okay, so please remember these 2 are specific complications for your VA ECMO. Okay, and some might ask for Harlequin syndrome what you do. Okay, how to solve the issue. Okay, so please go through that theoretical part because I can't discuss everything here. Okay. So trials for ECMO, there are lots of trials for VA ECMO, VB ECMO. These are the trials I've just mentioned. This includes everything. VA ECMO and VB ECMO, ECPR, all the trials. Okay, so just name of the trials I have mentioned. So important trials, at least you have to remember your Caesar, Eolia trial, okay, your Inception trial, okay. For ECOR, it is the Supernova trial. Okay, so please remember at least one name for each of it. Okay. So what is this? I think
Magnet for
Temporary pacemaker machine with the magnet and pulmonary catheter with the
okay,
pacing
temporary pacemaker. What type of temporary pacemaker?
trans
That you need to tell.
transvenous.
Transvenous, correct. Okay, so whenever you're telling, don't tell it as temporary because temporary could be transcutaneous or transvenous. So it is a temporary transvenous pacemaker. Okay, so the way you tell no, the examiner should be impressed. They should not ask again, okay, now what type of this, whether it is transcutaneous, transvenous, no. That's why I'm telling, whenever you're prepared, prepare for 15 instruments in a proper way. Okay, the examiner should not ask you in between any question. Okay, that is how you're going to pick up. Okay, I know these are very difficult instruments to be picked up because you're going to get a lot of questions in this. So can anyone tell me the indications for transvenous pacing? I think it is a little bit difficult theory part, a lot of theory part. So these indications are actually divided into class 1. Okay, that is the absolute indications and the class 2 indications. So class 1 is your symptomatic bradycardia. Class 2, the other one is the complete heart block with or without symptoms and your symptomatic second degree heart blocks. Okay, so these are the class 1. The remaining would be your class 2 classifications. Okay, so you should know about the indications, contraindications, okay, and some definitions. So they will ask 3 important definitions. So what is sensitivity, what is threshold, and what is output? And some examiners may even ask you to tell how to adjust each of it. Okay, so please go through all those things whenever they are giving a pacemaker. So indications, contraindications, anyways you're going to tell of the pacemaker. Okay, so what is sensitivity? Definition when they ask. Okay, so it is a minimum current at which your pacemaker is able to sense the intrinsic rhythm. Okay, that is your sensitivity. It is usually expressed in millivolt. The lower the number, more sensitive the pacemaker is. Okay. Second is your threshold. So what is threshold? It is the minimum pacing output which is required for the pacemaker to capture. In other words, it is the minimum pacing output at which an action potential is generated which leads to a myocardial contraction. That is your pacing threshold. Identification of your intrinsic heart rhythm is your sensitivity. Generating an output is your pacing threshold. And what is pacing output? So it is nothing but the current. The current with which it produces a brief pulse. That is your output. Okay, so how to adjust it? It is a little bit complicated and it is big also. So try to read it in the books or listen to some YouTube videos which will make you understand better. Now, yes, they will ask you about the revised NAPC code. Okay. So 1, 2, 3, 4, 5. So please go through this generic coding also. So the next one would be your ICD. So they can keep your ICD tubes, okay, and your drainage. So what are the questions that they usually ask here? Indications, contraindications, okay, and important thing is your drainage system, okay. So can anyone tell me what is your double and triple drainage system? So when is your double used? When is your triple used? What is the function of it? Actually, I was the last batch for FNB. So they literally asked me to draw the triple drainage system. Okay, so they wanted where the tube ends, where the second tube, where the positions, everything. Okay, so you should know the diagrams properly. Okay, for FNB only they were asking. I don't know for DRNB. It's becoming more clinical nowadays. Okay, so you please be ready to draw most of the graphs. Okay. So someone answered something. Drainage, water seal, and suction. Okay, that is a triple lumen. Good. So indications, I think most of you all know the indications for ICD. Yes, your bottle systems, under drainage water systems is very, very important. So the first one system is only for the drainage bottle. Okay, so you see where are the tubes starting from, at which level, where is it ending? Okay, everything they wanted. Some examiners want. I can't tell, yes, they will ask, but we don't know. Okay, so in a two bottle system, one is first the bottle will be a drainage bottle, the second will be a suction bottle. Whereas in the third, you have a drainage bottle, suction bottle, in between you have your water seal bottle. Okay, so just try to practice this while just drawing. Okay. So complications, so we have all the organ injury complications, okay, wherever, whatever are there around that, gastric, bowel, hepatic, splenic, diaphragm, anything can be injured, okay, pneumothorax, anything can happen. So technical, yes, tube dislodgement, non-functioning of the tube because of kinking, clotting can happen. Physiological complications, the most common is your re-expansion pulmonary edema, and infectious complications, we all know that. Okay, so this is a very, very rare one. So last time they told just to mention about this. So this is basically an Arctic sun, okay, which is a temperature management system. Okay, so why I've kept this is they might keep any of your warmer or your cooling system, and they might ask your targeted temperature management. So please be prepared for your targeted temperature management, when to do it, okay, what should be the temperature, how to rewarm the patient, everything is important. Okay, so this is all been discussed in your theoretical part. So you can just go back to all those slides or the notes which you have written. So Arctic Sun is basically a non-invasive targeted temperature management system. So what they do is they will attach some pads. Okay. Okay. Pads, they will be attached wherever, in whichever part you want. Need not to cover, like in our warmer, we will cover entirely. Or if you want to immerse the patient in the cold water, the entire body will be covered. Here that is not required. You can apply the chilled pads at some parts of the body, and then you can adjust the temperature. So the temperature adjustment can be between 4 to 42 degrees centigrade. Okay, and you adjust the temperature, and those pads will manage the entire body temperature. That is how your Arctic Sun works. Okay, so as I told, it is very important to read even for your practicals about the targeted temperature management. Okay. And coming to the other instruments which I have not discussed is your endotracheal tubes. Most of you all know it. They might ask about your nasopharyngeal, oropharyngeal airways. Bougie can be kept. Foley's catheter can be kept. Okay, Foley's catheter, and they might ask your measurement of intra-abdominal pressures. Okay, so please, you should know about that. Different IV cannulas and your IV sets and blood transfusion sets. They keep a blood transfusion set, and they might just discuss about everything about your blood transfusion. Okay. So these are the other instruments which are present. So please go through it. Now, any doubts you can put it, discuss it. So next is your ABG, very, very important. Okay. So what is the time now? It's already, okay, till around 7:30, I'm going to discuss it. Okay. So I've actually around 20 ABGs to be discussed, but I think 20 ABGs would not be possible. So as much as possible till 7:30, I'm going to discuss it. Okay. So please have a paper, pen in your hand, and you are the one who are going to tell me the answers. Okay. So this is how you practice it. Okay. So can anyone just go through this question and interpret the ABG here? I'm going to discuss the theory part after this question, but I just wanted to know how many of you all know how to solve it exactly. Take some time. Okay, they might even keep Ribova, Anaconda. Might be Ribova. Yeah. Hagma with compensation. Any other answers? Okay, I think you need some time to calculate, so please calculate and then put it in the group. So I request how many members here? I don't know, some 32 members I'll be able to see. So at least 30 members, please calculate it. Then only you're going to learn. You need not to revise again in the last moment. Oh, I don't know ABG, I should practice ABG. Okay, so you have 30 people here to discuss the ABG. So one person might answer something, one person might answer something. So you will actually learn. Hagma, HHS. Okay. So Shriram and Deepak, so still after compensation, Deepak, you stopped. There is a lot of thing after for metabolic acidosis to be done. You should calculate the anion gap, you should calculate your delta delta gap, and then you have to give me the entire answer. Okay, Hagma with respiratory acidosis with Nagma. Okay. Okay, this seems to be a little better. Okay. So I wanted an interpretation of the ABG with the diagnosis. Okay, so there is metabolic acidosis with respiratory acidosis plus Hagma plus I told interpretation of ABG. There are other things which they have given here. So there is hyperlactatemia with creatinine of 4 AKI. And the most probable cause is HHS. So this is the answer I'm actually expecting. Okay. Now we'll go to the steps. So most of y'all have just did the compensation and you have left it. So yes, Bhavesh, good. Pure Hagma with respiratory acidosis. That's very good. Hagma with respiratory acidosis with delta gap more than 1. Okay. So this is how you need to calculate it fully and tell. Okay, just don't tell yes, acute metabolic acidosis with some respiratory compensation. There could be a mixed underlying disorder also, which we don't know until we calculate the final step of delta-delta gap. Okay. So the first step, most of them will not ask whether the ABG is proper or not. So it is corresponding. Is it correct or not? So the first step is to check for the consistency of your ABG, and that can be done by using your modified Henderson's equation. Okay, so your modified Henderson's equation is nothing but your H plus into bicarbonate divided by your PaCO2 should be 24. So in the other way, you need to calculate your H plus ion. So how do you calculate H plus ions? It is 24 into your PCO2 divided by your bicarb. This is the first way of calculating your hydrogen ions. The second way of calculating your hydrogen ions is, okay, suppose if the pH is 7.23 in an ABG. So you take the last two digits, okay. So 80, it is a fixed one. 80 minus whatever the last two digits, decimal points, your pH is, you minus from that. So that will be your H plus ions. This is a second way and an easy way of calculating your H plus ions. The third way is, there is one a pH table. Okay, so pH and the corresponding H plus ion concentration. So this is only practical if you have the pH table. Okay, so very cumbersome, but this will give you the exact value of your hydrogen ion concentration. So three ways of measuring your hydrogen ion concentration. One is by your Henderson's equation. Second is the decimal point. Third one is your table. Okay, to see whether the ABG is actually correct, the accuracy of ABG. So you try to see your Henderson's equation, what is the H plus ions, and with this formula, what is the H plus ions, and it should be equal. If both are equal, then you can tell that, or nearly equal, you can tell that the ABG is accurate enough. Okay, so that is the first step. Usually most of them won't ask you about the first step, but you should know it. Okay, how to check for the accuracy of the ABG? You should know that you are going to use your modified Henderson's equation and calculate it. Okay, that is the first step. Now, second step, you cannot interpret an ABG without knowing the clinical relevant history. Okay, so please obtain a history before actually concluding or interpreting your ABG. Okay, the third is, you should look about the oxygenation status of the patient. So we all directly go for your metabolic acidosis or respiratory acidosis. No. So the third step would be to look at the oxygenation status of the patient. See what is the PaO2 of the patient, and also see what is the PaCO2 of the patient. So first comment upon that, whether patient is hypoxemic, hypercarbic, please see that status. Okay, so you should see the third step is your oxygenation and your ventilatory status. Okay, so depending upon your oxygenation status, you can tell mild, moderate or severe hypoxemia depending upon your PaO2 levels. Okay, so normal it is 80 to 100, mild 60 to 80, moderate hypoxemia 40 to 50, 40 to 60, and severe is less than 40. So that is your third step. Now coming to your fourth step is your acid-base status. So here you're going to see your pH, PaCO2 and HCO3. And remember your mnemonic, that is your Rome. So respiratory is always opposite and metabolic is always in the same direction. Okay, so I think primary everyone will identify it. So that's not a problem. So in a normal ABG, you should know these two directions. Okay, your pH and PaCO2 always move in the opposite direction. Okay, in a normal ABG. And your bicarbonate and your PaCO2 usually move in the same direction. Okay, why I'm stressing upon this thing is, in a mixed disorders, this can change. Okay. So whenever the pH and the PaCO2 change in the same direction, then the primary problem is metabolic. This you don't worry. Anyways, primary problem you know. But in a mixed disorder, your bicarbonate and your PaCO2 can change in opposite direction. Okay. Then the problem comes. What is that I'm telling is, so in this, okay, now you got a example here. pH is 7.25, bicarbonate is 16 and PaCO2 is 60. Just write it on your paper. pH 7.25, bicarbonate is 16 and PaCO2 is 60. Okay, now can anyone tell me what is the primary abnormality here?
Metabolic acidosis.
Okay, how do you tell it is metabolic acidosis? It could be even respiratory acidosis also, right? Right, it can be, right? It can be. So that is where you will be in a confusion. So here you need to check something different. This is a new thing, okay? So if the trend of change in PaCO2 and bicarbonate is the same, okay, then you should check the percentage difference. So here, seeing this ABG, I can say this is a metabolic acidosis or it is a respiratory acidosis. So how to tell which is what? The primary is what? Then only I can calculate your compensatory mechanism. Without knowing primary, I assume that this is metabolic acidosis. I can't tell your compensatory. It could be wrong. Okay, in such situations, you need to calculate the percent difference. What do you mean by that? So you should first calculate your bicarbonate percent difference. That is, the normal value is 24 of bicarbonate which we take, right? So 24 minus the given bicarbonate, that is 16 whole divided by 24. So this will come up to 0.33. Now similarly, you have to take the PaCO2 percentage difference. So PaCO2, the normal will be around 40. So here 60 minus 40 divided by 40. So here it is 0.5. So whichever the percentage difference is a higher number, that is your primary disorder. Now, when you calculate the difference, here it is 0.33 for bicarbonate. For PaCO2, it is 0.5. So 0.5 is the higher number. So the dominant disorder or the primary disorder here is a respiratory acidosis and not a metabolic acidosis. Understood? So if anyone didn't understand, let me know. I will again repeat it. Okay, so whenever there is a confusion between which is the primary one, usually you will not be confused, but in mixed disorders, we don't know which is the primary here. So in such situations, you need to calculate the percent difference. Okay, so separately you need to calculate the percent difference for your bicarbonate and for your PaCO2. Okay, and when you get the value, the highest value which you get will be your primary or the dominant disorder. Now this is a respiratory acidosis. Now you can calculate the compensation for that. Okay. Okay, so you will understand it when I'm actually giving one example for that, for the ABG. So there you will understand it, okay? So this is in cases of a mixed disorders where you have a confusion, okay, whichever. So this is about the primary part. Now next comes we'll go for your respiratory disorders, okay? So after the primary disorder is established as a respiratory, then you need to see 3 points, okay? Usually you see the compensation point, right? Okay, so if it is an acute respiratory or a chronic respiratory, you use your values of 1, 2, 4, 5. Okay, and then you'll tell the compensation. So that is not enough. For any respiratory disorders, you need to calculate two more things. One is your AA gradient. So if they provide you the FiO2, please calculate the AA gradient. They expect you to calculate the AA gradient when any FiO2 is mentioned in the ABG. Okay. Second, the rate of change in H plus to change in PaCO2. This is usually calculated to know whether this respiratory acidosis or alkalosis is an acute one or a chronic one. Yeah, sometimes you see, while seeing the history, you might tell that yes, this is a COPD patient. So this is a chronic respiratory acidosis. But this patient might be a controlled COPD patient, and because of an infection, there could be an acute one. So it could be an acute on chronic also. Okay, so you should know whether it is acute or chronic, then only you can calculate your compensation. Okay, so these are the three things you should know while calculating your respiratory disorders. I know it is complicated enough, but these are the ones which you should know at your level. Okay. So at a PG level, whatever we do, that small things are okay. But for a DRNB, you should know all of these. Okay. So how to tell whether the patient has an acute, chronic or acute on chronic respiratory disorder? Okay. So for that, you have a formula. What is that formula? Delta H plus. So please write all these formulas which I am telling in one paper, so that while solving these questions, it will be helpful for you. Otherwise, again, I need to go back and show you the slides. Okay. So to know whether it is an acute or a chronic respiratory disorder, the formula used is delta H plus divided by delta PaCO2. Okay. So how do you calculate your delta H? It is measured H plus minus 40. So your measured H plus can be any of the three things which I showed you initially. So you can measure using your Henderson's equation, you can measure using this formula, or you can measure using the pH. So in your exam, I think the better would be by using this one, right? Okay. So that will be your delta H. So if in that answer it was 37, so 40 minus 37, it will be 3. And your delta PaCO2 will be your measured PaCO2, which is given in your ABG, minus the 40. So when you divide it, both of it, if the value comes less than 0.3, then it is chronic. More than 0.8, it is acute. If it lies between 0.3 to 0.8, then it is acute on chronic. Okay. So this is how you actually calculate whether the patient has an acute respiratory acidosis or a chronic respiratory acidosis, or acute respiratory alkalosis or a chronic respiratory alkalosis. Then only you can use your compensation formula. Got it? So remember this formula. I'll go to the next slide. Then you need to calculate your AA gradient. Okay. So everyone remembers the formula for AA gradient? Okay. So basically your AA gradient is PaO2 minus your PO2s. Okay, your PaO2 is very important, that we need to calculate. So the formula for your AA gradient, please write it in your paper. It is FiO2 into your barometric pressure, which is usually 760, minus your water vapor pressure, which is 47. So just it is 760 minus 47. So this value comes as 713. Okay, so just remember that 713 value. Okay, your FiO2 might change. Okay, so please put it as not in a percentage. If FiO2 is 50%, it is 0.5 that you need to mention here. Okay, so FiO2, you got it. This will be fixed 713. Your PaCO2 will be changing, and your respiratory quotient is usually 0.8. Okay, when you get this value, you have to minus this with your PaO2 values. Then you will get your AA gradient. Okay. So normal AA gradient is between 10 to 15 mmHg, and this gradient may increase with the age. Okay. So just remember the value 10 to 15 mmHg. Okay. So I don't know whether I have so much of time to explain to you. Okay. So anyways, so this is a flow diagram which is showing how to approach a patient who has a hypoxemic respiratory failure. So any patient with hypoxemic respiratory failure, you should see, first you see the PaO2s, if you know that it's a hypoxemia. Second, you need to see your PaCO2. See whether your PaCO2 is increased or not. If your PaCO2 is not increased, then the cause is secondary to your PaCO, your hypoxemia is secondary to your hypoventilation. Okay. Then you please calculate your AA gradient. If the AA gradient is increased, then it is hypoventilation plus any other additional mechanism. If your AA gradient is not increased, then it is pure hypoventilation alone. And that could be secondary to your decreased respiratory time or neuromuscular disease. Okay. Now, suppose if your PaCO2 is increased. Okay, that is I told it is hypoventilation. If it is not increased, still you need to calculate your AA gradient. If your AA gradient is increased, then you have to give some oxygen and see whether your PaO2s will improve or not. Okay, so AA gradient is increased, and even with oxygen, your PaO2 is not increased, then the hypoxemia is secondary to shunt. Okay, your AA gradient is increased, and after giving some oxygen, your PaO2s has been improved, then that is secondary to your VQ mismatch. Okay, so in any case, please calculate your AA gradient. Okay, and this is how after calculating the AA gradient, you're going to approach for your hypoxemic respiratory failure. Okay, next comes your compensation. So I'm not going to discuss anything in detail except your Boston because I don't have time to discuss about your Copenhagen and Stewart. Just the examiner might ask what are the different levels of compensation, different methods you can do is, one is your Boston, which you usually do in your exams. The others are your Copenhagen and your Stewart's approach. Okay, your Boston compensation is only bicarbonate based compensations that you need to remember. Okay, so the Boston method has a 6 bicarbonate based bedside rules to assess your compensation. So I think everyone knows acute chronic. Okay, so for acute respiratory acidosis, it is 1. Acute respiratory alkalosis 2. For chronic, it is 4 and 5. Everyone knows this, so I don't want to discuss much about this. Metabolic acidosis, you know the Winter's formula, 1.5 into bicarbonate plus 8 plus or minus 2. For metabolic alkalosis, so everyone knows this formula, 0.7 into bicarbonate plus 20. Okay, so for me 0.7, this calculation would be difficult because you will not be getting any calculator over there. So there is some modification in for the metabolic acidosis which is given by Morgan. It is easy, 0.9 into bicarbonate plus 9. Okay, so easy to remember, 9, 9 and all. So whichever formula you're perfect with, please remember that formula. Okay. And one more thing which you remember is when you get an ABG, so there will be 2 bicarbonate values, right? Standard bicarbonate and the actual bicarbonate. Okay, so the bicarbonate which is used when you are doing your Boston's method, so it is your actual bicarbonate which you need to see. Okay, so that you have to keep in mind. So Copenhagen is basically, it uses 2 things. One is your PaCO2 values and the other thing is your standard bicarbonate excess. Okay, just remember that. And your Stewart's approach is the most recent, not most recent. So it's been used most recently. Okay, so in Stewart's method, you should remember 3 things. Okay, One is your PCO2, your ATOT, that is nothing but the total weak non-volatile acids, and important one is your SIT, that is strong ion difference. So it basically sees the independent variables and tells about your acid-base abnormalities. So at least remember what are the variables that are used in Stewart's physiochemical method. Okay. Strong ion difference. Okay. Now for metabolic disorders, yes, if there is metabolic acidosis, then you need to calculate your anion gap. So everyone know how to calculate the anion gap. Okay. So if you're calculating your potassium also in your anion gap, then the normal range ranges from 12 plus or minus 4. If you're not considering your potassium, the range is between 8 plus or minus, I'm so sorry, it is 12. 8 plus or minus 12. Okay, just, I mean 8 plus or minus 4. Okay, so 12 plus or minus 4 and 8 plus or minus 4, depending upon the potassium. And you should know the causes. Whenever they ask about the causes, you tell yes, the patient has metabolic hagma, nagma. You all should know the causes of high anion gap, metabolic acidosis. So mud piles is the one, I think everyone knows it. So for normal anion gap, it is hard up. Okay, so not going to go with each of the causes. Most of you all know this. So just remember the causes. And low or negative anion gap, there are some causes. The mnemonic is LIMS, that is low albumin or lithium, iodide, myelomas, bromide toxicity, or salicylate overdose. All these can cause, even salicylate can cause a low or negative anion gap metabolic acidosis. And one more thing you need to remember is your corrected anion gap if there is a hypoalbuminemia. Okay, so that value they might ask you, so you need to remember this. So you need to add 2.5 to the anion gap which you get for every 1 gram per dl of albumin below 4 grams. Okay, so if your albumin is around 2 and your anion gap is around 12 which you got, okay, so 12 is basically a normal anion gap, but your albumin here is 2. So when you correct it, okay, so 2.5, albumin is 2. So 2 gram below will be 2.5 into 2, 5. So if it's 12 plus 5, it will be 17. So you will get a high anion gap metabolic acidosis. Okay, so please remember this value. So for every 1 gram below 4 gram, that is 3 gram ke liye, you should add 2.5 for your anion gap. For 2 gram below, it is 5. Okay, so 12 plus 5 will be 17. Okay. So now comes your delta ratio. Okay, so delta gap, that is delta anion gap divided by delta bicarbonate. So please remember this values. This is very, very important. Okay, so less than 0.4, it is a pure normal anion gap metabolic acidosis. Okay, just write it in a paper. Less than 0.4, it is pure nagma. 0.4 to 0.8, it is mixed nagma plus hagma. Okay. Now 0.8 to 2, it is pure hagma, pure high anion gap metabolic acidosis. And if it is more than 2, then you have an additional component of metabolic alkalosis also. So hagma plus metabolic alkalosis. Okay. Please remember these values. Okay. So I think we will go for the ABG. Okay. So what's the time? Okay, it's only 15 minutes remaining. Please start. Please calculate it and let me know, ma. So describe the acid-base status, calculate and interpret the AA gradient, and what is your likely diagnosis? So what is the acid-base status for the first one?
So
Chronic
respiratory
respiratory
acidosis
acidosis with metabolic
with
compensation.
metabolic alkalosis,
Sorry,
with the
I think-
severe hypoxia, with the
Soumya, I'm so sorry, I
Probably
couldn't hear you once again. So acid-base status, what did you tell me?
so primary respiratory acidosis with the compensated metabolic alkalosis, with the severe hypoxia, and A gradient. I'm just doing.
So
A
Bhavesh has
gradient
written
is
as A gradient
30.
22.
30. A gradient is 30.
A gradient is 30. Okay.
White and
So what is your likely diagnosis?
chronic respiratory acidosis with metabolic compensation, ma'am. Probably
Mm.
OSS sleep times on
Okay, so what did you get A gradient in yours?
30. 70 minus 40.
Okay, so when I calculated, I got 33. Why are these fluctuations happening? Okay, 30 is okay, but I don't know, someone got 22. Okay, so acute respiratory acidosis with metabolic alkalosis, it is 0.3. It is 0.3. So what is the formula? What is the delta H you got in this patient? So 33. So 80 minus 33 will be?
47.
47.
Okay, 47. So your delta H is 47 minus 40, right? Okay. So measured you got 47. 47 minus 40 is 7.
7.
Okay. Now 7 divided by, so what is a bicarbonate, PCO2 there? 60?
64.
Okay, 64 minus 40 is?
24.
Hmm.
7 24.
So around how much it might?
0.29.
So 0.29 is less than 0.3. 0.29 or 0.28 it comes around. So this is a chronic one, not an acute one. Got it?
Yeah. Okay.
Okay. So this is a chronic one. So see, with little things also, for an acute, it should be more than 0.8. I don't feel this will come as more than 0.8. So your measured H plus is your decimal point minus 80. That is your measured H plus, which you told is 47. So for us, delta H is 47 measured H plus minus 40. Okay, don't keep it as 47. Okay, so 47 minus 40 is 7. So 7 divided by your 24 will come around 0.2 something. So it is less than 0.3, which is chronic. Okay. So now comes your compensation part. After deciding it is chronic. So most of you all told acute, so everything changes now. You people are understanding, right? So a lot of things are there actually. So it is not easy to calculate an ABG, which we were doing previously. So it is a chronic respiratory acidosis with metabolic alkalosis. If you calculate your compensation, your A gradient is nearly 33, which is above the upper limit even for your elderly patient. Okay. So your A gradient is increased. There is hypoxia. Okay. So as I told, if A gradient is increased and there is no PCO2 increase, you should go to the table again. So here your PCO2 is increased. There is hypoxemia and your A gradient is increased. Okay, so PaCO2 is increased, so hypoventilation is there. Your AA gradient is increased, so there is some hypoventilation plus another mechanism which could be either shunt or VQ mismatch for the cause of increased AA gradient and hypoxemia in this patient. Understood? It will take a lot of time to understand. Okay, I'll take one more class if possible. Okay, if you're okay with taking one more class, then I'm going to take for 1.5 hour more. Okay, if you solve all those 20 ABGs or at least minimum 10 ABGs, you will become perfect. I'm sure about that. Okay, so this is the last second ABG. I'll continue it for the other class. So please calculate this and let me know. Okay. So what is the primary abnormality here?
Primary metabolic alkalosis
Okay.
with appropriate respiratory compensation.
Okay. AA gradient.
17.
17. Okay. Any other thing, any other people who have calculated your AA gradients and any other answers?
Hypoxemia with a normal A gradient.
Hypoxemia with?
Normal A gradient.
Okay.
A gradient of 17 is
So I told in the aged people it will increase. So 17 for
Yeah,
them.
age by 4 plus 4 is normal in this case.
Good. So patient has primary metabolic alkalosis with respiratory acidosis. So you told there is a compensation which was there. Okay. So now the difference comes. So did anyone calculate it? No other people have calculated it?
Hypoventilation.
So did you take it as an acute metabolic alkalosis or a chronic metabolic alkalosis? Sorry, metabolic alkalosis. No, this is. Sorry. So metabolic alkalosis, you used that formula. So what was the compensation you got?
53 PCO2. Expected PCO2 of 53.
Okay. So 53, 56, there is some amount of metabolic acidosis also present.
56.
Okay. So it is increased. 56 it is. Okay, so 52 someone got. Yes. So there is some amount component of respiratory acid is also present. Okay.
Hmm.
And this is 17. So we are taking just a cutoff of around, it is just above normal. Okay. So could be secondary to only hypoxemia alone. Okay. As you told, it is 17 for that age. So it is a normal AA gradient. So the hypoxemia which this patient has is secondary to only hypoventilation.
Ventilation.
Okay. Okay. So shall we stop here? So let me know in our actual top in the WhatsApp group, when do you people want this ABG? Before that, you need to know about this theoretical part. Then only you will be able to solve the ABGs. So ABGs are not simple at all. Okay. So they will expect you all to calculate all these things at least. Okay, so you just tell me whenever you want, because I think all these 4 days are busy with the other schedules. So either next week or in the January first week, if you want, so that you will be able to remember it better, just let me know whenever to take it. Okay. So I think next Bhuvana will take it. Otherwise, I'll just put one ABG tonight in the group. So try to calculate it and put it in the group. Okay. Chalo.
Ma'am, one more.
Tell ma.
Ma'am, why this patient had this metabolic alkalosis? This is a COPD patient, no, ma'am.
Yes, yes. So that only. So could be secondary to all those things, reasons this they have mentioned here. I'm so sorry. I don't know why. Okay. So here they have not given any other information. Okay. So
Yes,
this
ma'am.
patient might be on some diuretics.
Okay,
Okay.
ma'am.
So that is causing the hypokalemia in this patient. Okay. Or this
Okay,
patient could be
ma'am.
on an acetazolamide COPD patient long term. Okay. So all these causes could have been causing the metabolic alkalosis in this patient.
Ma'am.
Okay. Okay, so just write all those formulas in a page. Okay, just stick it in your room and you have to mug those formulas. That's it. And when you practice the ABGs, then only you will be confident enough to solve over there. Okay, so the examiner will not give you 10 minutes, 15 minutes to calculate an ABG. Okay, so 3 to 4 minutes maximum, and you need to calculate all these things. Okay, so if any other doubt also, you can personally contact me in the WhatsApp. Okay, and I will definitely have one class to solve this ABGs. Okay, 20 ABGs, all the types of ABGs are included here, and it is, some of them are repetitive also, so it'll make you perfect. I'm sure about that. Okay, chalo, thank you.
Thank you, ma'am. That was an excellent class, extensive class. Even it was a revision to me.
Okay, Boon, I think you please start it. It's already
Sure,
half an
ma'am,
hour
sure.
late. Yeah, thank you.
That's okay, ma'am. Yeah. Good evening, guys. This is Dr. Bhuvi. Congratulations on passing the theory exam. Seeing the question paper, it is not a simple job. Congratulations. So I can see few of the names, Saumya, Joshna, Bhavesh are the very active ones. So I'm going to ask questions only to them then. Is it? Okay, can we start or you want a break?
I think let them have a break at least of 2 to 5 minutes. I think it was really, at least they were sitting till now.
Yes,
It's
ma'am.
actually
2
great.
minutes.
Yeah, and they were calculating very sincerely. That's great.
That's good. That's good. No, actually they were sincere with sir's class also. They were at least answering and all. Good.
Mm.
Okay, just
Mm.
take some 2 minutes break, drink some water, some snacks, and
Definitely,
then
definitely. Yes, okay. Soumya has answered, so I'm going to keep Soumya as the class monitor today. Okay, fine. So, good evening. So, we'll be discussing about few important stations. Navneet, you have started recording, right?
Yes, ma'am.
Okay, so we'll be discussing about a few important stations. These are important stations in a way that, like, suppose you take neuroprognostication, from here they go on to brain death. From there they go on to organ donation. Definitely, this will be a mandatory station for the OSCE. And number two, we will be discussing about ATLS, where there will be a case a presentation on ATLS. And thirdly, it will be a radiology, which it's a important station, which is a mandatory station. They cannot skip it. So this neuroprognostication post cardiac arrest is mainly based on 2025 AHA guideline. And similarly, ATLS will be the 11th edition 2025 updated guidelines. And finally, radiology, we'll see some of the important images, and we can have an interactive session where you can tell me the management, the findings, and all that. Okay, we'll try to keep it as crisp as possible. Okay, so first let us start with neuroprognostication. Can one of you tell me, like, what is neuroprognostication? What do you mean by that, and why do you do that? Why it is important to discuss about it? I'm not asking about the brain death. Okay, I'm asking about when do you initiate to talk to the patient's relative, as well as you as a physician make a clinical decision. It is going to give a favorable or an unfavorable outcome, whether the patient is going to have like what sort of outcome, why it is important, and why we are discussing about it. Can one of you tell me?
Ma'am, neuroprognostication so as to give an idea about the outcome of the patient. We can
Yes.
start it as early as possible. Sometimes patient may have myoclonus in the presentation itself.
Mm-hmm.
Then after 72 hours, we will take MRI and then prognostic tools, EEG, SSCT, and all, ma'am.
Very good.
So
very
that
good.
we can have an idea whether to continue with the treatment or not.
I understand. Good. So your answer is like 80% correct. Maybe few of the terms which you have to use to make sure the examiner knows the updated guidelines, as well as your clinical practice is good. That otherwise 80% your answers are right. Okay. So we'll be discussing about why are we doing neuroprognostication. So the main aim is that whether we are using a multimodal methodology to say that the patient is having an favorable or an unfavorable outcome, whether we are choosing a correct time for neuroprognostication. See, if yearly you are unnecessarily withdrawing the care which the patient deserves it, right? Or if late, you are unnecessarily wasting the resource and care which the patient does not need because he's out of everything. So the main aim of the neuroprognostication is that whether you are using a correct timing to define, to continue the life-sustaining therapy, or to withdraw the life-sustaining therapy. And are you using a single methodology or a multimodal methodology? What does the AHA guidelines say? And which methodology is better? Whether any methodology is better? In that way, we are gonna in those terms we are gonna discuss our lecture today. Okay, let us start with the case study, like a simple case study. So there is a 65-year-old male. He had a out of hospital cardiac arrest due to let it be ventricular arrhythmia, where CPR was continued, defibrillatory shocks given, ROC was achieved 25 minutes later. Okay, so on admission to the ICU, the patient remained comatose with a GCS of E1, VT, and M2. Okay, and even at 72 hours, despite normothermia, despite sedation, cessation, the patient GCS remained the same, like even VTM2. The pupils are 3 mm bilaterally, and they are sluggishly reacting to light. There is no corneal reflex. There is no motor response to pain. Okay, so we will be discussing which is the right timing, but can any one of you tell me, like the patient is post 72 hours, normothermia, GCS is low, few of the reflexes are absent, one of the reflexes is sluggishly reactive. So do you think, is it an appropriate time to start neuroprognostication to the patient, and what sort of neuroprognostication you'll do, like a favorable outcome or an unfavorable outcome? Can you answer this simple question, like any one of you?
We can first start performing MRI, because this is MRI brain, because post 72 hours, the ideal time for doing. Since the patient has low GCS with like no corneal reflex and no response to pain. And next thing we can also do an EEG and somatosensory evoked potential if it is available to look for absent N20. Then we can also do neuron specific enolase test. It's beyond 48 hours, so we can check for the increased levels of NSE.
Great. Okay, so as you suggested, yeah, you are approaching in a multimodal way. That's a very good answer. And secondly, the answer to the first question is yes, it could be a right time to start the neuroprognostication for an unfavorable outcome because 72 hours has passed post normothermia, and you are approaching in a multimodal way. Based on the results of the multimodal approach, we can start neuroprognosticating for an unfavorable outcome. That is how you should use your terminologies. But otherwise, Soumya, the answers were good, like great. So briefly, we will discuss about the AHA 2025 guidelines on neuroprognostication. I didn't had too much of a theory, like very simple terms, so that you need not revise like once and for all. We can finish it in the class. Okay. So as per AHA, neuroprognostication should involve always multimodal approach. Just because the pupil is not reacting, just because the corneal reflex is absent, just because there is no motor response, you cannot tell, yeah, I'm gonna start the neuroprognostication. No, you should always use a multimodal approach. There should be a combination of modalities, as Soumya said, whether it's let it be clinical, let it be electrophysiological, let it be neuroprognostication and neuroimaging based or biomarker based on the availability. You have to use a multimodal approach always to prognosticate, start the prognostication about the favorable or the unfavorable outcome to the patient relative. Okay. And the most appropriate timing as per the guidelines is 72 hours after normothermia. For example, if you treat a patient with hypothermia, as per the post cardiac arrest care, you have to maintain for 24 hours, right? And you have to start rewarming over 12 hours slowly every hour at a particular temperature reduction. You have to do it for 12 hours. So that only consumes 36 hours. So you are getting the patient to normothermia. When normothermia begins, more than or equal to 72 hours after normothermia will be a better window for a multimodal neuroprognostication for a patient. Okay, that is the gist. And when you start the neuroprognostication, it should be yearly. Like you can start immediately after the ROSC. You should be very transparent about the probabilistic outcomes. Like it could be, could not be, the patient may or may not have a favorable outcome. So, but you should start yearly, and your discussion should be more transparent, and it should be focused on like uncertainty, because we can't predict how after 72 hours the patient is going to react, right? So it should be focused on uncertainty, and we should explain clearly about the time frames that at this particular point of time, even after that, if there is no response, if all the modalities say it is a no-go, then we have to withdraw the life-sustaining therapy. So when you answer like, is it the right time to start neuroprognostication, you can start like, yes, I would like to start yearly discussions about it. I will be more transparent about it, but the appropriate timing would be more than or equal to 72 hours from the normothermia post ROSC. Okay. And the main problem, confounding factors with the neuroprognostication is that there are a few effects, either let it be from the medication, let it be because of the organ dysfunction, let it be because of the temperature effect, or metabolic factors. Mainly the clinical examination and the EEG could have confounding results. That is the reason we should not rely only on clinical examination, only on EEG to say we are having an unfavorable outcome, because these two can get a lot of confounding factors because of all of these reasons, right? And especially when it comes to medication, like the sedatives and the neuromuscular blockers may be metabolized more slowly in a post-cardiac arrest patient because of circulation, because of excretion, retention, whatsoever reasons, right? And injured brains may be more sensitive to the depressant effects of various medications, and residual sedation and paralysis can confound the accuracy of clinical examination. That is why, even as per the guideline, even I went through some of the studies to say any particular timing is there for sedative clearance so that I can say I can start the neuroprognostication. No. If you see organ donation, brain death, yeah, they would have mentioned 5 to 6 half-lives of the sedative agent. But when it comes to neuroprognostication, they usually mention an appropriate sedative clearance. There is no particular window because of the cardiac arrest, because of the circulatory effects, hemodynamic effects, if it is related to the heart, the drugs could have like chaotic excretion, distribution, etc. So there is no particular time frame. So safely we can keep like 24 to 72 hours post sedative clearance will be a better window, and that is the reason for all possible reasons more than or equal to 72 hours is taken as a better window to even remove the confounding factors, and multimodal approach would be a better methodology to start the neuroprognostication. Okay. So as per the guideline, operationally, the timing for prognostic impression is typically at least 5 days after ROSC for patients treated with hypothermic temperature control. As I explained, 24 hours plus 12 hours rewarming, and from normothermia post 72 hours. That will be the better window. And when you are answering the examiner, don't tell the days. Okay, none of the guideline will say days. Even this 5 days is not mentioned in the recommendation guidelines. It is given in the explanation guidelines. So when you say, safely say it like post more than or equal to 72 hours of normothermia post ROSC. That's what your answer should be. Okay. Coming on to timeline for prognostication. If you see the first 24 hours will be, we would have received the patient, we'll be aggressively treating the patient because we could revert back. So we will be aggressively treating the patient. So your first goal should be in the first 24 hours, 0 to 24 hours, your goal should be, I'm going to maintain the temperature management. I'm going to treat the cause of cardiac arrest and see whether I can get the patient back. Your goal will be stabilization, right? So in this particular phase, you don't talk to a patient relative in a way that, pupils are reacting. Yeah, there is a corneal reflex. Yeah, patient is having some M3 response. So there could be a favorable outcome. Like, don't be in a hurry to prognosticate like favorable outcome or an unfavorable outcome at this particular point of time. Okay, because a patient can have various confounding factors here. The next day, which is the most common day for confounding, where the patient can have treatment related medication effects, or the patient might have some organ dysfunction because of the first 24 hours organ damage, or the patient can have some temperature related drug excretion problems. So the second day is like the worst day for neuroprognostication, because this is where you find the high rates of confounding from various aspects. Okay. And the third day, I mean, the more than or equal to 72 hours, okay, will be the optimal timing for starting the neuroprognostication. Like, you are starting it early, but to say whether it's a favorable or an unfavorable, like to make a point to the patient relative, the better window will be more than or equal to 72 hours from the normothermia post cardiac arrest. And 72 hours is not a cutoff. For example, as Soumya said, if you are doing a multimodal approach, all are like, few are like inconclusive, then you need not rush it, okay, because it is about life-sustaining therapy to the patient. If you withdraw, it is a crime. If you continue also, it's a waste of resource. So if you feel that it is inconclusive, just wait for like one more day, 24 hours more or 48 hours more. When you get a conclusive report from a multimodal approach, then you start prognosticating. That is what the guideline says. Okay. So what is neuroprognostication? Basically, we are assessing structural injury as well as the functional injury to the brain, right? Structural injury, we can do neuroimaging and biomarkers. Functional injury, we can see it by clinical examination or electrophysiological studies. This comprises neuroprognostication. It is not a single test. That is what you should understand. Okay. And the most, the 4 common assessment modalities are clinical examination, electrophysiological examination, neuroimaging, and biomarkers. Okay, so AHA defines for each prognostic variable an favorable outcome and an unfavorable outcome. Okay, so it is evaluated for whether it supports a favorable or an unfavorable outcome, or has a certain prognostic value based on its specificity, the timing, and performance within a multimodal framework. What is a favorable outcome? We are giving a hope to the patient relative that brain function is recovering. There is some hope and we could get back the brain function. That is a favorable outcome. What is an unfavorable outcome? Where we reinforce to the patient relative, yeah, brain is going for an hypoxic injury. The chances of brain function getting recovered is very less likely. So that is an unfavorable outcome. So AHA evaluates all these 4 modalities, whether it is supporting a favorable outcome or an unfavorable outcome within a given timeline, like when to perform these tests. So based on that, we are going to neuroprognosticate the patient. Okay. So let us start with clinical examination. Clinical examination, all of us know, pupillary reflex, corneal reflex, motor response to pain, and presence of myoclonus, like some jerky movements post cardiac arrest. We'll come to that. So this clinical examination, as I told you, there are a lot of confounding factors, medication effects, temperature effects, organ dysfunction effects, all could be confounding. So always better to wait till a complete sedative clearance has happened, which we can't predict actually, but you can just follow the timeline. And it should always be a part of multimodal assessment. With a single absent pupillary reflex, I cannot tell the patient is going in for unfavorable outcome. That is what you should remember. So let us discuss first about pupillary right reflex. Okay. If the patient is having bilaterally absent pupillary right reflex more than or equal to 72 hours after cardiac arrest with appropriate sedative clearance and temperature and all of that, then it may indicate an unfavorable outcome. But you cannot take this alone as a single predictor for unfavorable outcome. But as a multimodal approach, this could be one of the predictors for unfavorable outcome. And the high specificity is at more than or equal to 72 hours with a very low false positive rates. Okay. And if suppose a patient is having a preserved pupillary reflex at any point of time, I'm telling, it doesn't support any favorable outcome. So always keep in mind that one single finding, you cannot neuroprognosticate a patient for a favorable or an unfavorable outcome. Okay. Coming on to another modality to assess the pupil. So as per the 2025 guideline, they have mentioned this index called Neurological Pupil Index. I don't believe this was insisted in the previous guidelines, but in this guideline, they have mentioned about the Neurological Pupil Index. Basically, you can see this device. It is called quantitative pupillometry, where you keep it close to the pupil and it assesses pupil size, constriction velocity, dilation velocity, the latency, and the percent constriction. All of that is assesses and it gives a value. Okay. If the value is between 3 to 4.9, that means the pupillary index is normal or brisk. If it is less than 3, then it is abnormal or sluggish. If it is 0, it is non-reactive or an atypical response. Okay. But as per AHA, they haven't given any particular value for a favorable or an unfavorable outcome. But there are many studies based on this, which is giving a value, which we can keep in mind for reference. But there is no proper cutoff or there is no actual validation for this particular methodology to say, to say that it has a favorable or an unfavorable outcome. Okay. So when it comes to quantitative pupillometry, it may be reasonable at more than or equal to 72 hours with other tests to support an unfavorable outcome. For a value of NPI less than or equal to 2, especially at 24 hours, which shows 100% specificity as per the studies. But this could also be influenced by medications, and the absolute cutoff is unknown, and it is not definitely given in the guideline also. Okay. Similarly, favorable outcome, they haven't given any specific favorable outcome suggestions nor the values. But as per the studies, if the NPI value is approximately 4 and above, then it indicates favorable outcome. But we don't know the ideal cutoff. Maybe in the future guidelines, if the studies show a promising evidence, then they may include in it. Okay. This is with respect to quantitative pupillometry. Coming on to corneal reflex, it is similar to pupillary reflex. So it is more reliable when the corneal reflex is absent at more than or equal to 72 hours post ROSC. And it could also be confounded by many things like medications, testing technique, etc. But just because the corneal reflex is preserved, it does not indicate a favorable outcome. Coming on to myoclonus, as Soumya was suggesting, like there are two different terminologies here. One is an undifferentiated myoclonus, where the patient can have like intermittent jerks, which is not proven by the EEG. So like an intermittent jerks, which you see clinically, which you feel it is a myoclonus. Actually, the usefulness of this particular undifferentiated myoclonus is uncertain, even within or after 72 hours after cardiac arrest. Okay, especially within 72 hours. It is mainly because of high heterogeneity, lack of standard EEG correlation, and it could be present false positively up to in 22% of the patients. So don't use this undifferentiated myoclonus alone as a predictor of unfavorable outcome when you start neuroprognostication. Okay, but there is no reliable role in favorable outcome for undifferentiated myoclonus. Coming on to status myoclonus. This is nothing but continuous generalized myoclonic jerk, which happens after cardiac arrest, which usually is seen in hypoxic injury. There is high specificity if this is present for an unfavorable outcome, but the consensus advises that avoid status myoclonus for prognostication. Always use a multimodal approach. Okay, and definitely it is not for the favorable outcome. Coming on to the motor response, even in the case we saw the patient does not have any motor response. This usefulness for this no motor response for an unfavorable outcome is uncertain, because there could be high false positive rates up to 75%. So you cannot use this alone as a modality for prognostication. But favorable outcome, if the patient is having M4 and above response, may be reasonable to support a favorable outcome. If suppose M4 and above higher scores, then it indicates even a better outcome after within or after 72 hours. Okay, so and if suppose the patient is having both pupillary and corneal reflex intact, like meaning present together, in the early ROSC, it could be favorable, but you cannot take it as a standalone predictor. Okay, so can one of you summarize what we discussed for clinical examination now? So clinical examination has pupillary, corneal, undifferentiated myoclonus, status myoclonus, and finally motor response. Can one of you tell me what is a favorable, unfavorable outcome with respect to pupillary reflex? If the patient is having an absent pupillary reflex, what do you mean by that? Like, can one of you try answering?
Pupillary reflex more than 72 hours, you can consider it as unfavorable outcome along with other
very
modalities.
good. Very good. Yes. Next, coming on to corneal reflex.
Same, ma'am.
Yeah, very good. Okay. Coming on to undifferentiated myoclonus, that the patient is having some jerks post cardiac arrest.
No use. We can't prognosticate
Using that alone. Correct. Next, if suppose the patient is having status myoclonus, though it is highly specific, what you should do?
They have specifically told not to say status myoclonus as a poor prognostic factor alone.
Exactly. Yeah. Suppose if the patient is having no motor response, like what will be your prognostication ideology? Yeah.
It could also be due to some confounding factors. So we have to correlate with other modalities.
Yeah, it is uncertain. Very good. So overall, we have discussed the clinical examination. Pupillary corneal reflex more than or equal to 72 hours post ROSC, absent pupillary and corneal reflex could indicate unfavorable outcome. Always when you're telling the answer, tell it cannot be taken as a standalone predictor. That is one thing. Motor response is uncertain. It could be absent because of many confounding factors. And myoclonus, undifferentiated, don't use it. Status myoclonus, don't use it at all. Like better not to utter those words. Just stick on to the clinical examination more than or equal to 72 hours could indicate unfavorable outcome. That is the final gist of the clinical examination. Let us move on to the biomarkers. So what does serum biomarkers indicate? It reflects the neuronal injury, proteins released into the blood. So ideally, if the levels are very high, it means the brain injury is bad. If the levels are low, that means the brain injury is less severe, right? But the prognostic accuracy could be limited by laboratory variability or extracerebral protein sources or hemolysis or lack of standardized threshold. Okay, so again, it should not be used alone. It should always be a part of multimodal approach. Okay. The two common biomarker which the guidelines suggest is neuron specific enolase and neurofilament light chain, NFL. Okay. If suppose the levels are very high within 72 hours after cardiac arrest, it is reasonable to say that the patient could have unfavorable outcome. But there is no specific cutoff value like how high is reliable. It is not given in the guideline. There is no optimal cutoff value. There is no optimal particular timing which has been mentioned in the guideline. But within 72 hours, if the levels are very high, it could be a predictor of unfavorable outcome. Coming on to favorable outcome. If suppose the levels are below 17 microgram within 24 to 72 hours, which could be a predictor of favorable outcome or a recovering brain. Okay, so low biomarker levels are really encouraging in the first 72 hours, and the specificity is generally above 80%. And there are also other biomarkers where the usefulness is still not based on the evidence, it's not fully determined. But there are other markers like S100B, glial fibrillary acidic protein, or tau protein, or ubiquitin C terminal hydrolase protein, where the evidence is limited. We don't know the cutoff values. It can be used within 7 days, but it is not recommended for routine clinical use. So can one of you tell me with respect to biomarkers, what is a favorable, unfavorable outcome, and what are the two common proteins we are using here?
We are using neuron-specific enolase and neurofibrillary protein.
Yeah.
The favorable outcome is when neuron-specific enolase levels are below 17, which can be measured at after 24 hours to 72 hours.
Yes, very good.
No specific cutoff for a higher level of NSE, but we can measure after 72 hours.
Yes. So if higher levels are like discouraging, like it could be a predictor of unfavorable outcome. Great. Okay. Great job, guys. So let us move on to the third part. That is the electrophysiological study. So as you people already told me the answer, we are using two modalities, mainly EEG, which assesses the cortical electrical activity, and somatosensory evoked potentials, which assesses the thalamocortical sensory pathway integrity. And mainly it is done by median nerve stimulation by recording the cortical N20 wave. Okay. So when it comes to the electrophysiological studies, at or beyond 72 hours, if the patient is having status epilepticus, persisting status epilepticus, burst suppression, or EEG suppression in the absence of sedators, and bilaterally absent N20 waves on SSEP, then that could indicate an unfavorable outcome. And similarly, if the patient is having seizures, EEG-based seizures, rhythmic or periodic discharges, and unreactive EEG post-ROSC, then it could be an unfavorable neurological outcome. So your main, you should remember mainly status epilepticus, burst suppression, and absent N20 on the SSEP. You can see that there are few EEG patterns which I have kept. One is a flat EEG, another one is the burst suppression EEG, another one is the last D is status epilepticus. Okay, these are some of the EEG patterns. I don't believe they would show EEG even as a OSCE, but you should just know the names. That's all. Coming on to favorable. So if the patient is having continuous EEG background without any epileptiform discharges, or if the patient is having normal voltage continuous EEG background, or if the patient is having N20 amplitude greater than 4 microvolts on SSEP, then that all could indicate a favorable outcome. The EEG findings should be within 72 hours after ROSC, and the N20 findings should be after 48 hours after the ROSC. Okay, so this concludes our electrophysiological study. So can one of you quickly tell me, like, what are the important unfavorable outcome we are looking at in EEG and SSEP? Like few important words you can tell. Yeah.
In EEG, if it is status epilepticus and there is a burst suppression happening continuously.
Very good.
Periodic discharges also. Those are
yeah.
but
And with respect to SSEP?
absent N20 at 48 hours. After 48 hours, it's unfavorable.
Okay. So always when you are saying a finding, just make sure you are putting a timeline to it, like a timeline 48 hours, 72 hours, like that. Yeah. Next, what is a unfavorable, what is a favorable outcome, especially with respect to SSEP?
If the N20 amplitude is more than 4 microvolt after 48 hours, it is favorable outcome.
Very good. Okay. So again, this could not be used as a standalone predictor. Always say the word multimodal. So today's mantra after neuroprognostication is multimodal. Okay. Coming on to neuroimaging. So CT and MRI are the main modalities. It helps to detect and quantify the hypoxic brain injury, right? And early CT, like less than 24 hours, if you're doing a CT, it may not give us any major prognostic accuracy. It can be used as a part of multimodal assessment, but better to wait. Like yearly, you can wait, like maybe you can start from 48 hours. That will be a better window. So what does CT brain says? It assesses the cytotoxic cerebral edema, which is quantified by the gray-white matter ratio. And the normal ratio is 1.3, and it declines with cerebral edema. Okay. Coming on to MRI brain, which assesses the restricted diffusion on DWI, which is quantified by the apparent diffusion coefficient. And the normal is between 650 to 1000, and it decreases with increasing injury. Okay, I'll show you the radiology images, that time you would understand. So what is an unfavorable outcome when it comes to neuroimaging? When the patient is having reduced gray-white ratio, which indicates a cytotoxic edema, or if the MRI is showing extensive restricted diffusion and extensive areas of reduced ADC between 2 to 7 days, then that indicates an unfavorable outcome. When it comes to CT, you can start a bit early, but when it comes to MRI, it is better to wait for 48 hours. Okay. What is a favorable outcome? When the GWR is preserved, and when there is an absence of restricted diffusion. Again, with respect to CT in an early imaging, with respect to MRI, it is better to wait till 48 hours. In this window period, if suppose the anatomy is preserved, the restricted diffusion is preserved and the GWR is preserved, then you call it as favorable outcome. Okay. So can one of you quickly tell me what are we looking at in CT, MRI, and what is a favorable and unfavorable outcome?
CT brain post-arrest.
Yeah.
Gray-white matter ratio is reduced, unfavorable outcome. Then
Yes.
MRI, diffusion weighted restriction is there, and in ADC, extensive ADC are there, then these are indicatives of
unfavorable outcome.
Unfavorable.
So for the MRI, what is the timeline we are putting?
2 to 7 days. MRI.
Very good. Yeah. Coming on to favorable outcome. If everything is preserved in this window, then it is a favorable outcome. Yeah, good. So overall, this is actually a picture from the guideline only. So neuroimaging, we have already discussed. Neurophysiology, we have already discussed. Clinical examination, we have already discussed. And biomarkers, we have already discussed. It is important that you note the timeline. And when you are telling the answer, you should tell it as a favorable and an unfavorable outcome attached with the timeline. Okay. So if you see this picture, the neuroimaging, CT, we can start as early as possible, but just better to wait 24 hours at least. Maybe it will give a better diagnostic accuracy. But when it comes to MRI, it is better to wait 48 hours to 72 hours or 2 to 7 days. Okay. Similarly, neurophysiology, EEG, yeah, you can start from post-cardiac arrest, but SSEP, it is better to wait till 48 hours for a better prognostic value. Okay. And clinical examination, as we discussed, pupillary corneal reflex more than or equal to 72 hours, and quantitative pupillometry could be an additional predictor, but the cutoff values are still not defined. Coming on to biomarkers, yeah. So you are seeing the trend. If suppose the values are in an increasing trend, then unfavorable. If the values are less than a particular value, then it is favorable. So this timeline, because if you don't tell the timeline, like what are we achieving? You can tell I'm doing this. If I do it at 24 hours, obviously the examination is going to be confounding. So when you answer this type of neuroprognostication question, it is better to attach the answer as with a timeline, and always say it is a multimodal approach. Okay. So now Coming on to the case scenario back, this will be our final slide for the neuroprognostication. So what type of neuroprognostication tools should be utilized at this point? So we know E is at 72 hours post normothermia and sedation has stopped for 24 hours. The pupils are sluggishly reacting, which is kind of 50-50 on the pupillary scale. There is no corneal reflex. There is no motor response. So what type of additional neuroprognostication tools which you can utilize at this point of time based on our discussion?
MRI, EEG,
and biomarker. Actually, it is a very good window for everything because 72 hours have passed. Yeah. And so in this case scenario, what are all the indicators for an unfavorable outcome? Like, of course, we cannot tell that as a standalone predictor, but with this scenario, what all the indicators that patient could have an unfavorable outcome?
Absence of corneal reflex and motor response persisting after 72 hours.
Very good. Yeah. So, so now there is a sluggishly reacting pupillary reflex. Of course, I'm going to go multimodal, but even with EEG, even as I don't have a biomarker in my hospital, so I'm doing an imaging which shows like a mild hypoxic injury, and the patient is still having sluggishly reacting pupils. So can I start unfavorable outcome discussion to the patient relative, or I can still wait to prognosticate? What will be your suggestion?
Can start prognosticating.
Can start prognosticating, or if you are in dilemma, you can even wait for some more time to prognosticate also. Very good, guys. Like, I think you have finished the neuroprognostication. This will definitely be an OSCE section, mainly because it is linked to organ donation and things like that. So you make sure that you just go through these slides very quickly. This is more than enough for your practicals. No need to like, okay. So let us go on to the second part, that is ATLS. Okay, so ATLS, how are we gonna go with the discussion? I will tell you like very quick updates about the 11th edition, not so much in detail because whatever I'm telling, that is enough for the OSCE, that much I can assure you. So the conceptual updates which you should know, which the ATLS is insisting that we must know as a team, ATLS team, and for the management of a trauma patient, that we will discuss quickly in 2-3 slides. And we'll go along with the case discussion. But I will not be discussing about a blunt trauma, penetrating trauma. Those are like one slide updates which you can go through. But main important updates I will definitely discuss with the case. Okay, just be interactive as much as possible. But the conceptual ones you can just listen. Okay, so we'll start with the ATLS update. So what does ATLS say newly about some concepts like which you should know, where the examiner might want to know that are you updated with the recent guidelines? Okay, so coming on to a concept called weave concept, where ATLS suggests like just don't go with the primary survey, team communication. No, it should all go hand in hand. It should all go hand in hand. It should be a patient-centered care. You should simultaneously manage. You should simultaneously handle the communication. You should see the environment. You should see the situational awareness, and you should start the communication. It should be a patient-centered care, but it is none of the concepts are like applied sequentially or in isolation, but everything should go hand in hand during a trauma resuscitation. That's all is the weave concept. So simultaneous resuscitation, communication, patient-centered care, and management of the patient, and no sequential or no isolated protocol to follow ATLS is what weave concept is. Just know it. Okay. Coming on to handover protocol, this is very important because a trauma patient is coming to your hospital. An ambulance driver or a paramedic which is coming to you should give you a proper handover, right? If suppose your hospital does not have any, does not have that particular intervention, you have to refer the patient for a definitive care to another trauma center by giving a proper handover. So handover protocol for a trauma transfer or for trauma receiving is insisted and given more importance in this 11th edition, where they have given many like mnemonic like this, many frameworks like this, which you should follow. And out of which the two commonest ones I have put here. One is a MIST. I think this was insisted in the previous ATLS also, where MIST is a mnemonic which says M stands for mechanism of injury or a medical complaint. I stands for injuries and information related to the patient complaint. And S stands for the signs, the symptoms, including the GCS score and the vital signs. And T stands for what is the treatment given either in the ambulance or in your hospital, so that you can transfer the patient appropriately with a proper handover framework. So you don't miss any critical information during the transfer. That is the ideology. There is also another framework which has been given. I know in our hospitals, if suppose it's a JCI or an NABH, we have some handover protocols called SBAR framework, where it says situation, background, assessment, and recommendation. So they have just incorporated that into the trauma with the new ABCD protocol, and background, assessment, recommendation is the same. So what does S stands for? You are basically explaining the situation of the patient, like this is so and so patient with such a gender and age, and came to us with such a injury. We have secured the airway breathing circulation. We have controlled the exsanguinating hemorrhage, and circulation is managed this way. Disability is this way, and the patient is not hypothermic. This form of ABCD should be your first framework, and followed by a secondary survey, like what you came to know about the patient's past history, and what is the current clinical status will be the assessment, and what you have to recommend during transport when you are shifting a patient from your hospital to the other hospital, or when you are receiving a patient from another center to your center. So these handover protocols have been given a lot of importance, so which you should know. So as an ATLS second update, so one is the first concept is weave concept, where nothing functions individually. It is a simultaneous act where you concentrate on everything at the same time with the team and a parallel group. And second is importance to the handover, where at least you should know MIST or this SBAR framework for an handover protocol. This is the second update which you should know for the OSCE. Coming on to team function, ATLS has given a separate chapter for this, like team communication, team leader, and assigning individual roles to the team member. Because if like AHA, like in cardiac arrest, we have loop communication, feedback communication, that communication and the teamwork makes like it gives us a better outcome. It gives us a different ideology where we perform even more better, rather than a single physician performing, rather than a single person ordering things and things like that. So they have given more importance to a trauma team, and how you are communicating among the trauma team, and how you are assigning roles for different team members of the trauma team, and what is the role of a team leader. So these are the important points where they have insisted, where a trauma team must have. So if suppose an examiner asks, like, what are the important updates you know of the ATLS, you must say the teamwork, the team communication, as well as assigning roles to the team members, and the functions of a team leader has been greatly insisted in this ATLS, where teamwork will give a better outcome, a better thinking process, where the mistakes can be corrected. Maybe in the next scenario, we will perform better. So a teamwork is given more importance in this ATLS. Coming on to communication, apart from the handover communication, as a physician, how you are communicating with the family is also equally important, where ATLS again is giving a greater importance for the trauma communication, where how a physician is going to interact with the family of a trauma patient, where it goes in steps. You just organize your thoughts, like what are you going to tell, how are you going to start, what is the important point you should put in front of the patient relative, so that they could understand the prognosis. Number two, how are you going to prepare the meeting, like will there be a translator needed, interpreter needed, or is a single family member enough, or an emotional family member is there? You have to know the situational awareness. You should know other family members are needed, and it should be a comfortable and a private setting, and you should look at the patient relative at an IE level to do a counseling. So you have to prepare for the meeting, and then you have to start with an ABCD protocol for the communication. Like you ask the family what you already know, and then you start like the prognosis could be bad, so sorry for the bad news, and then you have to start how you are, and then you have to summarize what is happening with the patient, and then like listen what the families wants to tell, whether it's an emotional or whatever they want to share, let them share, and then encourage and validate the emotion. If any further questions regarding the prognosis and further treatment care, you help them with that. Okay. And then you debrief with your team. This is very important. You communicate and then just you don't like leave it like that, because your other team members also should know, because ATLS is giving importance to the teamwork. So the team must know what you have discussed with the relative. So you should go back and debrief with the team. So this trauma communication is very important, because a breaking bad news is always an OSCE session in the practical exam. And especially when it comes to an ATLS, how you have to communicate with the relative as well as coming back to your team could be one of the OSCE station. So don't miss this part. This ABCD approach is given as different protocols, like spike protocol is the same, and there are other protocols is the same. But just remember with respect to the update, ABCD protocol. Okay. So these are the important updates. You should know conceptual updates with respect to ATLS. One is the weave concept. Second one is the handover protocols. Third one is the teamwork and team communication. And fourth one is the trauma communication with the family as a priority, and then going back to the team as a debrief. Okay. Hope you understood the conceptual updates with respect to ATLS. Okay. Now we will go on to the case. Sorry if I had bored you. I have made it as simple as possible. Okay. Now let us discuss about a case. I want you guys to be a bit interactive on this. Okay. So there is a 36-year-old male. He is an unrestrained driver in a high-speed motor vehicle accident, and there is a visible scalp laceration which is actively bleeding on arrival. And he arrived 25 minutes post-injury with the cervical spine immobilized. And if once you connected, the ambulance driver is already connected the patient to the monitor, where when you are receiving this patient, you are seeing all these vitals. He's tachycardic, hypotensive, tachypneic, hypoxic, hypothermic, and the GCS is only 7. Okay. So based on the conceptual discussions, as a physician who is receiving the patient from an ambulance driver, okay, what are you expecting? Like, what sort of handover protocol you are expecting? Like simple, whatever you could remember. Can one of you use that framework and tell me how the handover should be?
What is the mechanism of injury, first of all?
Very good.
Like what is the history you could collect from there at that spot? Then
Soumya, can you tell me which framework you are following here? It is the MIST framework, right?
Yes, ma'am.
Yes, that is what is important, because this handover has been given a greater importance in the update. When you receive or when you transfer, the handover should be very important, because you don't miss any critical information. So even when you're answering the examiner, you tell, I would like to start with the MIST framework so that I don't miss any critical information, and then I want to proceed like that. Okay. Yeah, very good. You told the mechanism. Next would be injuries. Yeah, please carry on.
He has.
Yeah, I didn't mention about that much. Yeah, you can just frame it. Yeah.
He has a injury on the scalp which is bleeding.
Very good.
Then signs and symptoms like tachycardia, hypotension, tachypnea, hypoxia, hypothermia, and low GCS.
Yes.
So second airway.
Yes.
Followed by like they have applied as immobilization to the cervical spine, and only that
they must have put some oxygen for the hypoxia, right? So always remember, this handover framework is very important. Either this or the SBAR framework. When you are answering, just make sure you are using the simplest one to know that you know the framework. Okay, let us move on to the next slide. So how are you gonna approach this patient based on the ATLS framework, like the ATLS protocol?
Was to stop visible bleeding, because X is the first, now they have changed.
Very good. So I would suggest you, like, if suppose they are asking a generalized question like this, okay, you can tell, like, I would start with primary survey, which has XABCD. And simultaneously, I'll perform the adjuncts to the primary survey. And then, if possible, if the patient is stabilized, I would move on to the secondary survey. And if there is a need for transfer, I would plan on it. And then definitive care will be planned. Maybe if they are asking a generalized question like this, how are you going to approach this patient? Then you can start with, I would follow the elements of initial assessment in this particular framework, but not in an isolation or in a sequential manner, but as all in all together simultaneously, because I have a trauma team which could function parallelly. Okay, good, Soumya. I'll just discuss the concepts here. Okay, so the main principle, what the trauma ATLS now is reinforcing is that treat the greatest threat to life first. Okay, don't wait for a definitive diagnosis to delay the indicated treatment. Okay, and assessment and resuscitation should occur simultaneously. Okay, and what is the framework they have given for the initial assessment? The initial assessment, it is a continuum that starts with the primary secondary surveys and proceeds through the definitive care, and re-evaluation is as important because we may miss something in the primary survey which we may pick up when we do the adjuncts and re-evaluate the patient, right? So this is the framework which you would follow when you're approaching a trauma patient. Your answer should, if the question is more generalized, then your answer should be more generalized in this way. Okay, so you're treating the life-threatening things first. Don't wait for, I will do X-ray and do this, I will do E-fast and do this. No, you are, if you feel that there is a life-threatening thing, you treat it immediately, and you are assessing and treating simultaneously. This is what the ATLS is insisting in this. Okay, as you rightly suggested, the first step after you tell the common framework is the primary survey sequence, which has been changed as XABCD algorithm. X means we are controlling the visible massive external hemorrhage. Okay, and followed by you're concentrating on the airway, breathing, circulation, disability, and exposure. We'll be discussing all of that in the next slides, just as a common algorithm. So when it comes to XABCD, what are the main things you are looking at? Like, what are the common issues you are going to look at when you are going through this algorithm? Number one, X, that is exsanguinating external hemorrhage. You are looking for any open extremity wounds or any open wounds that are massively bleeding. Okay, so this is slightly different from the circulation and hemorrhage control, because you are seeing which is open and bleeding, which you can compress and control. That is X stands for. It is not the actual hemorrhage control which you are doing in circulation. It could be looking same, but this is mainly open, massive bleeding, which you are seeing in a patient, which you can externally compress, or by tying a tourniquet or by giving a pressure, you can control. Okay, coming on to airway. What are we mainly looking at? We are seeing the airway patency or any injury to the direct airway where the airway could become more difficult, and the patient GCS is low where there is a risk of aspiration, or the patient is so hemodynamically unstable where in acidosis he could have a cardiac arrest and you need the protection of the airway. Those are the things you are going to look at the airway. Coming on to breathing, you're mainly going to concentrate on oxygenation and ventilation. And coming on to circulation, yes, of course, you are finding out the source of the hemorrhage and you're going to do the hemorrhage control, and you're trying to maintain the end organ perfusion. Restoration and maintenance of the end organ perfusion is your goal in circulation. Coming to disability, you're ruling out any brain injury is there, any spinal cord injury is there. What you can currently do, like just immediately do to prevent any secondary injuries or to prevent the spinal cord injury from worsening. Coming on to exposure, you are seeing any major missed injuries, and at the same time you're looking at the temperature problems like hypothermic, then you warm the patient because it is going to worsen the triad. So these are the main important things which you are going to look at X, A, B, C, D, E. Only if you know this, only if you know what to look for, you will look for it, right? So this table is as important as you know there is an algorithm, but what are you going to look at is also very important. Okay, I hope you understood that. So coming on to the control of exsanguinating hemorrhage, where you are looking for, very quickly you are looking for any massive external blood loss. Okay, and where exanuating compressible hemorrhage is your immediate priority. You can do direct compression, you can do wound packing, you can tie a tourniquet or junctional tourniquet and stop the bleeding. Your goal is to stop the external hemorrhage. Okay, and especially in this patient, we saw he's having a major scalp hemorrhage, which is one of the commonly underestimated source of hemorrhage. Okay, and when it comes to limb, if you're using a tourniquet, if you have tied a proper tourniquet, it should eliminate the distal pulse. That should be a sign that you have used the tourniquet very well. Okay, so these are some of the methods which you should use for controlling the exanuating hemorrhage. This could be asked because X, what does X mean, but how are you going to control it? Those methods are as equally important, and especially when it comes to tourniquet, you should tell, I will tie the tourniquet so that the distal pulse is eliminated. Then I know that I have tied the tourniquet properly. Okay, these are very important points which you should utter when a question is being asked in the exanuating hemorrhage. And in this patient, as we know, there is a open scalp hemorrhage. Your first step will be your, as already she told me, like when I answered her, she said there is a scalp laceration. You are trying to control the scalp bleeding, and then you are going on to the airway. Okay, that will be the next best step. Now, let us see this question. Now, you know that the patient GCS is 7. When you're examining the patient is having gurgling sounds and lot of blood in the mouth. How are you going to assess and manage the airway? Can just any one of you briefly tell me how would you manage the airway?
This patient, like right now, we don't know the cervical injury status. So cervical immobilization has to be done. Then followed by definitive airway because the GCS is low along with the threatened airway, like gurgling sound and blood in the mouth.
Very good, very good. You're absolutely right. So airway with cervical spine protection, as you rightly said, the GCS is low and the patient is unable to protect airway. There is a lot of blood and secretions in the oropharynx. He's at a great risk of aspiration. So you are going to secure a definitive airway with a manual inline stabilization and cervical collar. So, but when you said the answer, that sequence, see, you don't wait for a manual inline stabilization for airway protection. Of course, it is a hand-in-hand thing, but if suppose you could not do the manual inline stabilization like urgently and the airway is at threat, then the sequence is like you secure the airway with as much as possible with a manual inline stabilization, or you put a collar and do it, but airway comes first. Okay, it is always airway with cervical spine protection, but very good, you said that. And coming on to when you secure an airway, it should be mainly based on the mental status and the ability to maintain a patent airway and the chances of aspiration. Okay, and as you said, we should stabilize inline stabilization, but it should, if it is not a possibility that if you could not do it, just secure the airway, suction the oropharynx, pre-oxygenate, and always anticipate a difficult airway in a trauma patient. Okay, and pre-intubation, you should adequately resuscitate the patient, but you don't have time for this, then that's okay. You start vasopressors and IV fluid simultaneously, and keep always the difficult airway kit ready for such patients. And ATLS has also insisted on this physiology-based sedative agents. For example, if the BP is low, you can use ketamine. If the hemodynamic instability, you can use etomidate. And rocuronium and suxamethonium are the common paralytic agents suggested by the ATLS. And suxamethonium, you see to that the patient is not having hyperkalemia, muscle injury, and all of that. And always use a difficult airway kit. Always keep a difficult airway kit ready for the procedure. And apneic oxygenation is one of the techniques which has been mentioned in the airway chapter of the ATLS. Okay. And a difficult airway is not only defined by the anatomy here, because physiologically also the patient is having a difficult airway. He is hypoxic, he is hypotensive. If you give a drug, he may crash and have a cardiac arrest. So there are various factors which could define a difficult airway. It could be anatomy. No, it is like multimodal, where it is anatomy related, physiology related, environment related, and injury related. So when it is an ATLS, when you're answering about a difficult airway, you are telling, yes, I will secure the airway along with the manual inline stabilization, but I would anticipate a difficult airway because there could be anatomical, physiological, injury related, environment related difficult airway, which I must anticipate in a trauma patient. So what are the anatomical problems you can have? Patient can have a facial fracture where you may not be able to like put the scope in. Patient can have severe airway edema where a lot of secretions and gross bleeding, or patient could be morbidly obese and patient could have limited mouth opening. So all are some of the anatomical factors which could make your airway difficult. Coming on to physiology, patient can have hypoxemia, hypotension, severe hemodynamic instability, and gross elevated intracranial pressure, where some agents could be contraindicated, where you have to maintain certain targets of the hemodynamics, and there could be a risk of peri-intubation cardiac arrest with respect to physiology. Coming on to injury-related difficult airway, there could be cervical spine injury, laryngeal injury, tracheal injury, where even intubating may not be a possibility, where you may need other options, and penetrating neck trauma, in associated inhalational injury, expanding neck hematoma could be injury related difficulties you can face. And at the same time, environment related, like in a trauma patient, if suppose you have a limited space, like there is a team working on and you have a limited space, there is poor lighting and inadequate equipment, like you didn't keep the difficult airway ready, and you are the only person who's intubating, there is no team, there is no second intubator or second anesthesia trauma team which is there available. So these are some of the important factors which could even make a normal airway more difficult, and it is not based only on the anatomy. As you see, it is based on physiology, it is based on injury, it is based on environment, and that is why when you answer with respect to airway in a trauma patient, you always say, as she rightly said, airway with cervical spine stabilization, but I would always anticipate a difficult airway because it is not only anatomy, there are physiological, environment related, injury related complications that could happen during intubation. So I would be more prepared for a difficult airway. That should be an appropriate answer when you answer for airway support in a trauma patient. Okay. Yeah. Coming on to breathing. Now, the patient is having asymmetric chest movement with the reduced breath sounds on the right and SpO2 is dropping. What is your concern and management?
Could be tension pneumothorax because there is associated hypotension with hypoxia and there is asymmetric chest movement. So
Very
immediate just needle decompression has to be done.
Exactly. Yeah. Very good. So when it comes to breathing, yeah, as you rightly said, it could be a probable tension pneumothorax, where you said all the signs rightly. Here I want to just reinforce one point, like don't wait for an X-ray that, I'm thinking of tension pneumothorax, but I want to confirm with the X-ray. Don't think like that, because you always treat the life-threatening things first and don't wait for a particular investigation to do the management. Okay, so that is one important point which I want to reinforce. And as you rightly said, we have to do the needle decompression. The location of the needle decompression as per the ATLS, mostly it is the same. I just want to reinforce on this. They have mentioned either it could be a second intercostal space in the mid-axillary line, or it could be a fourth or fifth intercostal space between the mid and the anterior axillary line at the inframammary fold. Both are accepted points for needle decompression, but second could be more difficult, because if the patient is too obese, like sometimes anatomy could be very difficult. So there are some restrictive factors when it comes to second intercostal space, but yes, you can definitely use for needle decompression, followed by you should keep ready for the definitive management. That is how you're going to structure your answer. Okay, and I would use a safe triangle for the definitive ICD that you have to mention. Okay, and there could be other life-threatening thoracic injuries should also be anticipated, like massive hemothorax or an open pneumothorax or a flail shed with pulmonary contusion could also be the other reasons for the hypoxia and decreased breath sounds and all that. But as she rightly said, there is hypotension, hypoxia, and sudden drop in SpO2. All of that points us towards the traumatic tension pneumothorax. We should not wait for the differentials here. We should do the needle decompression and maybe anticipate indicate there could be associated life-threatening injuries also. And when it comes to breathing and ventilation, as per ATLS update, this is just an update, EFAST has become an integral part of whatever you assess. Like, for example, if you're assessing breathing, EFAST should be an integral part of your assessment. Like, you have to rule out hemothorax, pneumothorax based on the EFAST assessment. It should not be kept for, no, I will see the secure the airway, I'll see oxygenation and ventilation, I'll go to circulation and then do it as a primary adjunct later. No, it should be an integral part where the focus is being given more importance in this guideline. And always suspect mediastinal injury when you're having an anterior thoracic penetrating trauma. Always suspect mediastinal and cardiac injury, and don't do hyperoxia, because excessive oxygen is also harmful. So make sure that you are maintaining a decent target for the oxygenation. This hyperoxia could be problematic if the patient is having a traumatic brain injury, where it could cause secondary brain injury. So the main updates with respect to breathing and ventilation are: keep EFAST as an integral component, and when there is an anterior thoracic injury, always suspect cardiac and mediastinal injuries also, and make sure you are oxygenating in the correct target. Okay, and especially when the patient is having a rib fracture, they have suggested a multimodal pain control for the rib fracture, which is not an important part during the primary assessment. But suppose you finished your primary assessment simultaneously adjuncts, and you feel there is nothing major, the patient is having only rib fracture, then you can approach the pain control for the rib fracture in a multimodal way, where you can give scheduled acetaminophen, paravertebral block, epidural intercostal block, where you can give oral opioids and operative rib fixation later. So these are some of the updates with respect to breathing and ventilation. Okay, coming on to circulation now.
Now, just one doubt. This patient, he had a tension pneumothorax.
Yeah.
So immediately we are going to needle decompress. Should we take this first and do the intubation next? Because after intubation, positive pressure ventilation could worsen.
I do understand. But airway stands first. See, when you are securing the airway, in this case, you can put 100% oxygen in the ventilator, and you can still oxygenate, because organs should not be deprived of oxygen, especially the brain. So airway should be your first priority, and you are doing this simultaneously. This is what I'm trying to reinforce. You are not going to do step by step here. So there is a trauma team where one of you is intubating, and you could be a parallel team member where I feel it is a tension pneumothorax, and you could do the needle decompression simultaneously. So your answer should not be, I will do this and then next that. Of course, your doubt is very justifiable. Of course, this also is going to cause more hypoxia. And that is the reason they are introducing the weave concept. Like, it is not a step-by-step thing. You can tell I will be a team member where I will be doing intubation, where simultaneously my team member will assess for a tension pneumothorax and resuscitate for the breathing. Okay, that should be your answer, as well as the thinking process too. You cannot handle a trauma patient alone. That is not a possibility at all. Okay, and there is no priority front and back. It should be simultaneous, and airway comes first, then comes oxygenation and ventilation. Okay?
Okay,
great. So coming on to circulation. So now the BP is 80-40. He is very hypotensive. He is tachycardic, and you have secured the airway. But when he came in, he could not. Sorry, this pelvic pain might be a wrong wording here, because his GCS was low, and you are noticing a left thigh deformity, very obvious deformity on the left thigh. So how are you going to interpret the circulation status and prioritize the management? I'll tell you why this question is important.
Ma'am, based on the circulatory status, patient is in class 3 hemorrhagic shock. Since he's having hypotension also, along with respiratory rate was 30 initially, heart rate is also elevated.
Okay.
And so I will go with
Good, you started well. Can I ask you, can I lead you with few questions? Yes, what do you think is the source of hemorrhage here? What do you think?
Where is it? Injury, ma'am. Left femur fracture is there, deformity is there.
Okay.
So pelvic binder, if I'm suspecting
pelvic injury. Okay, great.
Along with massive transfusion, ma'am. Yeah,
I would suggest, Jyoti, when you are starting the circulation, you tell it because the patient is hypotensive and I'm suspecting an hemorrhagic shock, I will secure 2 large bore cannula, which is a simultaneous action. You are not doing it step by step. One of your team member is already securing a cannula, taking samples, starting fluids, where as per the recent ATLS update, you are not going to give liters and liters of fluid. They are like discouraging the crystalloids resuscitation. You will tell, I will start with 250-500 ml bolus, and I will immediately arrange for the blood products. If suppose grouping typing is possible, I will do group specific. If that is not possible, I'll start with O group, and then I will put a pelvic binder. So if you formulate your answers like this, starting from the cannula to the fluid to the blood and the definitive management, it would be great. But your thought process is very good. You have answered the question actually. So let us go on to the update with respect to circulation and hemorrhage control in ATLS. Okay. So as per the 11th edition, and or even by the previous edition, we know we are looking at the potential anatomic locations for the blood loss. Here she rightly guessed it is pelvis. Okay, so what are the possible locations for hemorrhage? There are some like remembering sentences they have given, like 1 on the floor and 4 more, and 4 and the floor. These are some of the things which could help us remember the locations, where they have mentioned either it could be a thoracic cavity, the bleeding could be in the thoracic cavity, and that is why EFAST examination, all of that should be a part and parcel of your resuscitation, rather than keeping it like I will finish this and do the EFAST like that. Okay, so it could be a major thoracic injury where the patient is bleeding. It could be major peritoneal injury where a visceral organ, or some bowel injury where the patient could be bleeding, or the bleeding could be in the retroperitoneal space where only during the exposure and during the log roll we may be able to like understand that, right? And it could be a long bone fracture, like as she said, it could be a pelvic fracture in this case, or a femur fracture in this case, because there is a thigh deformity, or overall there is an open bleeding, which of course we are controlling in the X part, or there is some open bleeding which is there, which we could control initially also, now also, so that we can maintain the circulation. The main goal of circulation is to maintain the organ perfusion. That's all. So these are some of the commonest locations where you have to anticipate bleeding when a patient is having hemorrhagic shock. If you could not find any obvious signs, for example, if the patient is having hypotension and you don't know where is he bleeding, then your answer should be, after a simultaneous resuscitation, I would be looking for the areas where he could bleed, and you should mention all these 4 areas, like thoracic, abdominal, retroperitoneal, as well as long bone fractures, where I would be looking for as the potential source of bleeding, and I would manage accordingly. Okay, your answer should be that way. So, sorry. Yeah. So as she said, we can put a pelvic after resuscitation, like after IV cannula, fluid, blood and all that, we can put a pelvic binder. And I will show you a flow chart for the pelvic fracture management, which is an update given in the ATLS in the next slides. And then I would look for the definitive management. That will be your answer. And as for the 5 regions, when you're suspecting an abdominal injury, okay, FAST is one modality where you can look at the pouches and look for the free fluid where the patient could be bleeding, which can be performed simultaneously during the primary assessment. And once you find if it is positive, then definitely you should involve the trauma surgeon and shift to OT if the patient is hemodynamically unstable, or you can do a diagnostic peritoneal lavage. Genuinely, I'm telling, I'm in 5 years in critical care, but I've never seen a peritoneal lavage done in my trauma center, because always FAST, and if patient is stable CT, then only we usually send the patient for OT. Yeah, but as per ATLS, you have to mention, if they ask for, like, how are you going to diagnose? How are you going to know that the patient is having bleeding in these regions? Then your answer should be, most common is FAST, but I would also use diagnostic peritoneal lavage if a trauma surgeon is available, or I can do it. And then if it is positive, I will shift the patient to OT. Coming on to chest, if possible, you get a chest X-ray, or you can keep EFAST as an integral part of your assessment and say whether there is a pneumothorax. Coming on to pelvis, yeah, pelvic radiograph as soon as possible, but it is not the first step. You treat the patient simultaneously, you try to get it. That is pelvic fractures. Retroperitoneum, mainly by means of clinical examination, which usually comes a bit late in exposure. Or if the patient is clinically stable, like, okay, moderate hypotension, which is managed with blood component, still we can shift the patient to a CT possibility, then you can shift and find the retroperitoneal bleeding. And obviously on the floor, you can look at the external hemorrhage and treat the patient. So when you're telling about the locations of the bleeding, they will definitely ask you, how are you going to look for the bleeding in particular places? So you should at least know fast DPL and X-rays. When the patient is stable, I can get a CT scan also and rule out things. Okay, this should be your answer. And one more thing I wanted to reinforce with respect to the updated guidelines. She was telling me it is a class 3 hemorrhagic shock. I know we are used to that old ATLS table where class 1, class 2, class 3, class 4 percentage of blood loss and all of the hypotension, tachycardia, all of that comes into play. But when I went through the 11th edition, actually they have given a different table, which is a physiology based resuscitation table, where you don't classify a patient based on the estimated blood loss. It is not a quantification anymore. Okay, like for example, in hemodynamic monitoring, what are we telling? It is not static, it is dynamic. We have to keep looking how the physiology of the patient is changing and recalibrate and assess based on the dynamic devices. Like that in trauma also, what they are reinforcing or insisting is that in the new updated guidelines, you don't name the class with a percentage estimated blood loss. Okay, you see the physiology of the patient, and then you classify as mild, moderate, and severe, and then you look for the physiological outcome. Okay, for example, I'm looking for a physiological improvement of the patient rather than a number, like percentage is improved, this is improved, that is improved. So your answer should be more of physiology based answer rather than a class based or a percentage based answer. That is what they are insisting. So the class 1 to 4 table has been de-emphasized in this ATLS update, where they are emphasizing on the physiological assessment and response to the resuscitation. Okay, so what are the signs of the shock you're going to look for here? Of course, we know all of this, just the terminologies are changed, and just be careful when you're mentioning about the class. Okay, hypotension, tachycardia, altered mental status, urine output, cold clammy skin, tachypnea, hypothermia. So these are the physiological signs of shock you are looking at. And what are the laboratory indicators you're looking at? Lactates, base deficit, and the basic hemograms. So this is all the same, where there also we were looking at base deficit and all that, but here they are mostly directing towards physiology, because the estimated blood loss is unreliable. How can you tell 30% of blood is lost when seeing only the physiology? Unless you do imaging, even with imaging, you cannot tell unless you open the patient and measure the bleeding, you cannot tell yeah, this much percentage of blood loss is there. Like they are pushing us more towards physiology and dynamics rather than a particular number, because the estimated blood loss is unreliable and the physiological response varies widely. And mainly the clinical assessment should drive management, but not the numbers, but not the percentage. That is what the ATLS is. Yeah. So if you see the ATLS 11th edition, you can see this table. There is no particular class attached with it. I'm not 100% sure whether the classes are removed, but when I went through the explanation as well as the detailed description they have given, it is mostly, this is the table we are going to follow in future also, where they don't name it as class, where they name it as minor, moderate, and major based on the physiology of the patient, the physiological changes of the patient, rather than the percentage or the numbers. Okay, please remember that. When you're telling what class of shock, which stage of shock is, which type of hemorrhagic shock you are looking at, then you can tell minor, moderate, major based on the physiological signs I'm seeing. Maybe that would be a better and safer answer when you're answering for the exam. So what are the parameters they are looking at? Heart rate, systolic pressure, pulse pressure, respiratory rate, level of consciousness, base deficit, whether the patient needs blood products or not, and what is the response to the resuscitation, and does the patient need operative hemorrhage control or not. So based on that, they are classifying the hemorrhagic shock into minor, moderate, and major. Okay, if you see this patient, of course, I didn't put the ABG finding and all. Maybe this patient would fit more towards the major hemorrhage because he's hypotensive, the pelvis deformity is there. Maybe E-fast is positive. He may need OT urgently. So he may fit into a major hemorrhagic shock category based on the newer updated guideline. That will be a better answer when you're answering for an ATLS. Okay. Now, as I told you, this particular flow chart has been given for the pelvic fracture in the 11th edition, where if suppose you are suspecting a patient with a pelvic fracture and hemorrhagic shock, as we already discussed, first is resuscitation and next comes pelvic binder, and you are doing a fast scan or a DPL. If there is an intraperitoneal bled, then patient is unstable, you immediately take the patient for laparotomy and you do a damage control surgery and you get the patient back. But if suppose there is no fast positivity or no peritoneal bleeding suspected, then you can refer the patient for angiography embolization or a RIBOA, especially when it comes to pelvic fractures and hemorrhagic shock. Just remember RIBOA. I will show you a slide on RIBOA. This RIBOA has been given more importance in the circulation in the 11th edition. Okay, I hope you understood that. So when you're answering a circulation question, always start with the cannula, fluid, bled, and then you tell the patient could be of minor hemorrhagic shock, moderate hemorrhagic shock, major hemorrhagic shock based on these physiological parameters. And because I'm suspecting a patient is having a pelvic fracture, I would resuscitate and put the pelvic binder, and I would do a E-fast. If it is negative, then I would call the interventional radiology as well as the orthopedic team to refer him for an angiography and RIBOA if he is a suitable patient for that. Okay, this is how your answer should be. And coming on to the next part, what the ATLS is insisting is that once you resuscitate the patient, how are you gonna say that the patient is a responder or not? So they are classifying the response to the resuscitation as 3: responder, transient responder, and non-responder, which was there in previous ATLS also, where responder is the one where the physiological signs are improving. You are looking only at the physiological signs, okay? And transient responder, he improves, but he suddenly deteriorates, which means there is an ongoing bleeding which needs intervention. And a non-responder, despite of blood products, fluids, and whatever you could do, is not responding and the physiology is not returning back, then you have to urgently shift him for OT for the hemorrhage control. Okay, so the main indicators we are looking at here are the improvement in the heart rate, the improvement in the urine output, the improvement in the sensorium and base deficit and lactate. These are the physiological markers I'm looking at to see whether the patient is responding to the treatment or not. Okay, in this case, as she rightly said, the patient should be given fluids, blood products, massive transfusion protocol she did mention in a 1:1:1 ratio. As per this 11th edition, whole blood is preferred more than the PRBC. And if you could not like group and match, you can start with group O packed red cells. If it is a pregnant woman, start with O negative. And if it is plasma you want to give, you can preferably start an AB plasma. And if you suppose you could get the cross match on type, maybe in the second blood product onwards, you can give the a group specific blood product. And the third important point is after the fluids, where it is not 1 liter or 2 liter, nothing is mentioned of that sort, only 250 to 500 ml of bolus. Blood products are more preferred than the crystalloids, and you start the transfusion protocol if you feel the patient is in hemorrhagic shock and not responding. And the next important point is tranexamic acid. So when you're talking about circulation and hemorrhage control after fluids, blood products, and plasma products, you should definitely talk about tranexamic acid, okay? Where they are insisting tranexamic acid given within 3 hours of a trauma patient could be helpful for the hemorrhage control and a better outcome, okay? So what is tranexamic acid? Excuse me. It is a competitive inhibitor to lysin receptor on the plasmogen. We know trauma is an hyperfibrinolytic state, right? So pathologic hyperfibrinolysis occurs during trauma and which could disrupt the clot formation and can contribute to uncontrolled hemorrhage. So what is tranexamic? You can see that the fibrinolysis is initiated when the tissue plasminogen activator binds to the plasmin and activated plasminogen, and then it breaks the fibrin. So this fibrinolysis happens this way. When you give tranexamic acid, it binds to the plasminogen and it keeps the fibrin intact so that the patient doesn't bleed. So the dose is 1 gram bolus within 3 hours followed by 1 gram infusion over 8 hours, or you can just give single 2 gram dose. And it does reduce mortality when it is given early in the bleeding within 3 hours of injury, but it is not recommended beyond 3 hours unless if you are doing a TEG and the patient is still showing hyperfibrinolysis, then you can give. But within 3 hours is the most preferable time. So don't forget, tranexamic acid should be there in your answer when a patient is having hemorrhagic shock. Okay. Now, a brief discussion about Ribova. Yes. So Ribova is nothing but resuscitative endovascular balloon occlusion of aorta. It stops or slows the blood flow within the aorta to the targeted zones while resuscitation continues. It is mainly indicated if the patient is having pelvic fracture with hemorrhagic shock and not responding to the initial treatment. And it could be a bridge to a definitive hemostasis. Okay. There are 3 zones, but only in zone 1 and zone 3, you can apply the balloon occlusion. And mainly, you should have a surgical team and proper equipments to do so for the Ribova, because the complications related to Ribova is also there. Okay. So as I told you, these are the zones, aortic zone 1, zone 2, and zone 3, where you can occlude the balloon only in the supraceliac or in the infrarenal areas. And yeah, there are catheter related complications. There are you are occluding a circulation, right? Obviously, the distal ischemic changes could be there. There could be reperfusion injury, and vascular access related complications could be there. So this is in gist about Ribova. See, when you again, as a gist with respect to circulation, when you're answering a circulation, start with cannula, fluids, massive transfusion protocol, and I would use O group. I would use AB group for plasma. If pregnant women O negative, whole blood is preferred than the packed red vessels. And if suppose I would grade the hemorrhagic shock in a major hemorrhage, where because EFAST was positive, I would direct the patient for OT, or because there is a pelvic fracture, I would direct the patient for angiography or a Ribova, and I would also give tranexamic acid if the trauma patient has reached within 3 hours of injury. So this completes your circulation answer, rather than putting only the definitive words like I would do pelvic binder, I would do this. So it should be a sequential answer where the examiner knows, yeah, you are truly handling a trauma patient effectively, so that the hemorrhagic shock can be controlled and the physiology can be restored based on your resuscitation. I hope you understood that. Then let us move on to the disability management. So the patient's GCS is 7. Multiple facial injuries are there. Patient GCS is 7. You have already intubated. Circulation is managed. What are you gonna do? Sorry.
My one doubt regarding
Yes,
the previous thing.
Yeah.
In that stage, what will be our BP target, ma'am? We don't know whether the patient is having TBI or spinal cord injury. So whether we will permissive hypotension in this stage, ma'am?
Yeah, exactly. That I'm going to explain in disability, but good you asked that. Because the GCS is low, obviously we know that GCS below 8 is a severe traumatic brain injury. You should safely tell, because the patient belongs to this particular age group and there is a suspected traumatic brain injury in this patient. Of course, I want to do the hemorrhage control also. I would safely maintain the target according to the ATLS age group related BP, and that is what you should tell, because you are directing the patient to the definitive hemorrhage control also. You are not missing anything here. So when you're when you're sure that you're going to direct it to the definitive control, anticipating a traumatic brain injury, it is safer to tell that ideally a permissive hypotension to be maintained, but because I'm anticipating a traumatic brain injury, I would keep a particular target for the a traumatic brain injury also. That is what I'm going to discuss in disability. Good that you asked. Good. Yeah. So what should be my disability management? Yeah, of course, the GCS is low. I know the patient could have a traumatic brain injury, or it could be just purely related to perfusion status only. So he could have a traumatic brain injury. So as I discussed in the first table, like what are we going to look in disability? We are anticipating a brain injury. You are anticipating a spine injury, where it could cause hypotension, complications, patient could become brain death if you don't intervene. So there are many things which you have to look at. But when the patient is having such a hemodynamic instability, you cannot shift for CT. Your goal is hemorrhage control. You put a pelvic binder, you're referring the patient to Ribova, you know that the GCS is low, but unless the physiology is restored, you cannot do anything about the brain now. So all you can do is prevent the secondary injury. Okay. You should tell that because the patient is hemodynamically unstable, I would first concentrate on hemorrhage control, But I would prevent any secondary brain injury because I'm anticipating the patient could have a severe traumatic brain injury. Unless I get a CT scan, I won't know it, right? So you have to tell it in a way that I would prevent secondary injury by preventing hypoxia, hypercapnia, by preventing hypotension. So he belongs to the age group of like 36 years, right? So I would maintain, according to his age related, I would safely maintain the SBP to 110 millimeter mercury because I'm already referring the patient for a definitive hemorrhage control. And at the same time, I would already I have secured my cervical collar in the airway part. So I would keep the cervical spine in stabilization with the cervical collar and manage the airway. Then later, once the patient is stabilized, I would go on for the adjuncts of the primary survey, let it be imaging, let it be CT, whatsoever, and then plan on the treatment accordingly. That is how you have to answer the question. I hope you understood. Okay. And there is a small update with respect to disability with 11th edition. They are mentioning a term called critical neuroworsening. When a patient is having a sudden drop in GCS, pupillary changes, and new focal deficits, which could indicate a traumatic brain injury. Just remember the term. You know, these are the signs of any neurologically deteriorating patient. Just they have mentioned a new term called critical neuroworsening rather than telling patient is having drop in GCS. So just remember the term. Otherwise, there is no major update in the disability part. Okay. Coming on to exposure. So in the case itself, we saw the patient was hypothermic, right? So exposure principles mainly on you. The main principle of exposure, why we are doing exposure, as we saw in the table, we should not miss any other injury. You are going to do log roll, retroperitoneal hemorrhage, or some spine fracture or something. You are not missing anything on the major injury which has been hidden in the back, or you are exposing the entire body and seeing anything else is missed or not. And number two, you are going to maintain the temperature of the patient, because we know that hypothermia is not good in trauma. It could cause all the coagulation factors malfunction, where the patient could persistently have bleeding associated with hemorrhagic shock, and acidosis could worsen the bleeding. So the environmental control mainly concentrates on recognizing any missed injury, and you're maintaining a temperature, and you are just making sure that you have not missed. That's all is exposure and environmental control. In this case, the patient was hypothermic. So you can tell simultaneously, I would start a warmer. It could be a forced air warmer, or I would use blankets, or I would give warm saline. All of that you can tell for temperature control. Okay. So now we have completed the X, A, B, C, D, E. If there are any doubts, please ask. I hope I explained how to answer rather than putting a point, how to answer sequentially when you are given a ATLS case. I hope you understood that. Is there anything else I want to clear up so that we can go on to the next? Okay. If nothing is there, we'll just briefly see the adjuncts to the primary survey. It is not that you should finish the primary survey and do the adjuncts. It should happen simultaneously. Please remember that. And if suppose the patient is not responding physiologically, then you should keep re-evaluating, redoing whatever you know, so that you don't miss anything. Okay. So what are the main adjuncts to the primary survey as per the ATLS? The main monitor findings like saturation, respiratory rate, vitals, ABG, and serial physical examination, and fast. That is the most common thing we do, e-fast and fast. DPL, I'm not sure on how many centers we do, but yeah, please mention that. And you see the exposure, see the log roll, see whether you have missed anything or not, see whether the cervical sign is secured. Just keep re-evaluating the patient. And yeah, imaging comes here, chest x-rays and pelvic x-rays. If it is on the bedside, I don't think it should be a problem. And all the catheters like urinary catheter, gastric catheters, and you keep monitoring the patient. So this should be your adjuncts to the primary survey. You have to keep re-evaluating the patient. Whatever modality you have to keep re-evaluating. And if the patient is not responding, you have to find out the source. That should be your primary goal, to restore the physiology and to prevent the secondary brain injury and keep the patient physiologically stable. That should be your goal. Okay. So in this patient, because the like let us take that E-fast was positive and he is having pelvic hemorrhage also, and the patient is not responding to whatever we gave, let it be fluids, let it be blood, tranexamic acid, and you have put a pelvic binder and you have called the interventional for angio, but it is not been done yet, but the patient is still not responding to, then you have to immediately call in the surgeon, take up for laparotomy, do a damage control surgery, just control the bleeding, control the physiology. That's all you got to do. There is no need of anatomical beauty here. Just you control the bleeding, make sure the patient is physiologically restored, and then you start with your next examination, whatsoever you missed. Now you want to do a CT scan brain, CT scan spine, you do it, because the patient is at least stabilized now. He is physiologically stable and fixed. If you have a window to do it now, you do it. So that is how the management went in for this patient. Okay. I hope the initial part is done. If you could come till there by answering all the answers, then I think you have successfully cleared your OSCE station. Yeah, now comes the important part where secondary survey. Once you completely feel that you have finished your primary survey and you have stabilized the physiology, the patient has been properly intervened, then you have to start with your secondary survey, where you must ask for the ample history, which includes allergies, medications, past medical history, last meal taken or last menstrual period, events related to the injury, and complete head-to-toe examination. What all you could have missed in the primary non-life-threatening things, you should reevaluate and check, and you should proceed with the definitive management for those. Okay, this completes how you have to approach an ATLS case scenario, starting from this is how I systematically go. This is how I start with XABCDE. And I found a visible bleeding. I controlled it with a tourniquet or compression or whatsoever. Then I moved on to the airway because I know it is a threat. I secured the airway with manual inline stabilization. And then there is a tension pneumothorax. I managed it simultaneously. I also used E-fast as an integral part. And then I came on to circulation. I did fluids, blood products, tranexamic acid. I gave referrals to particular department and I was simultaneously managing. And coming on to disability, I was making sure that the patient is not suffering from any secondary brain injury because of this particular hemodynamic impact. And then coming on to exposure, I maintained the temperature. And then I did all the adjuncts of the primary survey simultaneously. And once the patient is shifted to OT and damage control surgery has been done, physiologically patient is restored, I went on to the secondary survey. That is how you have to finish your answer. Okay, don't miss any important points in the airway. Always mention I would anticipate a difficult airway, I would anticipate a traumatic brain injury. Always make sure you're anticipating, because ATLS is not like like a questionnaire or a tick box. It is always your anticipation. Yeah, patient could have also this, so I'm going to manage this simultaneously. That is how your thinking also should be, and that is how your answering should also be. Okay, so there is one small update with respect to traumatic brain injury as per 11th edition. You have to manage the increase in the intracranial pressure in a stepwise manner, where you have to intubate and do controlled ventilation so that you don't do any secondary brain injury for the patient. Head end should be elevated with a proper sedation so that you are not triggering any sympathetic reflexes where patient is bucking the tube, biting the tube, and struggling, causing secondary brain injury. And you can give a transient hyperventilation, but that is not the definitive way. And hypermolar therapy, hyperosmolar therapy should be your definitive management for the ICP. Okay, this is a stepwise approach which has been specifically given, and they have even given a table comparing the mannitol and the 3% saline. There is no major difference. 3% is preferred over mannitol as per studies. There is no such thing, but of course 3% NaCl can get down the cerebral perfusion pressure more efficiently than the mannitol because of few reasons. That's all. That table I want you to go through. And then comes what are the indications for like surgical intervention in a traumatic brain injury as well as spinal injury. Spinal decompression should be as early as 8 to 24 hours. And when it comes to traumatic brain injury, if the bleed is hematoma is more than 25 ml, if the patient is having any posterior fossa bleed, or if the SDH is more than 10 mm thickness or with more than 5 mm midline shift, or if the EDH is volume based, like more than 25 ml or more than 15 mm thickness, or with a more than 5 mm midline shift, or if there is any clinical deterioration, and contusions measuring more than 50 centimeter cube with a clinical deterioration, and any hemorrhage more than 3 centimeter with a mass effect and a midline shift. These are some of the indications which 11th edition mentions to be the criteria for the surgical intervention. Okay. So this completes our ATLS. If there is any doubt, you can ask me. So we can quickly finish the radiology, where I'm just going to ask you questions. That's all. Only Soumya, Joshna, Bhavesh has not answered yet. Deepak is messaging, busy messaging. So I mean chatting. So one of you can start answering the radiology. Is it okay? Can we move on?
Ma'am,
Yeah.
ma'am, role of intensivist in managing polytrauma in an ED.
Role of
That was
intensivist.
asked, ma'am.
Okay.
In managing polytrauma in ED.
Okay. So what do you think? What should be the
Only
answer?
ATLS based.
Yes, there is no difference. Ideally, there is no difference with what we discussed. Okay. So,
Okay, ma'am.
as an intensivist, also, like I'm working in a hospital, it is a tertiary trauma center where I'm working in a hospital where there are ER specialists. But whenever a trauma code, we have a trauma code, whenever a trauma code has been announced, we do go to the ER and we do start the trauma assessment along with the ED physician as a team. Okay, that is the importance of ATLS team communication, also team members also. So whatever you have to do, actually all of this is meant for ED only. We actually receive after like registration. Yeah. So you should be like, if we receive a trauma code, if your hospital has a trauma code, then you should tell, as once a trauma code is received, as a part of the team member, along with a thoracic trauma surgeon, GA surgeon, I would be a team member. If anesthetist is there, I would be the team member. If anesthetist is not there, I would be the airway. Initially, I would do the airway. Start with team assessment. That is what you should tell. There is no difference in the answer at all. Okay, with respect to the question. Okay.
Okay, thank you, ma'am.
Yeah. So additionally in the chat box, no, Deepak stopped messaging now only. Okay, fine. We'll go to the radiology. Sorry, 1 minute. Just it is taking some time. Okay. Yeah. Don't worry, it's 54 slides, but I made it as simple as possible. We'll quickly go through. Okay. I have not put in how to manage things and all. I'm just going to ask question and you can just tell the single line answers, like how will you manage, so that we can finish the radiology. Just see the images, see whether you are able to identify it or not. Okay. So we'll be discussing about radiology. Mainly, we'll be discussing about the CT, MRI, important ICU related images, and a few of the chest X-rays and abdominal X-rays. That's all. Okay. And I'm 100% sure you will be able to answer most of it. So let us start with CT brain. Yeah, like since my critical care exam, I'm following this only, like from Radiopedia, it is there, how to interpret a CT scan of the brain, where we use a mnemonic called blood can be very bad, where blood indicates you have to look for any major hemorrhage is there. Second, you have to look for the cisterns to look for any bleeding is there, or if the cisterns are compressed because of any increased intracranial pressure. Then you are looking at the parenchyma, where again you are looking at the gray white differentiation, any mass lesions are there, any midline shifts are there, any herniation, infarction is there. And then you are going to look at the ventricles next to see the size and the symmetry. If there is a hydrocephalus, any urgent EVD is required. If there is an intraventricular hemorrhage, then any urgent EVD is required. So next you're going to go to ventricles, and finally you're going to look at the bone. If it is a trauma patient, obviously any skull fractures are there. If it is non-traumatic patient, just you're going to tell the bones are looking normal. That's all. Okay. So this is a mnemonic which we can use not to miss out the particular regions of the brain as well as the skull when you're interpreting a CT scan. And when you're answering, you can just tell whether it's a contrast CT or not. and what location of the head CT, chest CT, abdominal CT, and what are you looking at? An hyperdense lesion, maybe approximately measuring so and so. I'm thinking it could be a intracranial hemorrhage. So you start with the location, whether it's a contrast or a non-contrast study, CT or an MRA, and then you tell the diagnosis, and they would ask you how would you manage the patient. Just briefly finish the discussion. Okay. OSCE's, this radiology OSCE, when we had, it was hardly like 5 minutes, because there are many students, they usually rush. You have to just utter the exact management. Yeah, I would do urgent decompressive craniectomy for this patient. That's all. Like BP control surgery. That's all. You should finish like that and move on. Okay. So let us see the brain picture. So CT brain. Obviously, you all know. So can one of you tell me what are we looking at?
The first image is plain CT brain image, axial cut, which is showing.
Okay, you can just tell the diagnosis. Sorry, don't mistake me because of the time constraints. We can just tell the diagnosis. Yeah.
Intraparenchymal bleeding with the surrounding
Very good.
midline shift and effacement of the ipsilateral ventricle, and contralateral there is some dilatation of the lateral ventricle.
Very good, very good. So the second image, why it is more important, and what is the location of the bleed? That is why. So second image is?
It is located in the posterior fossa.
Exactly. Very good.
Cerebellum looks like cerebellum, right cerebellar bleed with
Okay.
the edema. The basal systems are completely compressed.
Very good, very good. The third image, still more important.
Thalamic.
This is a coronal image, a CT brain plane, and in the posterior fossa bleeding, which is in the pons and the
brainstem. Exactly. Because from there the question could go to the patient is having brainstem bleed. Now his GCS is 3. There is no response. So what I have to do next? Maybe the questions can go like that. So just when you are when you are seeing an intracranial bleed, just make sure. As she rightly said, if it is a posterior fossa, you should be more cautious because the space for the bleed to expand is very less. So I would immediately call for a neurosurgery. Even if the patient GCS is good, I would involve the neurosurgical team and keep it ready for SOS surgical intervention. And when it comes to brainstem, you should tell that I would prognosticate the family that the patient could become, because again, it's a posterior and brainstem. So I would prognosticate the patient. Good. So all your answers are right. So the management of ICH is only 2 lines. Of course, airway breathing circulation is one thing, but definitively BP management, neurosurgical intervention, SOS. That's all. Okay, good. Now, what are you seeing in the image?
Intraventricular bleed in the bilateral lateral ventricles.
Very good. Yeah.
So in the third ventricle, as we could see in the second image, and there is contralateral lateral ventricle hydrocephalus there on the third image.
Very good. So now if suppose with this finding, the patient's GCS was 14 and suddenly dropped to 8, you could not find anything else apart from the intraventricular hemorrhage, then ideally your treatment must be controlling the BP as well as urgent EVD. That's what you should tell, because that is one of the measures to reduce the intracranial pressure. So the treatment, definitive management would be EVD. That's all. Good. So now coming on to the trauma series. Of course, I had already put, I'm sorry, I wanted to keep it one by one, but I forgot to make it. So this is a brain image showing subdural hemorrhage. The main diagnostic point is crescent-shaped extraaxial bleed, and the main management point would be of course, we had already discussed now in the traumatic brain injury series, the ATLS is suggesting few measurements when you have to take the patient for OT. At the same time, when the patient is having sudden clinical deterioration, then you have to take the patient for OT. So when it comes to SDH, you have to surgically evacuate the SDH if the thickness is more than 10 mm or a midline shift of more than 5 mm, or suddenly the patient GCS is dropping from the baseline. Okay. This is with respect to SDH. This is an image showing
EDH. Right, EDH with the midline.
Yeah, and the shape is
egg shape.
Crescentric. Sorry, biconvex shape. Very good. So the management is the same. Here in the EDH, there could be a notorious picture where the patient could be normal and suddenly he could deteriorate. Based on the measurement, you have to, size of the bleed, you have to take a neurosurgery consult and take it for surgery. Okay. So this is a table comparing the SDH and EDH. for surgical intervention volume, where EDH is mainly based on the volume 30 ml, or it could be based on thickness of 15 mm, but SDH is mainly based on thickness, like more than 10 mm. And if there is any clinical deterioration in both the scenario, you have to subject the patient for surgery. Done. Now coming on to next image. Yeah.
This is quadrigeminal SH.
Very good.
First image is showing quadrigeminal SH.
Very good. So how are you going to differentiate from a normal CT? Usually the CSF spaces will be black, but when there is a hyperdense area, then you call it as an SAH. And in the next slide, I have just put in the common regions for SAH, where it could be supracellular, where it could be interpeduncular, where it could be ambient cistern, where it could be quadrigeminal cistern. These are the common areas for SAH. And how are you going to manage SAH? Just give me 2 definitive points.
BP management, then
Very good.
nimodipine.
Very good. Very good. Just put a word that I would evaluate for whether it's a aneurysmal or just a traumatic SAH. If it is aneurysmal, what are you going to do?
Neurosurgical intervention.
So
for
endovascular coiling or clipping.
Very good. Coiling or clipping. That's all. Very good. Good job. Just a few things when it comes to SH. It was extensively covered in our theory lecture, like which is better, coiling, clipping. Just see to those named trials and just make sure you know it. Please do mention coiling, clipping, and always tell I would rule out aneurysmal. Make sure you are telling that. Now coming on to hypoxic ischemic injury. Again, this could be one of the important imaging, because even with cardiac arrest, even with management, neuroprognostication, post cardiac arrest care, the patient will the patient could end up here, and from here, how are you going to take the patient? Like, let it be neuroprognostication, post cardiac arrest care. What are you going to do if the patient is hopeless? In that way, you should know this imaging. So this is imaging showing hypoxic ischemic encephalopathy, where you can see the sulci gyrae, and the differentiation is nicely maintained. But if you see here, the gray white matter differentiation is fully gone with respect to this image, HIE. So this is an MRI imaging. You can see that in diffusion restriction, you can't see this hyperintense things, but it is severely diffusion restricted. And this is what we were discussing in the neuroprognostication also. Like when you do an MRI between 2 to 7 days, you can see there is a diffusion restriction which can be picked up in the same time, this is a normal flare, where you can also see in a severe hypoxic ischemic brain injury, the flare is picked up, like it is more hyperintense. And ADC will be even lower, like it will become more duller. If you see the apparent diffusion coefficient, it will be more dull compared to a hypodense compared to a normal ADC. These are the findings you should know. Where how will you manage this hypoxic ischemic injury? Now patient GCS is 3, you are doing an imaging, but okay, we'll keep it as patient GCS is 7, and your patient is tracheostomized, your patient is having hypoxic ischemic injury. So what are you going to do in the ICU? Hi, how are you going to manage?
Hyperosmolar therapy.
Okay.
Neuroprognostication.
Okay, so the answer could be like, you will be preventing any further injury to the brain, right? So see, one thing is that in neuro questions, always remember the primary injury, you cannot do anything about it unless it's a bleed, or even if it's a stroke, only within window you can do something about it. Even then you are saving only the penumbra, but not the region where the brain is damaged. Always say the word that I'm going to prevent secondary injury. I will protect the brain, like as she said, ICP, temperature, hypoxia, hypercapnia, electrolyte balance, all those you will manage. If it is suppose immediate post cardiac arrest patient, then I would do a temperature management for such patients. That's all. Okay. Yes. Okay. This is again a very important scenario. Can one of you tell me what are we seeing?
A is loss of
MPA
cortical.
ensign and C.
Very good. This is MCA ensign. Absolutely. What are these minutes? Sorry, one.
A is loss of cortical insular ribbon sign.
Very good. An obscured gray white matter, gray white differentiation is lost here. And of course, MCA hyperdense sign. Very good. Very good. So, so the questions from acute ischemic stroke could be vast and vast. Please go through the theory. First question would be BP management. Second question would be when would you thrombolize and what are the trials related to it. Third will be when will you do a thrombectomy and what are the trials related to it. And next is what are you going to do next? I will prevent the secondary brain injury. So this you must know. Please make sure you are thorough with the trials. We had already shared 2 PDFs regarding the trials in the thrombectomy, thrombolysis, and stroke-related trials. Even in the class, theory class, it is extensively covered. Please make sure you're going through that. Okay. So what is this?
The A image is DW imaging of the brain, which is showing a left side parietal region acute infarct.
Very good.
The left side is ADC.
Very good.
Low ADC.
Very good, very good, very good. So this is just a table about the MRA findings. So what are we finding in the diffusion weighted sequence? It can pick up the cytotoxic edema within minutes after stroke, and that is why we are doing diffusion as a primary modality when we are activating a stroke protocol and when we are thinking of thrombolysis. Of course, non-contrast CT is the one, but in our hospital there is a stroke code, like where we immediately do once we rule out hemorrhage, we immediately do diffusion sequence and thrombolyze. But you go as per the guidelines. I'm just telling the diffusion weighted sequence will pick up cytotoxic edema as early as possible, and that is the most preferred sequence in the earlier strokes. And ADC, again, it is there could be an instant change, but it pseudo-normalizes by 3 to 5 days. And flare. In the flare sequence, the changes will start to pick up only after 3 to 6 hours. It's mainly because of the vasogenic edema. If suppose the patient is having positive diffusion but no flare signal, then that means there is a mismatch where we still have an hope for saving the penumbra, and probably the stroke could be less than 4.5 hours. Okay, but if the patient is having diffusion positive as well as flare positive sequence, then that means we are out of the thrombolysis window. Maybe for thrombectomy window he could be fit enough, but still we'll have to see based on the angio and the imaging. Same, whatever we were discussing. See, the diffusion is picking up, but in the flare, there is no pickup. So that means it is a mismatch where it could be a earlier stroke. There is a hope for thrombolysis and saving penumbra. But when there is a no mismatch, then that means it's an established stroke. Then we'll have to think of thrombectomy, or if thrombectomy is also not possible out of window, then we'll have to conservatively manage the patient. Okay. Then this is another important chart where malignant MCA infarct, because a lot of trials are related to the decompressive surgery. So you should know it. So when do you call an acute ischemic stroke as a malignant infarct? When the MCA territory is involved more than 50% on the CT, and there is a perfusion deficit more than 66% on the CT, and the infarct volume is more than 82 ml within 6 hours on MRI, or if the infarct volume more than 145 ml within 14 hours on the MRI. If you could remember 1 or 2, more than enough, because the auscultation is fast. So if you could utter 2 lines, that is more than enough. Okay, why it is so important and how are we going to manage? Because we should prepare the patient for emergency surgery as a part of of course, the primary damage has happened. So at least you should prevent the raised ICP secondary damage to the brain. So you should start like airway breathing circulation. I would prevent the secondary brain injury. I'd immediately call in the neurosurgeon and plan for the surgical intervention. So this is a table showing the important trials related to decompressive craniectomy in a MCA infarct. Again, in the theory class, it has been extensively discussed. I just put it here. Decimal trial, Destiny 1 trial, Hamlet trial, Headfest trial, and Destiny 2 trials. Please read through the trials. It's very important. They would definitely ask this question. Okay. Yeah. Next, going on to the herniation. So what are the types of herniation you know of? It's either an uncal or a central or a subfalcine or a tonsillar, as seen in this image. And you can see there is an uncal, there is a tonsillar, there is a subfalcine herniation. So when such an image is shown and they ask you how would you manage such patient, you should tell, I would see what is the primary cause causing the herniation. I would treat as per airway breathing circulation, and if it is a big bleed, I would go for urgent surgical intervention and prevent the secondary brain injury. That should be your answer. But picking up the question is important. Even if it is an intracranial bleed, if the herniation is in one pattern, you should tell it is an intracranial bleed with a subfalcine herniation. It is an intracranial bleed with an uncal herniation. In that way, if you answer, they would know that you know the concepts also. Okay. Yeah. Coming on to a traumatic brain injury patient. So what can you see in the CT?
Basifrontal contusions.
Very good. Very good.
And there are also like on the left AB image, it is left frontal depressed bone fracture.
Very good, very good. So, so same, the management would be urgent surgical intervention for the depressed skull fracture, and for the contusion, as we already discussed, if it is above a particular volume and there is deterioration of the clinical symptoms, then you would definitely take them up for surgery. Or else it is a conservative management, because it's a frontal region. You can give a seizure prophylaxis for 7 days, and then you can prevent the secondary brain injury. If a patient clinically deteriorates, I would immediately shift him for the OT as per the neurosurgery consult. That is how your answer should be. Okay. So what is this image showing? CT as well as this thing imaging.
On the cortical subcortical level, there are multiple punctate hyperdense lesions, and
Very
also
good.
the basic ganglia, there are some lesions which is suggestive of diffuse axonal injury if it is at the cortical subcortical level.
Yeah, very good, very good. So how are we going to manage this patient?
Airway breathing circulation.
Yes.
BP control for the TBI, if it's related to TBI, then BP control, then euthermia, eucarbia. Along with that,
prevention of secondary brain injury. Very good, very good. Because the prognosis is bad with such patients, so we cannot do much about it except for a supportive ICU care. So if you know that, that's well and good. Good. So what are we seeing? Of course, it's mentioned, it's a hydrocephalus. So if this hydrocephalus, it could be just normal in older people who comes to ICU without any significant clinical symptom, which could be an incidental finding when we do an CT. That is not important. But when the hydrocephalus, for example, you are having a meningitis patient, I have seen many meningitis patient in my center where they, because of the Neisseria meningitis, because of the streptococcal meningitis, they do get hydrocephalus within 24 hours, within this thing, they get hydrocephalus because of an SAH there could be. So in such emergency situations, of course, EVD is the immediate treatment. Based on the etiology, you should tell definitive management of the etiology and management of the hydrocephalus by drainage. Okay. So this is a CT image showing an empyema. If it is really causing a massific midline shift and a clinical deterioration, then urgent surgical intervention is the treatment of clinic. Mostly empyema, I don't think they would ask, but maybe as a part of case presentation, if a septic patient is there and he had a headache, maybe they can show a CT picture and do that. Then comes to CVT. So this is a CT image showing a filling defect in the left transverse and sigmoid sinuses. And this is one of the important sign called hyperdense triangle sign. Normally, it would be more hyperdense, but if there is a filling defect in a venogram, then it is CVT. This is with respect to CT I'm talking about. And if there is a dense clot sitting there because of the thrombosis, then that could also be one of the signs for CVT. When it comes to an MRI, absence of normal flow void on the MRI. For example, in general, there will be a normal flow void. You will see it as a hypodense area only. But if there is an hyperdense clot which you are seeing, then that could be an indicator of CVT. And this delta sign, triangle sign could all be asked during the OSCE image. The main management of CVT is
anticoagulation and therapeutic anticoagulation along with the anti-edema measures.
Very good, very good.
And the hydration.
Yes, very good. And yeah, of course, very good. So this is again another important question, because it could be related to pregnancy-induced hypertension scenarios, where you could have a case scenario or a long or short case with a pregnant patient who has such an MRI finding, where it is showing diffuse cerebral edema and increased pickup in the MRI, mainly due to hypertension changes. If you believe press is the reason for such a diffuse edema and hypertension and clinical deterioration, BP control and along with supportive airway breathing circulation is the definitive management for PRES. Okay, less likely to ask, but a possibility if you have a case study related to pregnancy. Okay, yeah. Next, let us move on to cervical spine. As I picked up some from the websites, like how to interpret as an approach to a cervical spine. You should always see the alignment of the cervical spine, where you should know if it is an X-ray, you should see which view it is, and you should know the lines, which I'll show you in the next picture, where these lines are aligned to rule out any displacement is there or compression is there with respect to cervical spine. And bones, you should measure each vertebra, whether it is fully squared like, or there is a compression or any irregularities are there, fractures are there, and how is the density of the bone. Also you should look for, that is the AB approach. And coming on to C, that is cartilage, you assess the intervertebral disc height and any narrowing is there, how is the uniformity and surrounding soft tissue. So ABCS approach is one of the cervical spine approach, but when it comes to trauma, mainly you have to look for which view, whether the lines are aligned and the bones are okay. And that is very important. Okay. So this is a radiograph showing the cervical spines, and these are the lines I was talking to you about. This is an anterior vertebral line, posterior vertebral line, and this is the spinolaminar line and posterior spinous line. You should know the lines are aligned, and you should look at the every individual body of the vertebra and the processes. Look for any fractures. Okay. So this is a CT scan showing Jefferson's fracture, which is the C1 fracture, and hangman fracture, mostly seen in hanging. And there is also an odontoid fracture, which is an unstable C2 fracture. Here I have mentioned only the unstable C-spine fractures. If it is shown, the intervention should be operative, or the patient would already be in, like what to say, in an unstable state. So urgent surgical intervention is needed for these fractures. Okay. So let us go on to the chest imaging. So this is with respect to trauma. You can remember a mnemonic to not to miss any major thoracic injury in trauma, that is called ABCDFGHI, where aortic injuries, bronchial injuries, spinal cord injuries, diaphragmatic injuries, esophageal injuries, flail chest, and any air anywhere in the pneumothorax, let it be pneumoperitoneum, any cardiac injury or any iatrogenic injury because of lines or ICDs or anything should not be missed when you are imaging for a trauma patient. Just remember this mnemonic when you are reviewing an OSCE station in a trauma patient, just not to miss out any major injuries. Okay. Coming on to chest X-ray, I hope you know what are the normal findings in a chest X-ray. Trachea, lung zone, right and left, and there is a SVC, right main bronchus, left main bronchus. There is a aortic arch, an aortopulmonary window, pulmonary artery, and the cardiac shadow and the gastric shadow, and diaphragms. So when you're looking at the ABCD, there is an ABCD approach for this also. I believe that you people know this because from MD time onwards, we are reading this. So that is the reason I just put a normal chest X-ray. Can anyone tell me what are the findings you are seeing in the chest X-ray? And what could be the corresponding CT findings in such a patient?
Bilateral non-homogeneous opacity.
Okay, very good. So what are the differentials? Of course, one I have put ARDS. What could be the other differentials? Very good, very good. So please make sure that you know some of the differentials, because it won't be a single answer. So what is the corresponding CT finding? If suppose it is an ARDS, what are we looking at CT findings?
Ground glass opacity.
Ground glassing, peripheral ground glassing.
Okay, so maybe with respect to ARDS, you can tell that if it is an early ARDS, okay, if it is early to moderate ARDS, then there could be ground glass opacities with consolidations. But if it is a fibrotic ARDS, I would find more of a fibrotic picture, like with reticulation, bronchiectasis, and volume loss. Okay, that would be a smart answer. So this is a CT image showing ground glass opacity is non-homogeneous, and in the later stages you can have fibrotic changes also. Very good. Done. This is chest X-ray showing a lobar pneumonia, and CT showing the lobar pneumonia. The questions from here will be typical atypical pneumonias. How would you manage on an, I mean, if it is a non-severe pneumonia, how will you manage? If it is a severe cap, how will you manage? And steroid indications in pneumonia. This would be the common answers. And if it jumps to the ventilator scenario, then it can go on from ventilator associated pneumonia. What will be the finding? What are the criteria? So make sure when it comes to pneumonia, you are covering the cap and VAP. Okay. Yes. So what is this?
Filling defect in right main pulmonary artery.
Very good, very good. So how are we going to manage this patient? Now I'll give you a scenario. The patient came to us. He's hypotensive. He's hypoxic. And this is the scenario. And when I do the echo, there is gross RA-RV dilatation. So what are we doing here?
The high risk PE, we have to
Very good.
we do their thrombolysis.
Very good. Very good. So now another patient is coming. Patient is not hypotensive. He's slightly hypoxic. But when I do the echo, there is some RV strain. But tropi is negative. Tropi is not too high. So which risk category he belong to? What are my treatment options?
The intermediate risk PE.
Very good.
So IV heparin, unfractioned heparin, high APTT protocol can be followed.
Okay, so can I keep this patient for thrombolysis? Are there any studies related to that?
PETO trial, ma'am.
Yeah, there are multiple studies. During the theory class, it was covered as a table. So please make sure, because this will be the question, because everyone knows, we know massive PE, we will thrombolyze and start anticoagulation. That everyone knows. And we will look for any risk factors later, like DVT or any other thrombus or thrombotic workup. That is correct. But when it comes to an intermediate high risk, intermediate low risk PE, how are you going to manage? And what are the supportive trials? Like the trials will be your Viva question. If it is like a very senior most consultant who's sitting for the Viva. For me, they were asking for CRRT trials, ARDS trials, and pulmonary embolism trials. So make sure if it is an intermediate PE with a clinical scenario, make sure you know the trials for intermediate PE. Okay, don't forget that. And these are some of the X-ray signs where because of the pulmonary infarction, there could be an Hampton hump. Because of the pulmonary embolism, enlarged right pulmonary artery, there could be a Palla sign, or there could be an elevated hemidiaphragm with oligemia, which is called Westermarck sign. These are some of the X-ray signs which we can see in PE. Okay. This could be some of the trauma series where this is a sign called continuous diaphragm sign, which could be an indicator of pneumomediastinum, especially when a patient is presenting with any anterior thoracic injuries, you should look for, or any visceral perforation, tracheal perforation, you should look for. And this is an image showing pneumothorax and pneumothorax. Yeah. And is there a hemothorax on the first X-ray? Okay, I know you're all sleepy. Yeah, because there is a in the left lower zone, there is an opacity which is hyperdense. Yeah, definitely there is a hemothorax. Could be an hemothorax. And this is an X-ray showing a whiteout lung where there could be lung collapse. So urgent bronchoscopy and recruitment would be the treatment for it. And this is X-ray showing what? What is this X-ray showing? Come on, few.
Section widening of mediastinum.
Hey, you keep it as a common term, like widened mediastinum. Okay, so what are the differential diagnoses for widened mediastinum?
Injury to great vessels like aorta.
Very good.
Mediastinal mass.
Very good, very good. Can pericardial effusion, massive pericardial effusion could be like this?
Yes, ma'am.
Yeah, and some of the hollow viscous, esophageal injury could also have widened mediastinum. Okay, yeah, very good. Just know the differential diagnosis. Okay, so what are the signs we are seeing in the CT? Of course, I have put the diagnosis. So what are the signs we are seeing in the CT scan?
Accordion sign.
So yeah, I don't know what is that. Sorry, can you explain like what is that sign about? Okay, so the first picture is showing us the portal venous gas, and the second picture is showing us what? The B is what? This is very easy. What are you seeing? Like these are bowel loops. These are
Pneumatosis intestinalis.
Very good, very good. So, which could indicate mesenteric ischemia, where the pain will be out of the proportion. The patient can have high lactates and hemodynamic instability, and the urgent intervention would be surgical intervention after hemodynamic stabilization. Okay, so this is these are some important signs related to mesenteric ischemia. And very important topic with respect to abdomen is pancreatitis. Please see through the images in all stages, like acute, moderate, mild, and severe. And there is a score, right? So please read through it. And management of pancreatitis will always be accompanied with the image question. So fluid resuscitation, what are the recent trials, pain management, and when do you do surgery, and when do you do imaging? All of these are the common scenarios which would be asked during a viva, which is being covered in the theory question. So please make sure, I'm just telling you the anticipated question, these questions will be asked. Okay, so this is a image, a CT image showing an acute interstitial edematous pancreatitis, but there is no collection yet. So we can call it as an interstitial pancreatitis, maybe in the early stages. So what is the CT index we are going to look at?
Balthasar CD severity index.
Yes, modified Balthasar index, which was found in 2004. The Balthasar index consists of two things. One is the pancreatic appearance, like whether it's a normal pancreas or enlarged pancreas with inflammatory changes, or there is a single collection or a multiple collection. Along with that, you're going to look at the necrosis, where if there is no necrosis, it's 0 point. If there is less than 30% of necrosis, mild, which you're going to give 2 point. And if it is 30 to 50% necrosis, it's moderate, where you're going to give 4 score. And if it is severe necrosis, then you're going to give 6 score. So the maximum is 10. And based on the severity, you can manage the patient. But whatsoever, there is no immediate surgical intervention. You got to wait for 3-4 weeks. But if something you can do after 2 weeks, then it depends on the patient situation. The patient deteriorates, or there is worsening necrosis, or you did a pigtail, you took a fluid and there is a positive growth and collection is increasing. So based on that clinical picture, you can treat the patient. So this is an image showing severe acute pancreatitis, where the structure is only gone, like there is full structure gone and the pancreas is not visible only. So it is a kind of a severe pancreatitis. And this is a pancreatitis image after 4 weeks, where there is a necrosis is walled off and it has become a walled off necrosis. Okay, where maybe a good window for a necrosectomy or a surgical intervention. Okay. Okay, few more. So what is the first picture? Chest X-ray shows
multiple air fluid level,
yeah,
large intestine involvement, the coffee
so
being
bowel up.
kept
Yeah, so it is a diagnostic of, it is diagnostic of
toxic colon.
bowel
colonic
obstruction. Yeah, bowel obstruction. So conservative or surgical, it depends on the patient clinical scenario. Mostly they do conservative, but if there is ischemia or the imaging showing any bowel ischemia, then immediately you have to take up for the surgery. So what is the second image? Of course, there are signs which are running in the screen. Like what is that image, and why it is important with respect to ICU?
Toxic megacolon.
Very good, very good. So, which is the commonest ICU condition which could get complicated as toxic megacolon, as an infective complication?
C. difficile infection.
Very good, very good. So the question could go from there, because in general, toxic megacolon we don't see, right? Like if it is a presentation, then immediately patient would be in the surgery. But with respect to ICU, from there the C. diff questions will be asked, and whether it's Vanco or what is that, F drug, fidaxomicin, whatever, like metronidazole, whatever. So oral or IV, rectal, all those questions would be asked. So you should know about C. diff and the signs of toxic megacolon, and clinically how are you going to detect when a patient goes down. Okay, this is one important picture. And yeah, this picture, what does it show? It's an abdominal X-ray showing what? This is also a common ICU scenario, so it is not too critical, but yeah.
Yes.
Yeah, paralytic ileus. So you should know the differential diagnosis of, differential causes for the paralytic ileus. Let it be hypokalemia, pseudo obstruction. So how are you going to treat like Ryle's tube, neostigmin, enemas, surgical opinion? So this should be our answer. And what does this image show?
Air and the diaphragm follow viscous
Exactly.
injury.
Yeah, so you should know the differential diagnosis. Of course, trauma is one thing, but there are some surgical procedures, like if you do a peg or so, the patient can have air under diaphragms. Whether you need to aggressively treat that patient, no. So you should tell, I would wait for the this thing to resolve on its own. So this completes our radiology. I'm so sorry for making it so long, but I wish it is helpful. Any doubts, guys, related to radiology, you can ask me personally also. I'll get back to you. Okay. Thank you, guys. Thank you for listening for so long. Thank you, guys. So tomorrow, all the scheduled classes will be done. Okay. Good night, guys. See you tomorrow.
Good night, ma'am.
Good night, Navneet. Thank you. Joshna, you are there? Okay, if your question is about in a hemorrhagic shock, whether you need to mention about TEG or ROTEM, yes, it is not like a mandatory thing which is mentioned in the any of the guidelines, but you should tell that I would draw simultaneously samples for all of that. I would send a TEG or a ROTEM. There is nothing wrong in mentioning that you are sending a sample for TEG or a ROTEM, if that is your question. That's all, I guess. Ultrasound, this TCD will be covered separately. Ultrasound, they are covering it separately. And okay, I hope I have answered all the questions. Thank you, guys. Good night.